in the early 90s, kind of in response to a rapid onslaught of information coming out of multiple meetings, and a place where clinicians can gather, hear the new information, and then discuss. That's the spirit of this. And historically, we were in Florida, and we had leisure time heavily scheduled in, and then that all became taboo, and you couldn't do that anymore. CME wouldn't let you. So we ended up becoming more of a, I guess I call it a traditional meeting, but it's still a great meeting with outstanding faculty. And while we've lost kind of the spirit of getting out of the Northeast and going to Florida and sitting around and having some leisure time, the content and the spirit of sharing new information and discussing it is still the mantra of the meeting. So thank you for being here. There's a lot of folks who are online. That's kind of one of the silver linings, I guess, of COVID, is that we learned how to have meetings that are more virtual. But I think still being here in person, having the chance to discuss things at meeting room, but also at the breaks and going to the meal sessions, gives us all a chance to interact. And that's also a part of the experience of sharing information and trying to figure out what's what with this new world that we're living in with information. Okay, so I'm Mike Sagg from the University of Alabama at Birmingham, and I'm very pleased to co-chair this meeting with Mark Sokoski from Johns Hopkins just down the road in Baltimore. So as I mentioned, we're in person and we're virtual. The accreditation is from Rush Medical School, and it's the standard ACCME approach, but there's also credits for nursing and pharmacy. The in-person credits will be 12 hours, and for online it'll be 10 because the workshop, the breakouts, we don't have a way to do that for the virtual attendees. And then you see here the designation of Category 1 for physicians, for nurses, 12 contact hours and 10, the same thing. And for pharmacists, again, 12 contact hours and 10. The units are a little different for pharmacists, but it all works out. There will be occasional discussion of, quote, off-label. That means indications that are not FDA approved. And we'll refer to that when it happens, but mostly it'll be on-label activities that we'll be talking about. We have several pharmaceutical companies listed here who have generously supported this meeting, and what that means is that they give an unrestricted educational grant that is basically dollars that are meant to support the meeting, but there's no input at all regarding content or selection of speakers or topics. And so we're very grateful for that opportunity. The brochure you see in front of you, for those of you who are here at the meeting, and it gives information about name badges. You've already gotten those, CME credit evaluations, hotel parking, etc. There is a conference code that we're getting to get on the internet. It's kind of come down. When it does, I'll announce it. Meanwhile, hopefully your phone is have some degree of signal down here, because we need that to do the polling, which I'll go over in a second. But we'll get you that code as soon as it comes down. And then for you guys online, there's a virtual brochure that has the same type of thing. It's a PDF, and hopefully you've received that. And the QR code down there at the bottom, I believe, gets you into the polling. Yep, for the presentations of each slide, it's right there. And then on the virtual conference login screen, click on the agenda topics to view the presentation slides. For help or technical assistance, there's a help button. Just push that, and hopefully it will help. And then you hear John Lennon singing. You know what was unique about that song? I don't know if you ever picked that up, but it's the first song where the actual echo of the lyric preceded the actual lyric. When I was young, I never needed, okay. The conference is both audio and video recorded, and so please hold your questions till the end of the presentations. We will have a QA system. Put your cell phones on stun, for those of you who remember Star Trek. And for post-conference, you will get an email asking you a question or two about what's what you remembered about the meeting, and especially did you change anything in your practice. These are CME things, but they're really important because you can come to a meeting, hear a lot of information, maybe be able to get a question right at the end. But the big purpose of all this is, what did you take away from the meeting that's new to you that changed what you do in practice every day? And knowing that is really kind of the essence of success of a CME meeting. And lastly, Russ is our contact person if you don't receive the email. I can just see it now. I didn't get my email that sort of alerted me to respond to something that I really didn't want to do anyway, something like that. These are the long-term outcomes, changes in what you did and your competence and performance and that type of thing. And you'll have this brief survey that I mentioned. So now the ARS system, we used to have little devices. In the old days, they were wired, so you were tripping over them as you went out to get coffee. And then they had these kind of things, but they tended to walk, and nobody could get them back, and they didn't have any kind of GPS to return. So now everyone has a cell phone, it seems. So you can use your cell phone. For the in-person attendees, scan this QR code, and it'll take you to a website where the questions will appear on your phone, and then you can participate by punching a button for the correct answer, the answer you think is correct, and it'll scan up here, and we can talk about how everyone has responded to the given questions. And for those at home, the polling question is a little easier. It just appears on your video screen. So, how is the weather where you live? Hot, cold, or absolutely perfect? It's hard to imagine in today's world that anything is perfect. I maybe should have something. How's the weather? Totally dystopic. We could say something like that. So A, B, or C, give you all a chance to log on, get oriented. All right, let's see how we do here. So, all right, we got some voters. Great. So, most people are absolutely perfect. That's great. It's like Mary Poppins, practically perfect. Okay, good, that worked. So the other nice thing about having virtual is that it gives us an opportunity to archive. So for those attending the meeting, online or otherwise, you can go back if there's a talk you wanted to see again, or you said, "Damn, what did they say about this?" You can go to the website for Practice Point, and you can actually pull up all the presentations, the slides, etc., and go back to it. But also, if you have colleagues who weren't able to attend the meeting, you could sort of give them this link. They can register, sign in, and they can not only do this, I believe they can get CME as well. So so you get the presentations and possibly CME for them. I'll double check that, but I think that's right. So here we go. As we've traditionally done in the last decade or so at this meeting, we now have 2 days. We used to have 3, but now we have 2 days. First day is HIV focus that I'll chair. The next day is hepatitis and liver disease focus, which Dr. Solkowski chairs. And so here's for today's agenda. Dr. Iran from North Carolina will talk about ARV start switches rescues. Raj Gandhi from Mass General will talk to us about what did I miss. He will play the role of Thomas Jefferson and sing that song when he comes up, he told me. Charlie Flexner is back for the 33rd time every meeting, and he's going to talk to us about long-acting agents. David Spock's here from the University of Washington, and he's going to talk about Jabber the Hutt and when do you jab people and when do you not, and with vaccines. Then we take a little break, and Meredith Clemeth from LSU is here to talk about STIs. old, new, and something in between. Rafi Landovitz is here from UCLA to talk to us about PrEP, and that'll link nicely to long-acting that you would have already heard from Charlie. And then, as usual, while we're having lunch, I'll try to create indigestion by showing a bunch of questions and cases. Then we'll break out into 2 breakout sessions. Based on your response, in the past you said you wanted to go to multiple sessions. You could only go to one at a time. So we have an opportunity to go to the sessions in 2 different time slots. One is at 1:45 for 30 minutes, and then at 2:15 for 30 minutes, and then you break for the day. And then the breakouts will be in upstairs, just 1 flight up, just take the escalator, in State, Treasury, and Commerce, which are, I understand, departments in the U.S. right now, but are on the chopping block, so we probably won't have any of those. So you got to make sure you go to the meeting quickly before it gets eliminated. I don't know where we'll go. We'll sit outside and enjoy the weather.
Hey, everybody. Thanks for being here. It's nice to see people and some old friends and old colleagues. And I just do want to say a minute about everything that people in infectious disease and HIV, many of us, maybe most of us, are going through. I think we need to stick together and support each other. It's really kind of a remarkably stressful time, I think. So I'm going to, these are my disclosures. I'm going to talk about initial therapy, switching with a past history of virologic failure, viremia in people with HIV who have inherited challenges, and rescue with extensive resistance. We'll have some questions. I show this every year. I think these are still our goals. We want to restore health, minimize adverse effects, have therapies that are accessible to all, and Charlie's going to really help with that in a little while, and prevent transmission of HIV to others via any route. And obviously that's challenged now globally. So this is the first question. This is actually, I hope, a polling question. You have a 35-year-old woman newly diagnosed with HIV. She has a relatively high CD4. Her viral load's there. She's hepatitis B immune, and her basic labs are normal. She wants to start therapy. Her BMI is in the obese range. Her A1C is also not normal. It's in the prediabetes range. What would you start? And you can see the choices there. Hopefully everyone knows the abbreviations. There we go. Oh, beautiful. Well, this is exactly how it is in the world. So I don't know. Can we go back to see what it was? But almost everybody picked bictegravir TAF FTC. And if you look at prescribing, just yesterday I looked at our, so 78%, and then 15% or 16% picked dolutegravir lamivudine. And we just looked at our 340B, our pharmacy prescribing yesterday, and it really, the only thing that's really increasing is dolutegravir 3TC, and the vast majority of our prescriptions, even for all patients, are BF TAF or bictegravir TAF FTC. All right, so good. I think that is, what most experts would tell you. These are our guidelines. There's been a couple of changes across the guidelines. One is the DHHS finally caught up with IAS USA and decided that people shouldn't start on abacavir, which we've been saying at IAS USA for some time. And this was a bit of a surprise to me. The following have been removed from the DHHS other regimens. So these are actually removed from other, which I didn't realize. That, for example, efavirenz-based regimens are removed, which is fascinating to me. So, this is a new. I was trying to find something new to tell you that you didn't already know. Maybe everybody here knew that. I did not know that. So the one thing that still, I think, preoccupies many of us who treat HIV is what's about this weight gain, right? And that was started by the advanced study. I'm not going to show you the advanced slide. That was in South Africa with these really remarkable increases in weight, especially in women, black women. Almost every person on the study in advance was black, not quite everyone. And some, women gained a mean of 12 kilograms, and the range was huge. And it's interesting, with efavirenz and TDF, there was in fact, in the first year, the mean weight gain was 0. That's also not right? In the study with the CD4 of 350 on average. And there was risk of metabolic syndrome on dolutegravir TAF. So we're worried about that. And we know efavirenz concentrations affect weight gain. The higher your concentration, the less weight you gain. So we know efavirenz is a weight suppressant. We know for sure that TDF is a weight suppressant. There was a randomized study of BF-TAF versus doravirine and islatravir in treatment-naive people that, as far as I know, hasn't been fully presented. But the weight gain was exactly the same with a regimen, doravirine, which is an NNRTI, and islatravir, which is an NRTTI. So I don't think it has that much to do with integrase inhibitors and TAF. But a lot of people believe, TAF and integrase inhibitors are the problem. It's possible. There was a study in the ACTG that was done actually years ago that showed within 12 weeks, insulin resistance doubled for everyone. Whether you're low, something I think happens immediately. And it's worse in some people than others, because all of us have patients that have gained, 30 pounds. Something is not right there. But I'm not sure it's the medicine, but we'll see. There's an ACTG study that looked at people transitioning from integrase-based therapy to doravirine-based therapy, and we'll see what those results show. We'll probably see them maybe even this summer or in the fall. But both guidelines don't recommend altering initial therapy. So the BF-TAF, dolutegravir 3TC, which I think 90-some% of the people push the button for those. I think that's still the right thing to do. And whether changing, as best I can tell, there's no evidence yet that you've changed therapy, it does anything once the weight's been gained. Okay, so what about switching in patients suppressed on therapy? And I think this is the mantra. People with HIV should be on the simplest, safest therapy that fits best with their life. Not what fits best with our life, but what fits best with their life, and you have to ask them to know. You guys do this better than I do, I'm pretty sure. And these are all potential reasons why someone may want to switch therapy. And, if there's some, disruption of Medicaid, there may be other reasons why people want to switch therapy, because they may have more limited choices. There are a ton of 2-drug and simple single-tablet regimens that have been studied. The very, very long list. And I think, to me, one of the most important things is all these studies were designed by our pharmaceutical partners to succeed, right? None of them were done with some risk to not being successful. I think that's really, really important. And in fact, some of the indications that we use these therapies for are actually broader than the study criteria. For example, cabotegravir rilpivirine, long-acting, the study actually didn't allow previous virologic failure, but the way it's approved by the FDA says just as long as you don't have integrase or rilpivirine resistance. And that's different, than what was in all of the studies, basically, except one, which I'll talk about in a second. So you have lots of choices for simplifying therapy, and certainly, dolutegravir lamivudine, the Tango study, one of the most convincing studies that two-drug therapy is fine over the very long term. What about switching with unknown resistance, where you just don't know? So here's another case. This is a man who comes to you. He was diagnosed in 2005. He got efavirenz TDF-FTC for several years, stopped due to what he says was virologic failure, and the providers told him it was resistance. He then went on raltegravir, TDF-FTC, good results, and then got switched to dolutegravir, TDF-FTC, and then when he came to your practice, is on BF-TAF, like many of our patients. All his HIV RNA in your practice have been less than 50. His CD4 is consistently above 500. But he's tired of taking pills. He lives in a group setting. He's worried about missed doses. What would you do? So the choice is here. I'm going to get my glasses out. You just continue and say, you're on a pill, you're great. Order an archived genotype, and then, depending on those results, start cabrolpivirine long-acting. Counsel the patient and start cabrolpivirine if he's interested, or you'll do something else. Very interesting. So people are getting archived genotypes. Raj, your sister's not going to be happy. I can tell you, Monica does not like this, period. I think this is really important. This is a really important question of whether we should use this archived genotype. I think we're in a research-rich setting. I actually think that's a very reasonable approach. But I'm not sure that it's any safer than doing choice number 3. Because I'm not 100% sure how good those results are. I think if you see rilpivirine resistance mutations and you decide to say, you're at risk of having virologic failure, then I think that's a reasonable approach. Do I know for sure that he's at risk? That's what the studies show. At least there was one exception, which I'm going to show you in a minute. I have a patient almost exactly like this, except I actually know that he definitely had efavirenz failure, and he has a K103N and a 184V. I know that for sure. But he intermittently stopped taking his BF-TAF, and he said, I just can't remember, I can't do this, and so he's on cabrolpivirine with counseling. I don't know that he has any rilpivirine mutations. I just saw him Thursday, and he is suppressed. So we'll see if I did the right thing. So I'm going to show you this one study. Raj is going to go into this in detail. This is the CARE study. This was done in Southern Africa. It was done by a public health approach. Very little, standard kind of viral load monitoring, except over the first couple months. And the thing about this study that was remarkable is that if you look in that box, when it was presented a year ago, they said, this worked despite the fact that 13% had rilpivirine resistance mutations and 10% had high level or moderate level rilpivirine resistance. And look at this, 16% had cabotegravir resistance mutations. And we were like, maybe it doesn't matter. Maybe we could just switch everybody. And what we learned and there was this tremendous result. The people with HIV in Africa were so happy to have this therapy. The follow-up, which Raj might mention, was fantastic. And he's going to go into the 96-week result, and I'm not going to tell you what they are. But I will tell you is, oh no, my duplicate slide went away. I had a duplicate slide. I'm very sad now. What they didn't do is they didn't correct their proviral genotypes for what's called an ApoBec mutation. This is something that our host defense does to protect us from retroviruses. And when they actually corrected for the fact that that's one of the ways our innate immune system protects us by kind of causing mutations in the virus, it turns out that, and I don't remember the exact numbers off the top of my head, that rilpivirine resistance was only in like 3%, and cabotegravir was actually only in 2%. It was not very prevalent, and Raj will tell you all those details. And so when making a choice about cabotegravir rilpivirine, people can do everything right. You can do everything right. The person living with HIV can do everything right. The injecting people can do everything right. And there's about a 1 to 2% chance of virologic failure. But try to explain that to a person. I mean, why do people buy lottery tickets when you could just burn the money, right? Well, no, seriously, because we think good things will happen. My friend over there, Glenn, could probably talk about this forever. You know, people think good things are going to happen and bad things aren't going to happen.
Look at my career.
Right. Exactly. We think, so it's very hard to explain 1% risk to people because they don't think it's going to happen to them. But it will happen to about 1, maybe 2% of people. And we're going to get better switches. This is islatravir and lenacapavir. Islatravir is this NRTTI. It works by kind of 2 mechanisms, extremely potent. People know lenacapavir, it's a capsid inhibitor, extremely potent. They can be given once a week together orally. And the phase 3 studies are starting, and I can tell you that this is the phase 2 study that was presented at ID Week. I hope there's a build there. These are not my updated slides. I'm so sad. Oh, well. Life is okay. I'll live. No failures. None. 0. See the zeros? That was circled with a nice thing. Go back. Go back. Back. Anyway, there was a bill. Oh, there it is. Thank you. All right, there you go. I can tell you the study, this is a smaller study, but the phase 3 studies have started. They're enrolling. This will be an option for you, I would say, 2 years from now. And some people really like the idea of taking therapy once a week. And then Raj is going to talk to you about this particular study. This is every 6 monthly. And we presented this last year at CROI in just 20 people. It appeared to be successful. But there was a phase 2 study, and Raj is going to talk about that. That was a little bit larger, and he'll talk about that. So. All right, I got to keep track of time. Viremia in people with HIV with adherence challenges. This is another thing that comes up, especially if you're very experienced HIV providers. Everybody has these people. They get their pills. They have trouble taking their pills. Sometimes they take them intermittently. Fortunately, many of them started in the last, 15 years now, so they started with an integrase inhibitor. They haven't established much resistance, at least that we can measure. So this is a 28-year-old man. He was diagnosed with HIV and PJP 4 years ago. He began on BF-TAF, consistently comes to clinic, but is intermittently adherent. Sometimes he suppresses to less than 50. His CD4 goes up, but he frequently stops because he has intermittent methamphetamine use. He skips scheduled visits. He honestly says, I know I'm not taking my pills. Why do I need to come in and for you tell me how I'm failing? I know I'm failing. I'm failing. But then he, feels sick or has a lot of DM. It was like, what is a DM? A text message, it turns out. With our Ryan White nurse, frequently he's engaged, but he's not. He's not taking his medicine. So obviously he needs therapy and counseling and some help with substance use. He needs an intervention. But what would you do with his antiviral therapy? Would you just continue BF-TAF, try to enhance adherence, more DMs? Or would you continue BF-TAF, do enhance adherence, and tell him, look, just get less than 50 for 20 weeks, and then I'll put you on long-acting? Would you just say, would you do that but less than 200? Or would you just say, I'm going to start cabrolpivirine, or would you do something else? Wow, 52% say they would just start. Whoa, that's more than I would have thought. So the numbers don't seem to be changing. I'm going to give it like another. Who would just go with cab rilpivirine here? Okay, so maybe it is 52%. I might actually try to convince him, since he's able to do it for short periods of time and get that viral load down. That would have been kind of my choice. But, you know, what are the data? So let's keep going. This is the Latitude study. This was presented last year at CROI. It's not yet been published, which Raj and I are chagrined about, but we're really helping people work on it. Should be out soon. But basically, this was that strategy with a little twist, which was take people much like the one I just described and actually pay them to take their therapy. So there was actual reimbursement for people that were able to get their HIV RNA. First it was less than 50, but then it switched to less than 200. And then when they reached that point, they were randomized to go on injectable versus to continue on their oral therapy without the payment, by the way. And not surprising at all, and what you guys already know, I think, is that it was quite successful, especially if one looked at virologic failure. There was much less virologic failure. That's what's in the middle there. And treatment-related failure. If the primary outcome was regimen failure, which included people who discontinued for reasons other than treatment. You know, you could argue that maybe we picked the wrong primary outcome because that missed significance by a teeny tiny bit. But the secondary objectives were significant. So this kind of certainly justifies the approach I took. And then there's quite a bit of data, a lot of it coming from Monica Gandhi's group at UCSF, looking at people who are just not suppressed. And that's probably why many of you all raised your hand, showing that really with the right support, people who are viremic actually can suppress and stay suppressed. And this is now, I think, the most recent publication from this group in CID in October, where they specifically called out the people who were not suppressed. Some of the data that Monica showed earlier kind of looks at her overall program, which include people who were suppressed and not suppressed. But in this particular one, at 48 weeks, 81% of the people remained suppressed while on rilpivirine. More of them stayed suppressed because some added another drug, some went back to oral therapy. But 5 out of 60 had some virologic failure with resistance. So the risk of resistance is higher. But, what the guidelines would say is, especially in someone that has a lower viral load, a lower CD4 or a past history of a opportunistic infection, that this actually makes sense. So that's what the IAS USA guidelines say, that Raj, by the way, leads. I should have mentioned that, and has done an incredible job. And so and the DHS guidelines are a little bit squishier based on limited data, they say, but it's the same idea. Whether in my example, if the person hadn't had PJP a few years ago and had always had a high CD4, you can start thinking about when does that tipping point kind of favor starting therapy. And then I think people are also aware, and probably some people here are doing it, is that for people with rilpivirine resistance, some people are either using cab, rilpivirine, lenacapavir long-acting, which is available, and in some cases they're wasting the rilpivirine and just giving cab, lenacapavir. Again, this comes from Monica Gandhi's group. This was also published a year ago, but there's another group in Mississippi that has published this work. Who here is using cabotegravir, lenacapavir? Yeah, I have one person. That's a more new. That's getting a fringe. It's getting a little bit farther out on the edge. The person that I'm involved with is CD4 less than 100. Is their choices are like dying or doing this. So I think that happens. Okay, so I still have 5 minutes. It's like a miracle. So here's a study that the ACTG is going to do. It's called PALIS. I'm not going to ask people from, I don't know if we have any industry collaborators here, but the ACTG, led by Monica Gandhi, actually got 2 companies, one that makes bictegravir and the other that makes dolutegravir, actually to work together. It's like a freaking miracle. So this is a study that's going to actually take approximately, I think it's 38 people that fit not being able to suppress, has rilpivirine resistance, is viremic, and it's going to look at the combination of lenacapavir and cabotegravir in a formal protocol, not with any comparison, but really to perhaps avoid the selection bias of success, people reporting when they're successful and forgetting when they're not successful. We're going to obviously look at everybody who enters in this study. So this study, we hope, will start in about 6 months. And then the last thing, I've talked about this last time I was here, so I'm not really going to dwell on this other than, this is management of ARV failure of those folks that take their therapy, have actual virologic failure. This is really uncommon, but it happens. And I think now, really, the triage point used to be, are they sensitive to a PI or not? It's really, are they sensitive to an NNRTI, to an integrase inhibitor or not? And then, if they are, then you can use either bictegravir or dolutegravir with additional agents. Maybe you just need NRTIs. Maybe it's better to add another active agent. I'm not 100% sure. Certainly in the U.S., we add another active agent if we can. In low and middle income countries, they just give, dolutegravir with TDF and FTC. And then if they're PI susceptible, then these people go on to. You can actually, again, manage them pretty well. And if they're not PI susceptible, then we have these other drugs. Fostemsavir, which is available, ibalizumab, which is available, lenacapavir, long-acting, which is available, that are active therapies in people who don't have options. I saw a patient of mine on Thursday who was on, this is the honest truth, absolute truth, tapranavir, ritonavir, ibalizumab for 12 years. He was on one of the first studies of ibalizumab, and he was on it for 12 years. He's now on, and he was also on 3TC because it's magic, and it is magic, by the way. I totally believe that. And Maraviroc because he had R5 virus. He's now on fostemsavir, lenacapavir. He's no longer on tapranavir, ritonavir. He's no longer on ibalizumab. He's still on 3TC and Maraviroc. And he looked so good, I almost cried. I mean, he was so much better. His CD4, he's been suppressed the whole time, but he just felt so much better. It was like really amazing. So we have these are not easy to give. Fostemsavir is easy to give, but it is twice daily. But ibalizumab is quite a challenge. Lenacapavir, we're getting used to it, and I think it's being used, and it's being used as a substitute more often than I think than being used as for people with virologic failure, just because they're so uncommon. And then, I think there are these broadly neutralizing antibodies, which Raj will probably mention because of that study that I briefly mentioned. I think the companies that have these, there's only one that has them that could distribute them. I think they should be available for compassionate use, actually, for people where we don't have active therapy, just like for unusual cancers or resistant CMV or whatever, right? And this is from Taewook Chung, I think, where they used a combination of a long-acting therapy and an anti-CD4 antibody to suppress a person who was not suppressible because of resistance. So I can hum for 16 seconds, but I won't. Here's my summary. Optimal initial therapy is still anchored by a second-generation INSTI. There is the risk of substantial weight gain, and I see it as an unsolved problem, but maybe we can figure it out. There is simultaneous comorbidity risk reduction in our people are going to gain weight, and we perhaps need to be proactive instead of reactive in terms of preventing weight. And I do think the evidence that our second-generation INSTIs may contribute to increased diabetes risk independent of weight change, I think that's possible. Hopefully, maybe next year you'll have an expert, I have this name-finding problem since COVID, our Hopkins Pale endocrinologist, or to come and talk to us. Optimizing therapy to improve lives is our priority, and focusing on sustained suppression and quality of life while minimizing risk and guiding decisions. That's what providers are supposed to do, right? Guiding decisions. And additional options, I think, are needed still for people with adherence challenges, those who we struggle to reach. I mean, all the work Monica Gandhi has done is people that actually come into their clinic. What about the people that don't come into their clinic? We have an R34 that's hung up because there's no council's not meeting of actually delivering cabotegravir, rilpivirine in the field. I don't know if it's a new investigator. She got a score of 13, which is right on the borderline. Hopefully she'll get it. So anyway, and multi-drug resistance is rare, but I think additional novel agents are needed. Thank you for your time, and I'm done.
You know, what's really nice about the meeting is that the speakers are actually out there seeing patients like Joe on Thursday, and bringing their experiences here. So now it's Thomas Jefferson coming up to ask, what did I miss? He's just returned from France, and he's fighting with Alexander Hamilton. But in the meantime, he's here from Mass General, and we're looking forward to what he has to say. What did I miss at CROI? Welcome, Ron.
30 minutes is talk about some of the highlights from CROI. What I won't do is won't cover a couple of topics that will be covered later on, and I'll come to that in just a minute. But before I get started, I do want to give a shout-out to a really galvanizing plenary at CROI this year, done by Rebecca Dennison, a writer and activist. The title of her talk was What's Changed, What Hasn't, What Shouldn't, and What Must in the last 40 years, and I think it really was an amazing start to an incredible conference. So with that, what I am going to cover in the next little bit is new approaches with current ART. I'll come back to some of the studies that Joe mentioned. I'll talk some about novel ART regimens and strategies. We're going to spend a little bit of time on co-infections. I'm going to have a section on Hep B vaccination, although you'll hear more about Hep B vaccination from Dr. Spock later today, and as well as Mpox. Talk about comorbidities and a couple of slides on the cure. What I won't cover is you're going to hear about long-acting antivirals from Dr. Flexner, STIs from Dr. Clement, and PrEP from Dr. Landowitz, so I'm going to avoid those topics. So new approaches with current ART. I do want to come to that study that Joe mentioned, the CARE study. It's a very important study that we received an update on. As you heard, it's a study of adults on stable oral ART. They were all virologically suppressed. They didn't have a history of treatment failure. I might underline that. They had never had treatment failure before. They either got oral ART, standard of care, or switched to cabotegravir rilpivirine. So again, they're all suppressed. And HIV RNA was checked every 24 weeks. This was mostly women. 57% or so were women. 21% had a body mass index of greater than 30. Why is that important? Obesity in other studies has been linked with higher rates of virologic failure. The time on first-line ART was 8 years, and 98% retention at week 96, really a stellar retention rate. What they did, Joe showed you the initial analysis where there was a high rate of rilpivirine and cabotegravir resistance. When they drilled down into it and when they removed those defective viruses, those APOBEC mutated viruses, now the rate of what they call intermediate or high rilpivirine resistance was down to 3%. 12 out of 400 or so people. And when they drilled right down to it for integrase resistance, there was only 5 individuals out of 200 or so that had integrase resistance. So they contracted the number of people with this so-called proviral DNA that had resistance. Now, the results at 96 weeks were almost the same as the results at 48 weeks, essentially 97% suppression in the oral group, 97% suppression in the injectable group, so clearly non-inferior to switch. There were a few people, 4, who had virologic failure. That's 1.6%. Remember that number, between 1 and 2%. So 1.6% had virologic failure. None of them had obesity, by the way, none of those 4 individuals. 3 of those 4 individuals did develop resistance, and they did resuppress on oral therapy. None of the people on the oral therapy group, the people who stayed on oral therapy, developed resistance. This is a theme that you'll see in other studies as well. And as Joe alluded to, 99%, over 99% of people in this study in sub-Saharan Africa preferred the oral therapy. A couple of other studies on current ART that I want to highlight. In the TRIO Health US cohort, so this is a large cohort here in the US, and people who switched or who initiated cabotegravir rilpivirine, the rate of virologic failure was less than 2%. So that's where all of these studies are converging, 1 to 2% rates of virologic failure. And resistance was really very, very rare. A second study, Joe mentioned that at UNC they have a grant to do kind of out-of-the-clinic administration of cabotegravir rilpivirine. This is a local study from Whitman Walker. It's a study called the Mobile Outreach Retention and Engagement Program, the MORE program, which I thought was a clever title. And 44 people with HIV who had had adherence challenges got home administration of cabotegravir rilpivirine. Not very long follow-up, but what they see so far looks great, 100% viral suppression at 4 months. And then the last study that I want to highlight is a study that is very applicable to our patients on bictegravir FTC-TAF. This is looking at over 1,000 people with mild to moderate renal impairment. That's defined as a eGFR between 30 and 90. Only 1 of those individuals discontinued bictegravir FTC-TAF because of renal events. Now, 90 is a pretty high GFR. When they drilled down to 94 participants who had an eGFR between 30 to 60, none of them had problems with their renal function. And I think that accords with what we're seeing clinically. Okay, so that's a bit on current ART. Let's now pivot to where we may be going next. We'll talk about novel ART and a couple of novel strategies. So at this meeting, we learned about a number of new classes of drugs. So here are the main classes of drugs. The ones in red are the ones I'm going to cover. So we saw some data on broadly neutralizing antibodies. We saw some data on a drug called islatravir, which Joe mentioned, but I'll give some more details on, including 2 phase 3 trials. We saw some drugs on a new, potentially long-acting integrase inhibitor that has a bunch of letters right now, VH184. And then we saw some data on VH499, which is a new capsid inhibitor. So those are the new drugs we're going to hear about. So let's start with the phase 3 trial, and this may be, I would say, on the horizon. This is a switch study. So doravirine is an NNRTI. Islatravir is this new class of nucleoside reverse transcription translocation inhibitors, NRTTIs. People will remember that when this drug was first studied, they used a higher dose that caused lymphopenia and low CD4 counts. So now they've dialed back the dose of islatravir to a lower dose of 0.25 milligrams a day, and they have reasonable data, and these data show that doesn't cause lymphopenia. So they gave the low dose of islatravir, they gave standard dose of doravirine, an approved NNRTI. And they did 2 phase 3 switch studies. The first switch study, so all of these switch studies are in people who are virologically suppressed on oral therapy. All of them were done in none of the participants had a history of treatment failure, and that's important because none of these people were really at risk of having resistance. They had no known doravirine resistance, of course, and they had no active Hep B. I'm going to come back to Hep B. These are tenofovir-sparing regimens, so keep your eye on Hep B. And there was a 2-to-1 randomization. So there were 2 studies presented. I'll show you the data. The first study took people who are on bictegravir FTC-TAF, and they either continued them on that or switched them to doravirine islatravir, about 500 people. This was double-blind. And then there was a different study that took people on a variety of different regimens. None of them had had treatment failure. and they either continued their treatment regimen or they switched to doravirine islatravir. Again, about 500 people. This one was open label. So a couple of themes. CD4 count and lymphocyte counts in both studies didn't really change. They were stable, and they didn't change between the islatravir group and the non-islatravir group, so that was good. How about the Hep B? 3 individuals out of these 2 trials did develop Hep B viremia, but interestingly, it was a very low level, and this was in the islatravir doravirine group, the group without tenofovir. Very low level. There was no hepatitis B surface antigen. There was no hepatitis. Separately from the people who had low-level viremia, 2 individuals had acute Hep B, and we're going to get to Hep B vaccination both in my talk and in David Spock's talk. Really a reminder as we're switching people off of tenofovir to immunize them for hepatitis B. Weight, Joe gave a preview of this, but in this switch trial, there was really no difference in weight with the switch to islatravir doravirine, except in those individuals who stopped those drugs that were mentioned, the weight suppressant drugs, TDF or efavirenz. So essentially, these switch studies didn't find a signal of a weight effect of the TAF or of the bictegravir. And we can come back to that in the Q&A. Here are the virologic results for the 2 studies. I'll show you the first one is the switch from bictegravir FTC TAF. The point to make here is that there was really no difference between the switch to islatravir doravirine versus continuing bictegravir FTC TAF, non-inferior results. There was no treatment emergent resistance in the people who switched, which is, again, good. How about if you switched from a variety of different regimens? That's that second trial. Again, no difference. Doravirine, islatravir was non-inferior to continuing baseline ART. Here they have a box with more details in terms of some individuals who had resistance that wasn't treatment emergent resistance. It turned out some of the people who entered the study, even though they were thought to have never had virologic failure before, some of the people had proviral resistance, and so they kind of delved into that. But these were not thought to be treatment emergent resistance. So again, the take-home lesson from this is that switching to doravirine islatravir given daily at this low dose of islatravir was non-inferior to other regimens that we might use. I think that this will go to the FDA. They also have a treatment-naive study going on, separate from this. These are switch studies, and we'll see what the results of those are in the future. I mentioned that there was a couple of other novel drugs. You're going to hear more about long-acting drugs from Charlie Flexner, but the 2 drugs that we saw data on, one was a capsid inhibitor, VH499. It was done in treatment-naive people. They gave an oral dose, and there was about a 2-log reduction in HIV RNA, so looked good for this capsid inhibitor. One individual did develop capsid inhibitor resistance, and this is kind of like what we see with lenacapavir. You can get resistance to the capsid inhibitor class. It doesn't happen frequently, but it can happen. What's interesting about this is now there's a long-acting injectable formulation that they're beginning to study in phase 1 trial. So that's one capsid inhibitor to watch for the future. And then an integrase inhibitor, a 3rd-generation integrase inhibitor. What does that mean? That means this integrase inhibitor has activity against dolutegravir-resistant virus, which could be important, especially in parts of the world where we're beginning to see a little bit of dolutegravir resistance. This integrase inhibitor, when given orally, had a 2-log reduction in HIV RNA, so again, looks promising. And this is going to be studied with in a long-acting formulation. Right now, they said that they're going to do it in people without HIV. So 2 novel drugs. I want to come back to the broadly neutralizing antibodies. This is a part of HIV medicine that continues to advance. We saw a phase 2 trial with lenacapavir, the capsid inhibitor, teripavilimab and zinlervimab, 2 broadly neutralizing antibodies, so phase 2 trial. If you look at all comers with HIV in the United States, about half of them have virus that's susceptible to both of these antibodies. And so in this trial, they took people whose virus was susceptible to both antibodies, randomized them 2-to-1 to either get the long-acting drugs, the lenacapavir with the antibodies, or continue the baseline ART. It was about 50 people in the long-acting group, 27 in the oral group. And those bars show you that 96% of people stayed suppressed at 6 months in both groups, so really no difference. One participant did get a lot of attention because in the injectable group, one participant did develop virologic failure. That individual had lenacapavir resistance develop. They lost susceptibility, the virus lost susceptibility to one of the two antibodies. But when they delved into the reasons why, it turned out that the lenacapavir level was on the low side, and so that may have been the reason why this particular person had virologic failure. That plus non-susceptibility, development of non-susceptibility to the antibody. And again, I'm hoping, Mike, that there'll be time in the Q&A to come back to this. The one other antibody study that I want to mention in the treatment space is the EMBRACE study. We'll talk about antibodies at the end in the cure space. So long-acting cabotegravir, so a small molecule plus a BNAb called N6LS was studied. N6LS is a BNAb that is being combined with monthly, not every 2 months, but monthly cabotegravir in this particular study. It was studied intravenously for the antibody or subcutaneously. And of 99 individuals who who were in this study and got the antibody and cabotegravir, 4 of them did develop virologic failure. 1 of them developed integrase resistance. You can see the overall results of virologic suppression, about 88 to 96% virologic suppression. Why are these people having virologic failure while on a small molecule cabotegravir and broadly neutralizing antibodies? I think we don't quite know yet. I think we'll have to see what the genetic barrier to resistance is of these antibodies, and so I think time will tell in terms of how these broadly neutralizing antibodies work. I think we're probably going to need 1 or more, probably 2 or more active drugs when you're using these antibodies. And so, again, in the Q&A, we can come back to that. What the plan is for this antibody is they're going to evaluate it every 6 months, given this antibody every 6 months with cabotegravir. I think this time they're going to give cabotegravir every 2 months in part 2 of this study. Okay, so that's a little bit about what may be on the more distant horizon. Let's now talk about co-infections. And I'll do one study on Hep B vaccination, and then we'll talk about Mpox, both a treatment trial but also some other observational data. So just as a reminder, David Spock will come back to this. Hep B vaccination in people who are negative for surface antigen and surface antibody, right now, including those people who are core antibody positive, right now it's recommended that we give the Hep B CpG vaccine. That's the adjuvanted vaccine that goes by the trade name of Heplisav. 2 doses at 0 and 1 months currently is the preferred vaccine. The guidelines suggest that we consider 3 doses of the vaccine in those who have low CD4 counts or in prior vaccine non-responders. Emphasize, which is check the surface antibody 1 to 2 months after completing the series and then re-immunize them if they don't seroconvert. So at this year's CROI, did that just flash on and off? Okay, good. But it's back. At this year's CROI, we saw some durability data. So the data that led to that last recommendation came from the ACTG Beehive study. At this year's CROI, we saw some durability data. How durable are these surface antibody responses? And I'd love in the Q&A to come back to, should we be monitoring people's surface antibody over time once you immunize them? Let's definitely come back, and David may actually talk about this as well. So Christy Marks at this meeting presented the durability data. I want to remind people that Beehive had 2 groups. Group A were prior vaccine non-responders, hadn't responded to Engerix or Recombavax or one of the older vaccines. In the original Beehive data, if they got 2 or 3 doses of the adjuvanted CpG vaccine, they had better seroprotective responses than if they got the alum vaccine, that's the Engerix vaccine. So that's Group A. Those data have been published. There was also a vaccine-naive group, first vaccination, and that was Group B. 100% of those individuals had a seroprotective response. So now we see data on how far out does the durability of these responses occur. Group A is the vaccine non-responders, and what you're seeing here is at the 2 top lines, you're seeing the CpG vaccine, and they're seeing the titers in the line that kind of goes down, that's lower, that's the Engerix or the alum vaccine. The basic finding here is that the people who got 3 doses of the CpG vaccine had a more durable response than people who got 2 doses. Both responses are high, but the durability was better with the 3 doses. And then 100% of the people who got CpG vaccine for the first time at the end of the study had seroprotective responses. Here's their summary. Higher end of study seroprotection achieved with the CpG compared to the alum vaccine. Higher seroprotection, higher durability with 3 doses of the CpG vaccine compared to 2 doses. And the higher your titer, if you get a titer over 1,000, you tend to have a more durable response, which is not surprising. If you have a lower titer, it's more likely you're going to fall down below 10. Switching gears again now to Mpox. People will know that tecovirimat is an antiviral that's been studied for the use for treatment of Mpox. These are the results of the ACTG STOMP study. So clade 2 Mpox is the Mpox that we have here in the United States and in Europe. In this particular study, 530 people with Mpox were randomized 2-to-1 to either get tecovirimat or placebo. The days from time of symptom onset to time to randomization was 8 days. Even though we tried to enroll people as quickly as possible, there takes some time for people to be identified and for them and their providers to know that they have Mpox, so median of 8 days. 35% were living with HIV, and most of them were well controlled with their HIV. The bottom line results are what you see in the graphic there. Clinical resolution between the placebo groups and the tecovirimat group, really no daylight between those two curves, so really no effect of tecovirimat. When the team delved down into symptom duration, even if you started before 3 days of symptom onset, even if you started before 5 days of symptom onset, couldn't see a difference in the curves. HIV status and prior vaccination, none of those really affected a response. And importantly, we know that one of the feared manifestations of Mpox is pain, and this did not find an effect on pain. There was a trend towards decreased detection of the virus at day 8, but by day 15, that trend was gone. And I think it just highlights once again that we need to do clinical trials before we can make conclusions. And the other corollary here is we need studies of newer agents, whether it be combination agents or some of these Mpox antibodies that are coming down the pike, especially in immune-suppressed people. A couple of other studies from CROI I want to highlight, separate from STOMP. In people who have severe Mpox, this was also an analysis from the STOMP study. In the subgroup of people who had severe Mpox, which is defined as having ocular Mpox or facial lesions or hospitalization, or in people in STOMP who had exfoliative skin conditions or uncontrolled HIV, those individuals got open-label tecovirimat in the STOMP study, but it appeared that the time to clinical resolution in that single cohort was similar to the placebo group in STOMP, so it didn't seem to be an effect there. In a study out of UT Southwestern, led by Ankh Najawan, severe scarring after Mpox, this was a different study, was associated with uncontrolled HIV and black race. And then a really interesting study out of California looked at reinfections. Out of 6,500 reported Mpox cases in California, 0.1%, 9 participants had confirmed or probable reinfection, and those reinfections occurred pretty late. The median was about a year or more, 448 days after the initial infection. So reinfections occur, they're not common, and they can occur a year or more after the original infection. Okay, galloping along, we're going to do comorbidities next. And let's start with a study from REPRIEVE. People will know that REPRIEVE was the randomized study that found in people with HIV that statins, pitavastatin, reduces cardiovascular events by 36%. Here there's an acronym I want you to know called MACE, Major Adverse Cardiac Events. So REPRIEVE was a 7,700 participant study. Here at this meeting we saw a mechanistic sub-study in 803 participants, so a subset of those individuals. These individuals had inflammatory markers measured, and they had coronary CTs done. In the sub-study, the median age was 51 years. The cardiovascular risk score was 6.6%. And what I'm showing you on the graphic here is if you look at baseline non-calcified plaque, okay, baseline non-calcified plaque on CT, those people who had baseline plaque had a 2.5-fold increased risk of having a major adverse cardiac event, basically having an MI or another cardiac event. So this lends plausibility to why statins are working here, because we know statins reduce plaque. And so this is kind of the mechanism, we think, by which statins are having their effect. But what was also interesting in this REPRIEVE study is they looked at several inflammatory markers like CRP, like IL-6, subclinical myocardial injury, and those two were also associated with a higher rate of these cardiac events. Another study that really, I think, shed some light on how inflammation may be contributing to some of the clinical events we see in people with HIV came out of a study of letermovir. This is also an ACTG study. So this is a study building on the observation that CMV is associated with immunosenescence and frailty. There's a lot of data making that association. So what this group did is they looked at letermovir, which is a CMV inhibitor, versus placebo in people with HIV on ART. All these people their HIV was suppressed, and they either got letermovir or placebo. This particular study was stopped after 40 participants were enrolled based on a futility analysis, because when they looked early, the primary inflammatory endpoint, which is TNF receptor 2, actually went up transiently. But they were smart enough to do additional follow-up, and when they looked at additional follow-up, that TNF receptor went back down. Other inflammatory markers, including really important inflammatory markers like IL-1 beta, which has got a long history of being associated with clinical events, that went down. Interestingly, and this is, I think, what got a lot of buzz, is that the CD4 count and CD4 to CD8 ratio actually went up, particularly in women, and particularly if the CD4 count was low to begin with. And then they looked at a measure of physical function, which is getting up and down out of a chair 5 times, and that also improved and was correlated with some of these inflammatory markers. So opens the door, I think, to some new directions. And then the last kind of topic on comorbidities was a whole plethora of studies on something that I learned about for the first time called epigenetic clocks. Epigenetics is not your DNA, it's the way your DNA is modified. And so all of us have our DNA modified by a number of modifications like methylation. There's also telomere length. These are clocks as to essentially what our age is, how old our DNA is. So there's our chronologic age, but there's also our epigenetic age or our phenotypic age. A number of studies have shown that epigenetic age can sometimes be higher than our age on our driver's license or on our birth certificate. So if our epigenetic age is greater than our chronologic age, that suggests faster aging. So at this meeting, we saw data that certain epigenetic clocks, and they come with a bunch of different names, are associated with increased aging events, serious non-AIDS-related events, and then mortality. So that's an interesting observation, but what can we do about it? One of the studies that was provocative was a study of semaglutide. You can't have a meeting without a semaglutide study. And so this looked at semaglutide and epigenetic aging. And this was building off a study that Grace McComsey led that looked in a randomized way on people with HIV-associated lipohypertrophy, so kind of a subgroup of people. And what this group reported is that semaglutide was associated with a 3-year decrease in the annual rate of epigenetic aging mortality risk. So they drew this nice figure, which is that HIV makes your epigenetic clock tick faster, and then semaglutide may kind of slow it down again. Now, what we don't know, of course, is the durability of semaglutide's effect, and we don't know clinical impact. It's a really interesting observation, but clinically, time will tell, so to speak. In terms of other comorbidity highlights, one other REPRIEVE study that I want to shout out, because this comes up day after day, which is, do statins cause dementia? The REPRIEVE, my patients ask me about this pretty often. In the REPRIEVE study, they found no evidence of a detrimental effect of the statin on neurocognitive assessments in people with HIV. I think this is, I'm going to feed this back to my patients that really there's no evidence that statins cause dementia. Hepatic steatosis, a separate study, was very prevalent in people with HIV and was associated with increased mortality, all the more reason to study treatments for steatosis. And then there was a whole themed discussion on heart failure, a number of studies showing that the risk of heart failure in people with HIV is higher than in people without HIV. Last but not least, a couple of cure studies. I want to start with a study that we did in one of our studies in the ACTG, which is looking at persistence of virus. And here we're looking at persistence of virus in the cerebrospinal fluid. Despite 40 years of HIV, there's relatively little known about what happens in a person with HIV and their CSF over time in terms of HIV. So we looked at 16 participants from an ACTG study. These 16 participants had been on ART for up to 20 years. They all had long-term suppression of virus in their plasma, and they underwent 4 to 5 longitudinal LPs. So really a shout out to these participants over the course of several years. The median time on ART at the time of the first time point was 9 years, so they'd been on for a whole decade. And what you're seeing here are 16 individuals. Each color is a different person, and you're seeing no evidence of a decline in HIV DNA in the CSF. Every single participant had at least one time point with HIV DNA and no evidence of a decline. So really we need to understand what is going on with the exposure of this in the CSF to HIV in terms of neurocognitive function, in terms of inflammation, et cetera. And then the last study before I wind up is a study called RIO. RIO is a study, it's kind of focused on cure, focused on reservoirs. It's asking a question, do 2 broadly neutralizing antibodies maintain HIV suppression? These are individuals who started ART during primary HIV infection or who had a CD4 count greater than 500 when they started ART. All of these people had been on therapy for 12 months or more, and they got randomized either to get saline, placebo, or to get BNAbs. And then they could get a second dose of BNAbs at a future interval, either the BNAb or the placebo. The main results of RIO, there was no viral rebound by week 20 after ART interruption. I didn't say this, but I'll say it now. After getting the BNAb or placebo, then they stopped antiretroviral therapy. So they came in on ART and then they stopped. At week 20, 75% of the people who got the BNAb didn't have viral rebound. And that's compared to 8.8% of the people who got placebo. And then after they looked at people who got 2 doses of either BNAb or placebo, about 40% didn't have viral rebound by week 72. So now we're going out pretty far. There were 3 patterns of rebound, the one that got the most attention. So some people rebounded quickly. Some people had kind of delayed rebound. But 7 out of 29 individuals, about a quarter, had this flat line with their viral load. Essentially, their viral load did not change at all. That flat line is at less than 50, so viral control. Some of those people actually were in the placebo group. All right, so here's my summary after this rapid tour. Long-acting cabotegravir/rilpivirine maintains HIV suppression in most people with HIV. We do need to do studies of long-acting injectables, both in the U.S. but also low- and middle-income countries. There are new combinations for HIV treatment on the horizon, including islatravir/doravirine. There are novel long-acting injectables, including combinations of BNAbs with small molecule antivirals. We need to do more of those studies. There's some new insights coming around how statins modify cardiovascular risk in people with HIV. Epigenetic clocks offer another view of aging in people with HIV. Now, if we could just turn back that clock. And tecovirimat did not improve mpox clinical outcomes. New drugs are needed. And finally, research into HIV reservoirs and cure are accelerating. So with that, I will stop. Thank you for your attention. And look forward to the Q&A.
Great. Encourage folks to come to the microphone. I've also got a iPad here to take questions from the virtual attendees. Looks like I may kick it off with to Joe and Raj, both of you, I guess, just to challenge the sense of what is the value of a DNA genotype for archive virus. It just feels to me like there's more problems with it than benefit. And so what are you guys doing in your practice? Are you actually ordering that?
I order it very occasionally, not routinely. The trouble with the DNA genotype is a couple of things. One is it's not very sensitive. There was a study that was done a number of years ago where people had M184V in their virus. There was 100 people who had M184V, And we knew that because there was an electronic report saying they had M184V. And only half of those 100 people, when they did a proviral genotype, could they find it. So that means it's only, for that particular mutation, about 50% sensitive. There was also a study at last year's CROI that looked at if you did proviral genotype sequentially over time, what were the results? These were people on ART. That's when you do proviral genotype, is when people are on ART. And essentially what that study showed is that there was variability over time as to what mutations you found. So there was kind of you didn't get the same answer every time you got a proviral genotype. So that also raised some questions. So I think bottom line is it's not been validated in terms of its use. I will use it very occasionally if I have someone suppressed, they're maybe having toxicity and I just can't get a treatment history. And I've done my best to try to fill in gaps in their treatment history. And I'm just wondering what might be there with the understanding that it may not be even replication competent. It may not be, even if I were to find a mutation, it may not be relevant. So I don't use it very often. I use it only when under these unusual circumstances. And if I find a mutation, I tend to take it seriously. But if I don't find a mutation, it still may be lurking in the background. So you could see my hand waving going.
Yes, I noticed that hand waving.
The hand waving is kind of very rarely.
Yeah.
Not routinely.
I mean, I think there are two issues. One is it's a resource, right? So if you're in a resource constrained setting, which a lot of our kind of Ryan White programs are in, I don't think it's worth it. If it's not a resource constraining, the issue is what do you do with the information? And I think what Raj said is exactly correct. I think what we do know from a whole slew of cabotegravir-rilpivirine studies, if you see a rilpivirine-associated resistance mutation in proviral DNA, that person is more likely to fail. I think that we know. And it turns out in the 4 people who failed on the CARE study, 2 had a rilpivirine resistance mutation. And that means the failure rate in that particular group was somewhere around 14 or 15%. So it actually verifies the previous study. So I think it's what you do with the information. And I think if you find it, you really have to counsel people that they're really at high risk of having virologic rebound based on what we know. And if you don't find it, you shouldn't say, oh, you're free. You won't have any, this will work for you. I guarantee it. I mean, I tell people when they go on BF-TAF, if you take every pill, you will not fail. I mean, I feel 100% confident of that response. So it just really, it's like a risk assessment, and we'll get Glenn to come and talk about humans and risk someday.
Great talks. Hey, Ra, I'm just going to start off with a clinical question, which you just destroyed a central dogma that we all probably learned, Raj, that what was the rationale for looking at durability of surface antibody response to hepatitis B? Because we all learned that there's an amnestic response if you demonstrate that it's greater than 10 to begin with. And even the CDC, said that these people didn't have to be revaccinated.
Okay. So I might call a friend in a minute and see if Mark Sulkowski wants to comment. But this is what I would say. So if you look, and I did look at this recently, the CDC guidelines right now say after Hep B vaccination, there's one group that everyone agrees, well, the CDC at least agrees that we should do serologic testing. And this is not HIV. This is people on hemodialysis. So people on hemodialysis right now, if you look at the Hep B guidelines, if someone on hemodialysis loses their surface antibody, which then implies that you're checking them, that's generally recommended that you re-immunize. So that's not most of our patients. What about HIV? So I have for years, Doug, said the same thing that you have, which is once you get a surface antibody, if you've got a documentation that they're going to have an anamnestic response if they get re-exposed, and so I don't need to worry about them. Christy Marks has told me that there's now case series of people who've lost their surface antibody with HIV who have acquired hepatitis B. So that breaks that dogma that we've been saying for many years.
And obviously we're not either.
So now that we're in more instances considering non-tenofovir regimens, yes, I think if they're on tenofovir, I think that would be vanishingly rare. But if they're on cabotegravir-rilpivirine or in the future cabotegravir-lenacapavir or islatravir-doravirine, then we saw in some of these instances that there were cases of hepatitis B. But we have two people who could come to the microphone, David Spock or Mark Solkowski, who may want to comment on, should we be checking surface antibodies, Mark, in our patients who have HIV at some interval, or once they're positive, are we done?
So while Mark's walking to the microphone, I'll just, believe it or not, I still do general medicine attending. And on the first day, one of my lines that I tell them is that there's a thin line difference between what's dogma and what's dog manure. So you got to keep that in mind as you listen to things. Yeah.
Yeah, getting back to Hep B vaccine, I don't have a lot to add to that. I think one of the issues is they've done studies of people vaccinated as children, and many will lose their titers of antibodies. But then I think you have a lot of people whose risk of acquiring Hep B is actually relatively low. So to identify that subset that may still be at risk turns out not to be a major issue. But then when you talk about populations where the risk of exposure is actually not small, and we might put some of our patients with HIV in that category. I put people living with someone with active Hep B, not on treatment, in that category. And there are others. Healthcare workers, for example, may be in that category as well, depending on their line of work. So I think it's both. It's the potential risk of exposure. Someone at low risk, you wouldn't want necessarily care.
So what I would add is that what I'm doing now, just for if someone is going off a TDF-based regimen and going on to a regimen that doesn't cover hepatitis B, then I actually get a surface, even if I have a history of positive surface antibody, I test. And if it's not positive, I vaccinate. Just I don't know if that's a guideline or not. Right now I'm just reading the New York Times. I don't have time for guidelines. To see if I still have a job or whatever. But so that's what I do. I don't know what anybody else does.
I think actually, Mark, I think the DHHS has more or less said do what you said, which is if you're switching off of tenofovir, good time to make sure at least in the last year or two they've had a surface antibody, or do it then. And I think that's probably the answer to your question.
Sounds like new dogma to me. Okay.
Or the other.
This is Mickey from Hopkins. My question is one to Joseph, one to Rajesh. Joseph, for you, you talked about weight gain. I know we're going to beat that to death. How would you comment on Jordan Lake's presentation at CROI? Because she was very confident that, it's INSTIs and TAF, this is what's doing it, and that's what's happening. And for Rajesh and to Mark Solkowski, that the Hep B antibody, we recently had a patient who seroconverted, were core antibody positive, switched to injectable, and had a remount, and no risk factors apparently. In the millions, actually a month later of switching. Wow. So the question became, should we be testing people for surface antibodies and vaccinating sooner? And we spoke to Chloe Teo at Hopkins, and she pointed to DHS guidelines. There's 2 studies done in a very small subsection talks about that perhaps in certain patients who are at higher risk, but they don't define what higher risk is, that maybe we should be checking surface antibodies every year. Almost. Right. So what would you say about that?
Well, I guess I'll go first. I was stunned by Jordan Lake's presentation. I got to say. I think, for example, that one big study, SOLAR, which was focused on what happened with people on cabotegravir and rilpivirine, actually were people on BF-TAF who went off TAF. They stayed on integrase, and there was no improvement in weight. So I think going off TAF, there's tons of randomized data. Gemini, not Gemini, the Tango, etc. And then I showed you that study. It was with a higher dose of islatravir, I don't actually know if that study's published, but it's available on clinicaltrials.gov. If you compared BF-TAF with islatravir doravirine and you looked at weight gain, at 48 weeks, 3.8 kilograms in both groups. No integrase, no TAF. I've urged the people at the company who did that study to publish those data and look at what happened to women, what happened to people that were obese. they're going to wait till they get their lower dose thing done, I guess. So we'll see. But I was stunned. What can I say? I think something does happen when people start therapy. There may be a contribution of second generation integrase. I think the evidence for TAF is pretty darn weak. So that's what I think.
And actually, the switch study supports what Joe says, staying on weight gain for a second. The switch study, the group that switched off of bictegravir FTC TAF to islatravir doravirine, so they stopped their TAF, they stopped their bictegravir, they had no difference in their weight change than the people who stayed on bictegravir FTC TAF. So that switch study also, plus the other study Joe's mentioning, all of that, I think, is going to lead us to predict that switching therapy is not going to make a difference.
There is one study that Jordan did present, pharmaceutical sponsored study called Pasa Doble, that there is suggestions and subsets. I just found it odd that was presented when there's, if you do 100 studies and your p-value is 95, 0.5, one of them might show something, so I just have to be really careful and look at that study very, very carefully. It may be true in some subsets that it makes a difference, but I think you have to be very careful.
So we have questions from your
microbiome. It's usually the answer. The Hep B question is, I think, to reiterate, if someone is switching off of tenofovir, it's a good time to check their surface antibody. And I think that case that I wrote it down, rebound in the millions, illustrates the fact that with core antibody alone, where they've lost surface antibody, I would reimmunize that person before if there's an urgency to switch, then of course switch. But if there's not, then reimmunize them first and then switch them. As to whether we should be checking yearly, I don't know the answer to that. I don't think so. And the reason I say that is, once you get really high titers with surface antibody, I think it takes a fairly long time for that to fall. And so even if they stay off of tenofovir for a while, maybe at some point in the future recheck, but it's not going to be at a year.
So we'll have a few minutes left. We got a number of questions from the attendees that are virtually here. How do you measure an epigenic clock? Is it you go to Switzerland and it says cuckoo, cuckoo or something?
These clocks have these real, I won't answer I don't know the answer to your question. It's a research test, but they have really amazing names like Grimm's. Grimm's, I don't know. Some of the names are like kind of
sounds like a fairy tale.
Yes, I was going to say. So I think it's all research.
They come from very large data sets, right? Yeah. Where they measure various methylations at very specific sites, and the Grimm guy has some sites, and the other guy has some sites, and then they correlate it with some outcome, whether it's mortality or how fast you can stand up or how strong your grip is. Whether changing it with a medication actually makes you live longer is completely unknown.
Yeah. Makes me feel better.
But it makes Mike feel better.
Yes. So a couple others real quick. So what would the benefit of switching to islatravir doravirine provide over currently available are? Do you have a sense of that?
Yeah, it's a good question as to what will be the niche for doravirine and islatravir if it's approved. I think it's not common, but if there are occasionally people who don't tolerate integrase inhibitors. I acknowledge that's uncommon. If some of these issues around integrase inhibitors and glucose and integrase inhibitors and other metabolic effects, if they pan out, and we'll see, I think right now there are more signals than anything definitive, then there may be a role. But I think it won't be the majority of my patients. I think, it's one of those things that's going to be dynamic.
So a couple other things real quick. So coming back to the resistance question with rilpivirine, if you have, say, a non-rilpivirine in an RTI resistance mutation, like, say, K103, still okay to use that?
It's a good question around K103N and cabotegravir. I'll say my opinion and get Joe's as well. So the Atlas and Flare studies were the studies that got cabotegravir rilpivirine FDA approved in the US and Europe. They allowed people who had K103N into those studies. It turns out when all was said and done, there was only about 20 or so participants, not a very large number, who came into those studies that had K103N. It wasn't exclusionary, but they didn't turn out to have very many people who had K103N. Those people didn't seem to rebound when they were on cabotegravir rilpivirine, but there wasn't a ton of people. It was 19 or 20
It's really important that they let them in if they had no history of
Yes.
NNRTI failure.
Right.
So they're transmitted resistance,
Right.
which is different than
acquired.
selected resistance.
Yeah. So it depends, again, on risk tolerance. I think it depends on the specifics of your patient. I think in general, the worry about this is if they have rilpivirine resistance hiding in the shadows there, at low levels, that they might fail. And there's instances where that's happened. I know patients who have failed cabotegravir rilpivirine who had K103N, but it's hard to be sure. I have a patient right now, just, speaking of seeing patients on Thursday, who has, sadly, esophageal cancer and just cannot swallow. I mean, he cannot swallow while he's getting his chemotherapy. And so he does have K103N, but he's not swallowing his pills right now, so I'm putting him on cabotegravir rilpivirine. He has no other mutations. We probably might add lenacapavir as well. We're working on that. So there's some instances where I'll do it, but I don't do it kind of blithely.
Right.
So, yeah.
Okay, real quick last question, and then we'll...
Quick question for Dr. Gandhi, that Termavir in CMV patients with frailty senescence, were those people viremic or just antibody positive?
They were antibody positive.
Okay.
Yeah. Some of them were shedding virus, but they weren't. I don't think any of them were viremic.
Correct.
Yeah.
Correct.
I don't think any.
OPMAN 33, a third of a century. My first OPMAN was OPMAN 3, so that tells you how old I am. So I would like to start by thanking the loyal in-person audience. We have 400 people at home. Your younger colleagues are watching this in their pajamas, or they are walking their dogs while looking at it on the phone. So again, I think that dates those of us who are actually here in person, but thank you for being here. So please scan the QR code if you're sitting at a table or if you're watching this from home, because I'm going to challenge the audience response system during my talk. So here are my disclosures. And here is audience response question number 1, if you are able to access. What is the longest interval between doses approved by the FDA for a long-acting drug designed to be given repeatedly? And your choices range from 2 weeks to 5 years. So let's go ahead and vote if you are able. Yes, here we go. Okay. So, interesting. The audience is thinking very short, 1 month or 2 months. Remember that cabotegravir rilpivirine is approved for every 2 months, so it's at least that. The correct answer is actually number 7, 3 years for long-acting etonogestrel implants. But globally, the answer is 5 years. The levonorgestrel implant is an every 5-year implant. It was never approved by the FDA, but it has been approved by the EMA, and it is used globally, especially in sub-Saharan Africa. So we are behind our colleagues in hormonal contraception when it comes to long-acting therapy. And today I'm going to try to answer the question of how long, oh Lord, how long for long-acting therapy? Okay, this is just the concentration time profile over 3 years for etonogestrel and levonorgestrel implants for hormonal contraception. Obviously, the technology has taken us to the point where we can do this, at least for hormonal contraceptives. And as I'll show you later in my talk, we're getting there for HIV. So that brings me to audience response question number 2. What's the longest interval between doses approved by the FDA for a long-acting drug designed to be used for HIV prevention? This is now in the prevention setting, and Dr. Landowitz is going to talk about this later this morning, but let's think about What's the prevention interval for drugs approved by the FDA for HIV? So let's vote on this. Okay, this is pretty good, actually. I thought you were going to say every 6 months, which is response number 4, and only, 32% of you said that. This is a bit of a trick question. People think of lenacapavir as being approved for HIV prevention, but it's not. Its approval target date for review is June. The application has been submitted, but it has not been reviewed yet. The assumption is that it will be approved, and I think Rafi will talk about that later. But the correct answer is number 3, every 2 months for cabotegravir. And the majority of the audience got that right. So give yourselves a pat on the back. The OPMAN audience is still cutting edge. Okay, this is, I pulled this slide from ancient history. This was the first CROI presentation of the pharmacokinetics of lenacapavir before it even had a name. And there's 2 important takeaway points from this slide to remind us that the pharmacokinetics of lenacapavir support its dosing every 6 months, which is how it's approved for treatment. But this was the only dose-ranging study of lenacapavir that was ever put into the public domain. If you vary the dose of lenacapavir from 30 to 450 milligrams on a log linear concentration time plot, and I'm sure you're all fascinated by that, the slope of the line over 6 months does not change, regardless of dose. So this is a drug that does not display dose linear pharmacokinetics within this range of doses. And that's very important when we get to the concept of whether or not we can give lenacapavir less often than once every 6 months. So keep in mind, this is a drug, regardless of the dose, at least within this dosing range, the apparent half-life does not change. And I want to remind you, there are other drugs out there that have apparent half-lives that would allow them to be given every 6 months or so. This is a dose-ranging study for VRC01-LS, one of these long-acting, broadly neutralizing antibodies, similar to the 3 that Dr. Gandhi discussed in his talk, and again showing that at least in the dose range from 5 to 40 milligrams, the slope of the log linear concentration time plot over 6 months does not change. So these are also drugs whose pharmacokinetics is not dose dependent, suggesting that we might be able to give a higher dose and give less frequently than once every 6 months. So that's pretty exciting, I think. So audience response question number 3. What is the longest interval between doses in humans for a long-acting drug designed to be used for HIV prevention or treatment and now published in the peer-reviewed literature? And again, same time range, 2 weeks to 5 years. Oh, you're so close, so close. The majority, 62%, said 6 months. 11% of you got the answer right. So you must be reading your Lancet every week, because the answer is 1 year now for this drug, lenacapavir. And this was data that was presented at CROI 2 weeks ago and published in Lancet on the same day as the presentation to avoid the CROI embargo. And these are data from that publication for the 89% of you who haven't seen it. So this is the pharmacokinetic profile of lenacapavir given once yearly in HIV seronegative volunteers. And this is interesting because the top box shows one new formulation of lenacapavir designed for less frequent administration, called scientifically enough Formulation 1. and the second formulation in box B, called, scientifically enough, formulation 2. I feel like I'm reading Dr. Seuss. But the top plot, the blue and the green, is the once yearly formulation with concentrations shown over 56 weeks. And the bottom plot in the orange is traditional every 6-month subcutaneous lenacapavir, showing that the once yearly injection in both cases achieves concentrations higher than the every 6-month lenacapavir and maintains concentrations far above the antiviral target, which is the protein-adjusted EC90, for over a year. So now we're starting to get into the range of dose frequency with an anti-HIV drug that is similar to what I showed you earlier with the contraceptive implants. Drugs that could be given once yearly or perhaps even less frequently. Because look how high the concentrations of lenacapavir still are at 56 weeks, and they're not falling very quickly. So we are entering a new era of possibilities for drug dosing for HIV drugs, at least with lenacapavir. And these are the comparative trough concentrations of these two new formulations of lenacapavir as compared to the traditional every 6-month formulation. Now, there's something very important that's pointed out in the legend of this figure, which is the large difference in doses between the once yearly formulation and the every 6-month formulation. The every 6-month formulation, as many of you probably know, is 927 milligrams every 6 months. How they came up with 927 milligrams, I don't know, but that's what it is. The dose for the once yearly formulation is 5,000 milligrams. 5 grams of drug given once a year. And we're going to talk about what that means for the patient. Yeah. What that means for the patient is very large volume injections, and lots of them, 5 of them, given at one time, subcutaneously. To my surprise, 100% of patients did not report injection site reactions. In fact, most patients seemed to tolerate these drugs with no hurt at all, was the response. It's healthy volunteers being paid to do this study, and maybe they thought that's what they were being paid to say. But my guess is when we start to give these formulations to patients, we're going to see nearly 100% hurt. And the reason I say that is one of the things they did to the lenacapavir formulation to allow it to be given once a year was they put ethanol in it. And I don't know if any of you have ever injected yourself or one of your patients accidentally with ethanol, perhaps through an ethanol swab, but it stings like crazy. So the formulation 1, which is on your right, had 5% ethanol, and formulation 2 had 10% ethanol, and perhaps not surprisingly, more injection site reactions, more pain with the higher ethanol formulation 2, than with the lower ethanol formulation 1. I guess if there's any good news in this figure, it's that if you iced the injection site prior to injection, as was done with formulation 2, you greatly reduced the pain at the injection site. So that, I think, gives us some insight into what we may be doing in the future to try to prevent this from happening in people getting once yearly lenacapavir.
So your alcohol should always come with ice.
Yes. Yes. The lenacapavir cocktail on the rocks, please. Yes. Rafi mentioned don't go driving after your injection, especially if they decide to give you a breathalyzer test. Okay. So this is the summary of once yearly lenacapavir. subcutaneous injection. The formulations are actually similar to the every 6-month formulation, but contain ethanol. The complete recipe for the formulation has not been published. The dose is substantially higher, 5,000 milligrams versus 927 milligrams. And the injection volume for the once yearly formulation is also substantially higher, 2 5-milliliter subcutaneous injections, which is incredible, a 5 ml subcutaneous injection versus 2 1.5 ml injections. Sorry, IM. Yeah, IM. It's still an incredible 5 ml intramuscular injection, trust me. Trough concentrations for the once yearly formulations are about 3-fold higher than the 6-monthly formulation, suggesting the possibility of using a reduced dose and a reduced injection volume, even when given once a year. So I guess hats off to Gilead for making sure this experiment was going to work. It was designed to assure that they would have concentrations above the target at a year. But I think, at least for prevention and probably for treatment, the concentrations are way higher than they need to be. And maybe that means we'll either give the same dose once every 2 years, or maybe we'll be able to reduce the injection dose and the injection volume. But here we are in the once yearly administration range. Okay, I want to point out that this is not the only once yearly ARV formulation that has been developed. This is a figure that was presented at CROI last year from a group at a company affiliated with the University of Nebraska, showing a dose-ranging study for a novel cabotegravir prodrug, a cabotegravir stearate, that was given, in this case, to rats, not to healthy volunteers. But again, no dose dependency of pharmacokinetics. This formulation has actually been licensed to ViiV Healthcare. So ViiV was interested enough in this that they have picked it up, and we may be seeing this formulation or something like it in humans very soon. So this is the possibility of a once yearly administration of cabotegravir, which is also very exciting. And there was also a novel formulation of bictegravir, a bictegravir dimer, that could potentially be given every 6 months or longer at a different dose. This was only a single dose used in this study, and this was in non-human primates, not in humans. But again, more activity looking at ways to give integrase inhibitors less often than once every 2 months. Okay, so that brings us to audience response question number 4. What is the estimated efficacy of lenacapavir given every 6 months to prevent HIV in randomized controlled prospective clinical trials? And Dr. Landovitz is going to talk about this, but we'll give you a preview. The estimated efficacy range in the prevention setting for every 6-month lenacapavir, is it somewhere between 25% all the way down to, is it greater than 95%? So let's vote. Awesome. The OPMAN audience, once again, is on target. So 76% of you already know that the efficacy of lenacapavir in the Purpose 1 study was 100%, and the efficacy in the Purpose 2 study was about 99%. So this is a drug that has, at least in 2 large randomized clinical trials, more than 99% efficacy in preventing HIV infection. This takes me to my next question. For comparison, what's the estimated efficacy of this year's trivalent influenza vaccine in preventing hospitalization? And same range, 25% to greater than 95%. And I think my colleague may be speaking about this. Okay. I think you are all as confused about this as your patients are. So the CDC has estimated that the protective efficacy of this year's trivalent vaccine for preventing hospitalization is 35%. Answer number 2. Most of you thought it was substantially more than that, and 8% of you thought it was greater than, or 6% of you thought it was greater than 95%. There's never been an influenza vaccine that has even come close to 95% protective efficacy. So the point of these two questions is to indicate to you that something revolutionary is happening. We now have an anti-HIV formulation. It's a small molecule. It's not a traditional vaccine. But it is more protective than almost any vaccine we have for any disease given once a year in clinical trials. So maybe we should stop thinking about lenacapavir as PrEP and start thinking about it as the HIV vaccine we are probably never going to have. And even when we have an HIV vaccine, I seriously doubt it will be this effective if given once a year. And the most effective HIV vaccine strategies involve multiple injections of something within a few months to get us to 30 or 40% protective efficacy. Why would we even be doing that? We already have an approved product with a formulation that can be given once a year to provide unbelievable protective efficacy against the acquisition of this infection. So maybe there was some reason why Dr. Sag paired me with a vaccine guy for this session. All right, so that's what I want to say about where we are with moving the bar forward for long-acting formulations. I want to finish with a concept that we don't usually talk about here, and that is trying to provide these marvelous, revolutionary drug formulations to places where most of the HIV infections are, in low and middle income countries. Still 90% of the world's infections and most of the new infections are in low and middle income countries. So I will tell you today, access to injectable cabotegravir, rilpivirine, and lenacapavir in low and middle income countries is terrible. And it is going to get worse because PEPFAR had promised to purchase 1 million doses of injectable cabotegravir, and now that is not going to happen. So I'm advancing automatically. I'm not exactly sure why. This was, we organized a workshop last September to try to find out what we could do to make long-acting injectables more affordable and more accessible for low and middle income countries, and what did we learn? So first of all, how much time elapses between marketing approval for a long-acting injectable innovator product to the first generic version of that product for any disease? What's the best that we have done in the past? Well, the best we have done is 10 years, and the range is as long as 17 years from the innovator product's approval to the first generic. So people are clamoring for generic cabotegravir and rilpivirine and eventually lenacapavir, and they want it yesterday. But if we're anything like any other drug that's ever been developed in the long-acting arena, it will be at least 10 years to get us there. And why is that? The best case scenario is anti-schizophrenics, paliperidone, and hormonal contraceptives. But again, minimum of 10 years from innovator approval to generic. And why is that? Well, this is a quote from René Holm, who's one of the world's experts on making long-acting formulations. He's at the University of Southern Denmark, but he was a participant in our conference, and he said this: if you know how to make one long-acting injectable formulation, you know how to make one long-acting injectable formulation. These formulations are all different, and they're all complicated. There's specialized equipment needed to make nanoformulations and particle suspensions. Batch-to-batch consistency can be tricky, and this cost cabotegravir and rilpivirine a year in their FDA approval because they could not convince the FDA that each batch was the same as the next. Excipients need to be acceptable to regulatory agencies. Every time you develop a new excipient, unless it's so-called generally regarded as safe, it requires the same kind of testing as a new drug. Injectable products have to be sterile, and this is not true for oral products. So approaches to product sterilization are different for different approaches to manufacturing, and that's, again, something that complicates the process and extends the amount of time it takes to show that you're actually making what you're trying to make. Takeaway number 3, if an innovator formulation requires an oral lead-in, then the generic formulation will as well. So right now, lenacapavir cannot be given without an oral lenacapavir lead-in. I would really call it a loading dose. It has very little effect on the pharmacokinetics of the injection, but it protects you during that period from the start of therapy until the injectable drugs concentrations are high enough to treat or prevent HIV. And what that means for a generic company is instead of being asked to make one generic formulation, they are now being asked to make 2 generic formulations, an oral formulation and an injectable formulation. So how are we going to get around that? Well, one solution is to try to obtain permission from the innovator for access to their oral product, hopefully at cost, since the market size for the oral product is likely to be so small that generic companies aren't going to be very interested in making it. The other possibility would be to say usually what makes generic drugs so inexpensive is competition. And so if multiple generic companies are making the injectable form, maybe you could designate one generic company as the one that makes the oral formulation, and they can sell it to everybody else. And then finally, you have to ask yourself why you need an oral formulation to begin with. If the oral formulation is a loading dose to prevent infection, why not use an approved oral antiretroviral combination in place of that? So why not use oral tenofovir, lamivudine, and dolutegravir, TLD, which is what we're using in most parts of the world, to protect against HIV infection until the cabotegravir or lenacapavir concentrations kick in? That would be way cheaper than asking generic companies to develop generic oral lenacapavir, for example. Finally, this is something I learned just in the last few months, and it's important and it's really interesting. Injectable solutions like lenacapavir are very different from nanosuspensions like cabotegravir and rilpivirine with respect to generic regulation. So there is a pathway to approval for generic lenacapavir that would require no human studies, 0. How is that possible? Well, there is a bio waiver for injectable solutions. And if you can prove to regulatory agencies that your chemistry and manufacturing control meet all requirements, and if you can prove that it's the same ingredient at the same concentration, given at the same dose, with the same excipients, with the same concentration, and administered in the same way, you can get approval for a generic product with 0 clinical studies. Because regulatory agencies assume that if you meet all of those manufacturing criteria, then you're going to achieve identical concentrations to the innovator. So lenacapavir, interestingly, could be brought to market as a generic drug very quickly. And that's unlike cabotegravir and rilpivirine, which would require not only the chemistry, manufacturing, and control data, but also a phase 1 human study. Actually, we learned that the minimum duration of a phase 1 clinical study for generic lenacapavir, for generic rilpivirine and cabotegravir is 15 months. And that's because the law states, at least the FDA law states, and I think the EMA laws are the same, for a generic product of any kind, you need to follow it out for 5 to 6 half-lives before it can be approved. So that's 15 months for lenacapavir. There is no generic company on the planet that will do a 15-month clinical study. So I think that's going to make it nearly impossible to produce generic versions of lenacapavir and cabotegravir and rilpivirine and these nanosuspension formulations as opposed to these injectable solutions like lenacapavir. Also recognizing that you would still need to do something about the oral formulation. So that was hopefully a little bit of consciousness raising about how we're going to get these wonderful life-saving drugs and vaccines, whatever you want to call them, to the rest of the world. Something to think about, big challenges ahead, but lots of excitement, and we are living in a changing world in oh so many ways. So thank you.
So we're very pleased to have David Spock here from University of Washington, who is one of the best educators that I know. He leads a number of programs at UW that reach out to the region in terms of clinical assessments and help online, but his materials through the UW resource site are just phenomenal. So, David, it's very happy to have you here, and welcome.
Great. Thanks, Mike. Thanks. Well, this is going to be a little bit of a shift because we've been focusing more on antiretrovirals. I'm going to switch to just vaccines. I love the discussion that was sort of the hot debate about hepatitis B. I'll try and weigh in, maybe raise a few more issues related to that. So I want to mention a couple things. I do not have any disclosures, but if you ever think about it, really, vaccines don't have generic names. So it is really hard to give a nice, crisp talk on vaccines and not use trade names or brand names, and people know what you're talking about. So I actually will be using trade names, which I generally never do, but it's only because it's really very hard to distinguish these in vaccines. That's the only reason I'm doing this. These are the 6 sort of issues I'm going to address. I'm going to start off with conjugate pneumococcal vaccine. You go, well, what's new about that? Well, there is a PCV21 now. Talk a little bit about meningococcal vaccine, pentavalent meningococcal vaccines. Do any of these prevent gonorrhea? Talk a little bit about hepatitis A vaccines. There's a lot to talk about hepatitis B, and maybe a new paradigm how we're thinking about what our goals are with hepatitis B immunization. Mpox vaccines. I want to underscore just to what Raj said earlier about how poorly we're doing with actual treatments right now with tecovirimat and Mpox, and how important it is to vaccinate people for Mpox, because we really don't have at least established proven therapies for Mpox, maybe other than some combination therapies that might be used. And last, I'll talk a little bit about RSV, a little bit about zoster vaccine, and what live vaccines to watch out for in your patients with HIV. And some of them are CD4 based, some of them are just in anybody. So the first thing is pneumococcal vaccine. So just so we're all on the same page, this is so much easier than it was when I started doing this. We had these complex dosing, had to do this wait 8 weeks, give it 5 years later, give it again at 65. The simple take-home point now is that if you use PCV20, it's one and done. And that's the take-home point. And I think this is what most clinics around the country are doing. It's conceptually really straightforward. If you don't have PCV20, or for cost reasons, whatever, you decide to go with PCV15, then you need to follow that at least 8 weeks later with a PPSV23. But everybody that I've talked to around the country predominantly is using PCV21 and done. So I think everybody, is probably very familiar with that in their practice. A couple of things, though, to point out that are subtle. This is just a graphic bar of the serotypes in PCV15 compared to 20. And you can see that everything that's in 15 is in 20. They're the exact same serotypes with 5 more additional serotypes that are new. So that's an important concept to get. These vaccines overlap tremendously. Okay, now what do you do, though, if someone has started their series, maybe they've been out of care for a while and they haven't gotten PCV20, and they've gotten a PCV13 dose, or maybe they've gotten that and a PPSV23. The recommendations for this in the OI guidelines have now also gotten very straightforward, and you have 2 options. You can do one and done again and give them just 1 dose of PCV20 as long as you've waited a year between the actual last PCV13. So I'm talking about somebody who's only had PCV13 now. I should have said that at first. Only PCV13. You can do one and done with PCV20, or if you want to really kind of be a martyr, you can go and complete the old schedule, as you can see on the bottom, which is very cumbersome, hard to get follow-up, poor accomplishment that actually happening in the real world in the clinic. So our clinic, we've taken the approach, anybody comes in, if they're incomplete, they got one PCV13, we wait at least a year, and we give them PCV20, and we're done. Okay, now what about if they are further along? They got a dose of PCV13 in green there, then they got another dose of another vaccine, the PPSV23, following our schedule. The bottom line again here is anywhere along the way, you can be one and done by giving them PCV20. Very straightforward approach. The only thing you need to remember as a clinician is that between the conjugate doses, you need to wait 1 year, but after polysaccharide, you need to wait 5 years. And that's based on some immunological studies of potential immunologic interference. It's not clear that that's really needed, but that is what's currently recommended. The only place where it's a little ambiguous, if you've got a patient in your clinic who's older than 65 and they've already finished that bottom row there, do you need to give them a PCV20? That's considered optional. You certainly can do it. Again, they'd have to be 70 years of age because you're going to need to wait at least 5 years after giving that last dose of PPSV23. So this is, again, a nice, straightforward approach. Most things in clinical practice seem to get a lot more complicated. This is great. And then for clinicians, it's really simple now. Okay, so what about PCV21? Quick raise of hands. How many people have given a dose of this? How many people have heard of it? Okay, good. So PCV21 is a new pneumococcal vaccine. It is in it's not in the actual OI guidelines now. They do mention it, but there's no recommendation to use this in the OI guidelines for people with HIV. So I just want to say I'm just introducing this, but I want to be clear, it's not actually in the OI guidelines. What I want to do is try to conceptually give you an idea. This is a very different serotype vaccine. So now look at these serotype bars and look at PCV21. It just doesn't line up hardly at all with PCV15 and PCV20. So this is truly very different, and that could have advantages. It could also have disadvantages. So those of you who have been following this probably know the one potential disadvantage is in serotype 4. So this is the one take-home point to know about PCV21. It does not have serotype 4 in it. So why is that important? If you look at the MMWR, really that talked about this vaccine and introduced it, they make this point and they illustrate these things. There are certain adult populations in the western United States where more than 30% of the invasive pneumococcal strains are serotype 4. So if you think of that, if you're living in the western United States and you're thinking your main goal is really to prevent invasive pneumococcal disease, that's a significant miss in terms of what you're missing on your vaccine serotypes. These are some of the epidemiologic and geographic risk factors, the mainly comorbid conditions, but the big one is mainly for people who are based on the western United States, that you may want to really think twice before giving this vaccine. And it's western and southwestern as well, too. So that's what's new about the pneumococcal vaccine. I think based on this, we're probably not going to see a move in the OI guidelines to really push this into first line, especially given how effective the PCV20 has been. Okay, now turning to meningococcal vaccine, and what are a couple of practical issues, and what do we do with this in terms of our patients ask us about, will this prevent gonorrhea for me? What can we tell them? Okay, so there's really 3 groups of meningococcal vaccine to try to keep straight. There's the conjugate quadrivalent vaccine, which is the regular vaccine that we're giving over and over again in the clinic. This is the one everybody's familiar with. For those of you that have been practicing a little bit longer, you may be familiar with Menactrol. That's what we used predominantly 5, 10, 15 years ago. It's no longer on the market. So now we only have 2 quadrivalent vaccines that are Menveo and Menquadfi. There's not probably any real significant difference in those. It is ideal if you start one, you try and finish the person or stay on the same vaccine if you can possibly. Stay on the same brand that you're using before. Meningococcal vaccine, and I should say quadrivalent meningococcal vaccine, are routinely recommended for our people with HIV. And I'll go over that in a little more detail. Meningococcal vaccines, that are B vaccines, as you all know, is really predominantly for older teenagers, young, late adolescents, college students where it's considered shared decision making in the general population. And it can be given. It's a safe vaccine. It's a relatively effective vaccine. It is just not really usually recommended on a routine basis. It is not a routine vaccine for people with HIV, but it can be given based on shared decision making in a younger adult. Not given to anybody certainly older than 23 or 24 years of age. There's no data for that. Now, if you look at meningococcal B vaccines, it's important to see there's two types. And this is where the gonorrhea issue comes up. Meningococcal B vaccine has some things in it that overlap with these outer membrane vesicles and outer proteins on Neisseria gonorrhea. It's not a stretch of the imagination, Neisseria meningitidis, Neisseria gonorrhea. There is some overlap that has only been seen with meningococcal B vaccine, not the quadrivalent. And there's only one of them where it overlaps, and I'll go over that in just a second. And it's the top one, the Vexero, the 4C. So when you get asked about this, and I'll come back to this, that it isn't all meningococcal vaccines that have any protection. And the protection against gonorrhea is moderate at best, but people are always looking for any additional risk reduction for acquiring gonorrhea. And that is the one vaccine that's been associated, at least that we have FDA approved in the U.S. Now, here's the confusion. We now have a pentavalent meningococcal vaccine that's mentioned in the OI guidelines now. That is called Pangrea, and that has the standard quadrivalent, and it also has meningococcal B in it. So the question I keep getting asked is, well, now that we've got this pentavalent, could we use this and also get the benefit of reducing gonorrhea risk? Here's the issue. The standard recommendation right now is not to give the pentavalent, but to give the quadrivalent vaccine. And you all know there's an initial primary vaccine where you give 2 doses of it, at least 8 weeks apart. It is recommended that you give this vaccine every 5 years. I would, say how many people routinely do this? Let me just ask you a show of hands. How many people would say they routinely give every 5 years for their patient? Raise your hand. Okay, so it's mixed. And that's probably what I would say in our clinic as well. This is one of the vaccines, if you look at it, I would say in terms of implementation, there's a lot lower implementation, which I bet if I asked how many people give PCV20, it'd be everybody. So this is, and it's just because most people have not seen a lot of invasive meningococcal disease. There is increase to people with HIV, but the overall rate is low. So we don't see this as a high uptake compared to some other vaccines. Okay, now, and I'll come back to the gonorrhea issue in a second. So one of the questions, and this data doesn't get talked a lot about, but there was a study done more than 10 years ago where they looked at the response
of a standard quadrivalent meningococcal vaccine, the one that we're given all the time in the clinic. Based on CD4 percentages, it was very interesting that you look at early response, seroprotective response, 28-week and 72 weeks, and across the board, the seroprotective responses were much better in people that had higher CD4 counts. So I do want to make sure people know that when you're giving this and people are newly diagnosed and they have a really low CD4 count, you have a much lower response rate with that. And some people, some experts, they mentioned this in the guidelines now. This wasn't mentioned until very recently. Some experts now say at least consider getting them on antiretroviral therapy, getting them virologically suppressed, maybe letting their CD4 count bump up a little bit before actually giving them those first 2 doses of meningococcal vaccines. Just to clarify, the guidelines do not say to delay it. I'm just saying based on this data, I usually wait a little while. And also in my priority list of vaccines, meningococcal vaccine is not at the top of my list. And so by the time we get to it, it's usually 3-6 months in, and most people are virologically suppressed at that point on newer integrase-based regimens. Okay, so now back to this question about which meningococcal vaccine may have some protection in gonorrhea. This is could be a whole talk. It's very, controversial. It's very interesting. There's a lot of speculation about exactly what cross immunity you need. But what is available based on all the studies is that this particular vaccine, the MenB, the Bexero, does have some cross protection in preventing gonorrhea. So if you have a patient and they really want this, this is the only vaccine out there that may provide some cross protection with Neisseria gonorrhea. The important point is that the pentavalent, a lot of people sort of assume, because it's got meningococcal B in it, it's going to be providing the protection against gonorrhea. But note, the actual vaccine that's in there is the second one, the FHBP, which is the Tremembel, which has never been shown to have any protection against gonorrhea. So if you're going to try to go that route, you've really got to specifically use the meninge B vaccine that is the Bexsero. Okay, now let me switch to hepatitis A. So there's 3 vaccines available for hepatitis A, the Havrix, the Vacta, and the Twinrix. And I'm going to make the argument that in people with HIV, I don't think we should be using Twinrix. And I will give you the argument why in just a minute. But it is available, and it's very convenient. But I'd like to give you, I think, a pretty compelling argument why I think that is in the guidelines as an option, but I don't think it should be, in my opinion. Okay, so one of the questions that comes up, and this was great, we had some discussion in the Q&A earlier about serologic monitoring and follow-up after people get immunized. So, with B, we know, everybody said, we're all checking titers after people get B, but do you check a titer after somebody gets hepatitis A vaccine? So when I ask this question, most of the fellows and the residents who are in the clinic, they go, no. But actually, the guidelines recommend yes, because there are reduced responses in people with HIV. In the general population, in your practice, if you're giving hepatitis A vaccine to some healthy individual who has an indication, you do not need to do, or it's not recommended to do a post-vaccine titer. But with people with HIV, the recommendation is check a titer 1 to 2 months after. Now, the interesting thing is, what do you do if they don't respond? Because we talk all the time about Hep B. What do we do if they don't respond? What do you do if they don't respond to Hep A? So the guidelines actually give us very specific recommendations what to do. And it's based on their CD4 count. So if you have somebody, you gave them their 2 doses of Hep A, at least 6 months apart, and they didn't respond, but their CD4 count's greater than 200, the recommendation is go ahead and give them another dose. Give them a 3rd dose. If their CD4 count's less than the 200, the idea is wait, assuming that you're going to be able to get their CD4 count up, and start all over again. So there's a difference. Above 200, 1 more, less than 200, start all over again after they've gone up to 200. We all have people in our practice who are stuck that did not get good immunologic recovery, and I think most people would say there isn't anything in the guidance. Most people that I've talked to in my own practice and those people, if you know they're stuck, I would just re-immunize them again. I think we're all wanting, the future of some sort of like CpG 1018 adjuvant that could be added on to Hep A that would give us these great serologic responses like we're getting with B, but right now we don't have any other sort of tricks up our sleeve with people with Hep A other than to try to vaccinate them again. Okay, so one of the questions, and now that I brought this issue up, that people under 200 don't respond as well, should you defer if somebody comes in, they've got a CD4 count of 100, they're newly diagnosed, and the OI guidelines actually give us some direction on this from a practical standpoint. So the answer is maybe. It depends on their risk for actually acquiring hepatitis A. So if their CD4 count's above 200, there's no reason to wait. You just go ahead and give them the Hep A vaccine series, and then check a titer again 1 to 2 months later. However, on the bar out to your right, if the CD4 count's less than 200, you have 2 options. You could just go ahead and say if they've got ongoing risk for hepatitis A, you're just going to do it. You know it may not work, but you're going to check a titer, and if it doesn't work, you're going to do it all over again. And that's a very reasonable approach. If they don't seem to have any active risk for hepatitis A, it's considered acceptable that you could either just give it or you could wait till their CD4 count gets above 200. So you do have a couple options there. All right, so now what about hepatitis B vaccine? I'm sure there's going to be, and I'd love to have more comments and questions to be brought up about this. I'll give you my own take on this and kind of an offshoot of some of the comments that Raj made and some of the comments that others made as well. I think we may be thinking about hepatitis B vaccine very differently in people with HIV now than we were 10 years ago for 2 reasons. Number one, with many people considering going on long-acting injectables that are not going to be on TDF or TAF, the issue is really very relevant now. So I think a lot of people maybe where we at least we think sort of if they're taking TDF or TAF, they're probably protected. So I think this issue is going to be different. I think we're also learning more about it. May be the level of serologic response may matter. So it's not just achieving immunologic response. It may be maintaining immunologic response that we start to re-examine the issue. And back to the question that came up about people who have titers that go down and then get hepatitis B after that. We had 2 patients in our clinic that were presented, or in our echo cohort, that were presented to us in the last year that were this exact same scenario. And I had not seen it before, and I didn't believe it. We made them go back and get the records and send them to us. And sure enough, these were people that had prior Hep B antibody titers greater than 10, like 5, 7, 10 years ago. They declined, and they got acute hepatitis B. So I have seen this. I think it's real, and I think that's why this issue is coming up. Okay, so where are we now with hepatitis B vaccine? Just to step back and review what's in the guidance right now, and to review what's conceptually different. So our old hepatitis B vaccines are the aluminum adjuvant. Both vaccines, and then the new hepatitis B vaccine, I should say, is the CpG 1018 adjuvant. So if you look at the old vaccine and the new one, they're both the same surface antigen. You're still using a single antigen hepatitis B vaccine. What's different is the adjuvant. And you should think of the adjuvant as more like something that alarms the immune system to respond better to the antigen that you're presenting. So it is very important to understand probably what makes HEPLISAV-B so special is the CpG 1018 adjuvant, which is an oligonucleotide that codes inside the cell for basically activating toll-like receptors. So it's a very clever way of activating some of the cells that may upregulate to respond to this vaccine. And that's what really makes HEPLISAV-B so special. Okay, now what is in the guidance? And this is very different than it was 3 or 4 years ago. HEPLISAV-B went from, oh, maybe we know about it, then it went to, oh, it's an alternative, to, oh, we could use it, and now it is the thing. So if you look at the guidance now, it's very clear in the OI guidelines, HEPLISAV-B is the preferred vaccine. So the wording on all the old vaccines are, oh yeah, not that they're equivalent, but now the wording is only use those if you can't get HEPLISAV-B. And I think that's reflective of how good the data is with HEPLISAV-B, both in naive and in people who failed previously. So if you don't have HEPLISAV-B, you're not using that for cost reasons or formulary reasons, it's important to know that the old aluminum adjuvant Engerix-B and Recombavax, you're supposed to use double dose of that vaccine. So Engerix-B, Recombavax, double dose if you're using it. HEPLISAV-B, you use standard dose, 2 doses 1 month apart. And there are some experts that say maybe give 3 shots with naive, but in the guidelines, they only recommend at present, as of December, giving 2 doses of HEPLISAV-B for vaccine Hep B naive susceptible individuals 1 month apart. Okay, so it's much more convenient. It's much more effective. We've gone to this 100% in our clinic for all of our patients for Hep B immunization. Now, why did I say Twinrix, in my opinion, is it's in the guidance as an alternative, but I don't think we should be using it, and I'll give you 2 reasons. The first reason is, number one, if you're using Twinrix, you're using essentially Engerix-B, which is not as good as HEPLISAV-B. So that's the first reason. The second reason, if you're using Twinrix, it is a fixed dose combination, and it's only single strength, single dose Engerix-B. So you're doing 2 things. You're not giving the preferred vaccine, and if you're giving the alternative, you're not giving the double dose that's recommended. So for those reasons, I think we really should be vaccinating people with HEPLISAV-B and hepatitis A vaccines separately. And I know this is in the guidance, but I to this day don't understand why it's still there, because those 2 are just discordant to have a double dose recommendation, to have a Twinrix, which only has single strength, single amount. And we don't ever give 2 doses of Twinrix at the same time, because then you're giving an unnecessary amount of Hep A vaccine. Okay, just to briefly review, and Raj mentioned some of this longer term data, but back to this study that he was mentioning, by Dr. Marks, who presented this, and this has been published now in both CID, and then the follow-up's been published in JAMA. But this was a really well-done study called the Beehive study, which I think was really a practical study that all of us were thinking about in the clinic all the time. What do we do with the best, how do we get a better vaccine responses than we're getting? Could Heplisav-B do that for us? And then what can we do for people who don't respond to vaccine? So the study had 2 parts. Part B is actually the naive. Part B used 3 doses of Heplisav-B. So some people, when they first saw this, said, oh, the Beehive used 3 doses of Heplisav-B. That's not going to tell us what we really want to know. Could we give 2 doses and get a good response in our patients? So actually, I think the study answered the question beautifully. So here's the serologic responses after the first 2 doses, and then the 3rd dose was given at 24 weeks. So the people that came in at 24 weeks had their blood drawn on that same day. And you could see before they got that 3rd shot, 99% of them had a seroprotective response. And as Raj said, 28 weeks, they're 100%. So this vaccine gives extremely high responses. Now, I didn't put the slides in because I didn't know the discussion was going to go this direction. But really interesting, if you go back and you look at these, Dr. Marks breaks this out in the article and shows you, like with the Heplisav-B, how high a percentage of these people get titers above 100 and above 1,000. That's the thing that I think makes Heplisav-B so unique, and it's back to this question about durability of vaccine. And Heplisav-B not only gives you a higher percentage of serologic response, it gives you a much higher number of people that get very high titers, which I think is going to turn out to be, in the long run, relevant when we look at these issues. So what do you do when somebody doesn't respond to hepatitis B vaccine? So Raj mentioned the data on this, and I just want to reiterate this again, what the study. This is the other part of the Beehive, and they were published separately. So this is the recommendations now and the guidance, and I'll show you the study, and the recommendations are based on that. So in your clinic, if you have somebody that doesn't respond to the old vaccines we did, Engerix-B or Recombavax, you can give them 2 or 3 doses of Heplisav-B. I will show you the data why you may want to think about 3 doses versus 2. But if you give them 2, you're still going to do really well. So that's the bottom line. We do much better than we were doing in the past, which is doing all this over again or giving them 4 doses of it or whatever. I never had much success with that. Anecdotally, for those of you who actually, want to know about healthcare workers who don't respond, there's data with Heplisav-B and healthcare worker non-responders that looks great as well, too. So it's just a better vaccine with much better immune responses. Okay, so here's the overall design, what they looked at. So there were Heplisav-B was given either 2 doses or 3 doses, 2 doses in the top green, 3 with the purple, and it was compared with standard dose Engerix-B. That's the only downside, I would say, of the study. It would have been nice if they'd used double dose for that, but my understanding was that it was standard dose. The yellow there is just telling you when they did the blood check for seroprotective responses. So here's the punchline, what they saw. Heplisav-B 2 doses, basically more than 90% of people got a really good serologic response. And if you gave them 3 doses, you're almost at 100%. So the response rates were great. And Engerix-B was a reasonable response. That's higher than what we've seen generally. And I think it's because they had pretty high CD4 counts of the people. And I think we really want to know the litmus test that, in the clinic, even all of our patients, lower CD4 count, how would this work? Here's the one piece of the data that I think, if you look at it, these are people who actually got a titer greater than 1,000. So this kind of came up earlier, and what about if you get people up really high? Aren't they going to maintain serologic titers longer? Yes. So with 3 doses, look at that, 78% got a titer above 1,000, and notice that was dramatically better than 2. So can you get serologic protective responses with 2? Can you achieve that in non-responders? Absolutely yes. We don't know how long they'll maintain that, and I think that was part of Raj's comments and from the study at Croy, is that this data is going to be really interesting to see with these 3 doses. Are these people going to hang on to titers a lot longer? So just to then get to the one sort of place where we don't know what to do. If you give somebody Heplisab B and they don't respond to 2 doses, the recommendation is go ahead and give them a 3rd dose. If they don't respond to that, we're kind of out of luck. There was a triple antigen hepatitis B vaccine, Prehebrio, that was on the market for a while. It's off now, so we actually really probably don't have great options in these individuals right now. Okay, so how do you manage isolated core? I'll tell you what's in the guidance, and I'll tell you what I would do. And what I'll tell you that I would do is actually what Raj said a little while ago. The guidance actually says this, and there's one really important point in the guidance, though. If you have somebody with isolated core, surface antigen negative, core antibody positive, surface antibody negative. The guidance says give them a standard dose of any vaccine. And I checked this again yesterday. That's exact wording in it. Standard dose of any vaccine. I'm not saying it's the right recommendation. That's what it says. Then it says check a titer in 1 to 2 months. There's no mention in the guidance about doing hepatitis B DNA, and some experts, especially a lot of hepatologists, do recommend that, but this is what the guidance says. Give them a dose, check a titer. Here's the thing to know. There is a different threshold for isolated core in all the guidance, and it's 100, not 10. So when you're doing your regular serologic seroprotective response, the cutoff is 10. And the guidance, they use this based on 2 French studies, and it kind of gets back to that higher titer may actually matter. There's something unique about people with core antibody positive where they don't hold on to their surface antibody as well. So the guidance is if they go above 100, you're good to go. If they're less than 100, what they say then is finish out the series. That's what the guidance says. I will tell you what I'm now doing in my practice. If I see somebody with isolated core, I'm just giving them 2 doses of Heplisab B and then checking a titer and maybe give them a 3rd dose after that. And I think these people, for sure, you want to get above 100, and maybe even getting them above 1,000 may also be a really nice goal. Because the people with core antibody, they're a little bit different in terms of losing their seroprotective response. And the reason this 100 is not just pulled out of thin air, this is what the guidance cites back. It was a study published in JID in 2016. And basically, in a French study, if you didn't get above 100, you basically were right back down to 0 or under 10 very soon in a large percentage of people. So they saw in this study that to get a high percentage of people protected 2 years later, they needed to get above 100. And that's that. Okay, so now let me just shift gears and talk a little bit about Mpox vaccine. Again, this is really important now because our therapeutics are limited. And everybody probably is very familiar with using Jynneos. I just want to make the point that sometimes it's confusing because Jynneos is a live vaccine. So we talk about, we don't want to give people with HIV live vaccines who have low CD4 count. It's a live vaccine, but it's non-replicating. So it does not pose any danger to our patients. The ACAM 2000 is live and replicating. So you absolutely do not want to give ACAM 2000. So just to make sure there's no confusion about it, you can't just say give the live vaccine, don't give the live vaccine to people with HIV. Jynneos is live, it's just non-replicating. So when we talk about Mpox vaccine, really we're always talking about Jynneos. So the recommendations are Jynneos, give it at least 28 days apart. And you do need 2 doses. Seroprotective responses with 2 doses are definitely better than with 1 dose. Although you do get some protection even early with that, right after that first dose. So here are the 3 questions that always come up about the Jynneos vaccine. Do you give Jynneos to someone who's previously had Mpox? Do you give Jynneos boosters? And number 3, do you give Jynneos to someone who said they got smallpox vaccine as a child? Those are the 3 questions that we have in the clinic over and over again that come up. Here's the answers to those based on CDC guidance. So do you give it to someone who's previously diagnosed with Mpox? The standard answer is no. But as Raj mentioned earlier, there are some people that do get Mpox who've been previously infected. So it's a small percentage, but that could be with shared decision-making, somebody with very high risk, ongoing Mpox outbreak, you may want to consider it. But the standard party line is no. Now, same thing for booster. Right now, there's no formal recommendation. The European approach is a little different, but right now in the U.S., there's not a recommendation to give booster doses for Jynneos. And then the third thing is, can you give Jynneos to someone who got smallpox vaccine? The answer to that is absolutely yes, as long as the smallpox vaccine was more than 10 years ago, which many people, typically, it was stopped in 1972, which is the dry vax, which is the one I got when I was a kid, that they jab you in the arm about 10 times and then say, did you get a take? That was stopped in 72. So most people, that's not going to be an issue. Now, the last question about Jynneos is, can you use it for post-exposure prophylaxis? The answer to that is yes. So here's the thing, though. Timing is everything. So based on available data and guidance, it appears that if you give the Jynneos within 4 days after the exposure, you have a pretty good chance of preventing actual infection. If you're past that time, you're 5, 7, 8 days, you may modify the disease, but you're probably not going to prevent the infection. And if you're more than 14 days, you're probably not going to have any impact at all. So the take-home point from this, if you can, if you're going to use it for post-exposure prophylaxis, try and give it within 4 days of the exposure. Okay, quickly kind of going through the last issues of the last group of vaccines. Zoster vaccine. This is now routine. I think everybody knows that we're giving this to all adult patients with HIV, and this is great. This one does get overlooked a lot, and I think it's something to step back and make sure that you are doing this. And the couple of things that come up about this is, if somebody's had zoster before, can you give it? Absolutely yes. People can get zoster many times. What if they've had previous Zostavax, the old vaccine? Absolutely yes. There's data actually that people respond very well to this, even if they've had Zostavax. And the third is, do you need to adjust on CD4 count? The answer is no. You can give this vaccine at any CD4 count. I will warn you, you all have probably seen it, that a lot of people do get, not say a lot, but some people definitely get a real vaccine reaction to this and feel pretty sick for a day or two. So I try to tell people to do it on a day that they don't have to do something important the next day. RSV for people with HIV, we're just seeing this filter into the guidelines in December, and there are recommendations now. There are 3 different types of RSV vaccines, and some of you may not know that there's now an mRNA RSV vaccine. There's the subunit vaccines that have been out for a while, but there was just recently an mRNA vaccine for RSV that was mentioned. So who is out there for that we should be recommending? The guidelines basically kind of go down the 3 groups. Anybody 75 years of age and older should get RSV vaccine. 60 to 74 if they have comorbid conditions. So low CD4 count, other major comorbid conditions, RSV vaccine is recommended. The third is if you have any pregnant patients who are at a stage where you see them between September and January at weeks 32 to 36 gestation. That's the time period where there's the highest value in immunizing them, and that has to do with sort of maximizing their ability to pass on immunity to their child as well. Okay, the last thing to mention is live vaccines. This comes up a lot. Which ones do we need to step back and think about in the clinic? So I'll tell you what the guidelines say, and I know there may be some questions about measles, and Joe and I were talking about this earlier. The guidelines actually say for these vaccines, you should not give if the CD4 count's less than 200, and that's MMR. That's the chickenpox vaccine. That's the yellow fever vaccine. And I will say that, I think some people are, very expert and know a lot about immune responses and people that have long-term viral suppression. They may modify this, but this is what's in the guidance right now. There's certain vaccines that are not recommended to give to anybody with HIV. Flu mist, which is popular for children, really we don't see it much use in adults. That's an influenza vaccine. The smallpox vaccine, ACAM 2000 I mentioned, that's out. That's a no-no for people with HIV. Live oral polio and live attenuated oral typhoid. There are other IM injections that you can use for that. You don't need to use those for people with HIV. So in summary then, I just tried to hit a couple highlights for these 6 sort of issues related to that, and hopefully that's a little bit of perspective on the new sort of recommendations for pneumococcal vaccines, what we know about meningococcal vaccines, and separating out which ones actually probably or should be used and recommended and don't provide any benefit for gonorrhea. Hepatitis A and B, there's issues related to serologic follow-up, and B is very complicated. And then again, just to emphasize, try to get your patients vaccinated for Mpox because I think given the limited therapeutics. Okay, I'll stop there and thank you.
So I will start with a pneumococcal comment that a personal thing. My brother-in-law, 73, about 4 weeks ago, developed pneumococcal sepsis meningitis, and I get a phone call from the ER, and he had had a prior old vaccine 12 years before. He has no immune compromises, IgGs, whatever. Happy to report he was treated appropriately very quickly, and he's had a full recovery. But that is a bad disease. Yeah. I mean, that can kill you in 6 hours, and he was treated within 3 with steroids and ceftriaxone, so that makes a big difference. So,
and there really are data too in people with HIV. The risk of invasive disease is significantly elevated compared to people without HIV.
Really bad disease. Yeah. Let's go to the microphone. Yeah.
Hi, this is Mickey from Hopkins. Just the question on the
Turn it up a little. Tilt it up so we can hear you. Thank you.
Just a question on the varicella vaccine, the 19-year-old and above. It's quite a bit of expense in a lot of organizations to give the vaccine, less than 50, especially FQHCs, because a lot of people have Medicaid. So my question was around that I wrote down that when we look at the varicella vaccine when it was approved in 1995, and anyone, if they were vaccinated against varicella and did not get infected with chickenpox, right, do they still need to get the Shingrix vaccine? Because how can they get a reactivation, logically speaking, if, they didn't have that infection? Second is if we do, is testing for VZV antibodies an option still? Because if someone is negative for VZV, shouldn't they get the chickenpox vaccine after the Shingrix anyway?
Great. I love this question. So there is a couple of issues. A lot of children who got 1 dose of varicella vaccine were not considered immune, so recommendations later changed to give 2 doses. As a reminder, varicella vaccine is a live vaccine where people actually get dissemination of varicella at the time they get vaccine. We don't know a lot yet about the risk of zoster after varicella vaccine. So I think your question is really centered around, do we need to give people shingles vaccine who only had varicella vaccine because it is not a true chickenpox infection? And the answer to that, to the best of my knowledge, there's no formal recommendation on that. And part of it is because people, the generation that's been immunized against varicella is still really young. So we just don't have enough data to know whether or not there will be a significant amount of zoster or shingles, and will it be really different than with true live, real, clinical infection with chickenpox. So I don't know the answer to what we should be doing in people with HIV. I would say this, though, that the zoster vaccine that we use now, the Shingrix, is very safe. There's no live virus in it. And I don't think there's a lot of downside to giving it other than a person feeling bad for a day or so. So I think when in doubt, I would still give it to people with HIV. And the general community, we don't know the answer because all those individuals have not gotten to that 50-year age group yet. But in people with HIV, I would probably err on the conservative side, even if they never had true clinical chickenpox infection. And there's no formal guidance that I've seen in that, unless somebody else knows.
Hot topic of measles. So I take care of a large group of HIV-infected patients that are my age or older. And they have had their initial measles MMR when they were young, but now everyone's asking about what should we do. And the question I have is, those, as healthcare workers, my age group got a second shot, and many of my patients haven't. So the question is, do we just check titers? They all have high CD4 cell counts. Should we just give another MMR? What are you guys doing clinically?
Perfect question, and very timely. And when we submitted all these slides, it was really before the measles outbreak, so I didn't focus on this, but I'm really glad you're asking the question. I'm glad Joe's at the podium because we were just talking about this earlier, and he was telling me actually just this week he checked measles titer on several of his patients. So I'm going to let him comment in just a second. I can tell you that right now, the guidance in the OI guidelines were last updated in December 24. So they have not addressed this yet. So we don't have a formal guidance from HHS on this, and because of everything, the way things are going on with guidelines right now and things being on hold, I don't know that we're going to get a quick answer to this. The CDC has not come out with a formal recommendation. A couple of key points, and I'll let Joe give his 2 cents on this, so I think it's really very important. They're the people, the highest ones for you to worry about are anybody who got a vaccine, and this is a general population, anybody that got vaccinated between 63 and 69. That was not a good vaccine. It was not the same type of measles vaccine that was given later. Anybody vaccinated after that, before 1980, got only 1 dose instead of 2 doses, and they're probably protected over 90%, but not in that upper 90% range and where we would say. The other thing is, we haven't been, these are all sort of like, we haven't been challenged as a country and a community to really know. So I think you could default, and kind of Joe may take this approach, that we don't really know that people who got it in childhood are still protected, but you definitely can check titers. And the only thing I want to make a point on the titers is that if you're going and you're looking up measles titers in old records, it's variola. So a lot of times people get confused about that. They're looking or they're searching for measles. Sometimes the labs will report it only as a variola titer, and you have to look it up that way. Rubiola, I'm sorry, rubiola, I'm not variola. Rubiola, sorry, thank you. So anyway, so I think the bottom line is, I think then the last factor is, what's the likelihood that measles is actually impacting your community? And if, you're in Texas right now, it's probably higher than maybe if you're in some other states. So I think we will see probably more formal recommendations on this. I think if you are screening and testing your patients right now for titers, I think that's very reasonable. And I'll let Joe maybe add in too, because I know he started doing this. And maybe Mike too, if you want to add in too.
I was going to say, my patients are like your patients, I bet. They're in that same age that you talked about, between, vaccinated in the 60s. And so I'm checking titers. But I don't know, maybe we should just vaccinate people. I'm not sure.
And what titer would you panic over and say you need
Well, they just give you positive or negative.
Yeah.
Okay. As I understand it,
So what we're weighing out, because there is no guidance yet, but what we're weighing out is the risk of active measles versus the risk of a vaccine, an extra vaccine. And it seems to me, if you're living in an area like Southwest Texas or some area where it's exploding now, it seems to me there's less harm in just giving a single vaccine and moving on. I think what we forget is that 1 out of 1,000 people who get measles gets a bad case of measles and can die. I mean, it's really a bad disease, especially for an adult. And so I would err on the side of over-vaccinating, especially at the outbreaks emerging. We don't know what to do about healthcare workers yet. I suspect if you're working in an area where this is rising, your HR department or whatever, your hospital is going to recommend that you get a vaccine.
I'll also just say measles in people with HIV is bad. So it's in the general population, it's a bad disease. And people with HIV, it's a really bad disease. So that's why I think a lot of people are really concerned about this issue.
I wouldn't be surprised. I mean, I think even in this environment, we're going to probably hear guidance in the next month because this is starting. Yeah, I hope so. This is a good topic.
So just to add to that, David showed the recommendations to not give the MMR vaccine in people with a CD4 count of less than 200 because it's a live vaccine. I think that recommendation was made out of an abundance of caution. Correct. If I had an HIV-infected patient with a CD4 count of less than 200 in Southwest Texas who, had the usual history of not being vaccinated since the 1960s, I would definitely go ahead and vaccinate that person. I think there's no evidence that live vaccine disseminates an immunocompromised host.
Once they're suppressed, I think.
Yes.
How long do you have to wait after you start antiretroviral therapy for an immune reconstitution syndrome? Do you have to wait till the CD4 is greater than? Yeah. No, you can have one in a week. You can have one.
Well,
viremia is an immune suppressant.
Correct.
All the studies that base it on 200 are based on 200 and viremia. All those studies.
Yeah, I'm glad you said. I was about to say the same thing. That remember that the cause of immunosuppression in HIV disease is the virus, not the CD4 count. CD4 count was just an epidemiologic thing that we used to track risk of relative opportunistic infections. The virus is the enemy. If they're suppressed, even if their CD4 count is low, then I don't think you have to worry about the CD4 count as a metric.
And we've learned that from OI prophylaxis with pneumocystis. That's kind of the classic where, probably even, we use a cutoff of 100 if they're biologically, probably even lower.
Right.
They probably won't get it if they're biologically suppressed. So these are great points.
Follow up?
Yeah, well, I didn't realize I was going to engender such a long conversation. This has bothered me my entire career, David, if you can answer it. Why? So when we first started vaccinating with Shingrix, I actually called the CDC. I was amazed that it was efficacious in patients that actually had an episode of zoster.
Yeah.
So they had natural infection, and yet you give them a vaccine and it was efficacious. So immunologically, why does that happen?
So I don't know the answer to that, but two things just to mention. I'm glad you bring this up. You shouldn't give the shingles vaccine in the midst of an outbreak of shingles because there's kind of immunological interference where you don't get as good response. But it is fascinating why people do that, because you would think with natural response to shingles, you would get the best immunity. There's something about, and I actually think it may have to do with the adjuvant that's in the vaccine, because that is also an adjuvant with this ASO adjuvant that is a very potent and that's the only speculation I've heard, but I love the question because I've thought about that myself and wondered about it too.
So Charlie, I have two questions for you. One, going back to your lenacapavir 1 year data, and pulling the old historical data from whatever it was, 2011, the slope of the curve is parallel and flat regardless of the dose. Is that because there's less metabolism or elimination of the drug, or is it because of slow release?
Yeah, so we didn't talk about this. We talked about it last year, for those of you who heard my talk last year. So the pharmacokinetics of a long-acting injectable depot is characterized by something called flip-flop pharmacokinetics, which is a term that I hate because it implies that clearance happens before distribution. But basically, what flip-flop pharmacokinetics means is that the rate-limiting step in determining systemic concentrations of the drug is not clearance. It's absorption, or the release rate of the drug from the depot. So, because that absorption rate is so much lower than the elimination rate, that is what's determining how much drug is in the systemic compartment, so to speak, as determined by plasma concentrations over time. So, so that's all good and fine, but there's still this principle of physics, which is that once the depot is depleted, the concentrations are going to drop. And one thing we did not talk about is, even though that curve still looks like it's relatively flat at the end of the year, and even though the concentrations are still quite high, at some point the depot is going to be depleted and the concentration is going to drop. We just don't know where that point is yet.
And that was so evident in the later slide you showed. I think it was Cabo, where it just suddenly drops off.
That was the bictegravir dimer.
Yeah, so that's a great point. And I'm showing my age a little bit, but I remember one of the...
What about if you give someone that with cabotegravir or lenacapavir, and you give them rifampin? What happens to that?
So the question is, for those at home, the question was, if you give rifampin while there's long-acting depot release.
So that is a fascinating question, Joe. So this is a study that needs to be done to confirm. But every pharmacokinetic model, including models I've done myself, suggests that will be bad news for the formulation. That will, because then your clearance rate is going to begin to approach your release rate from the depot.
So
but interestingly, though there is a recommendation, there's a warning in every package insert, cabotegravir, rilpivirine, lenacapavir, to not give rifamycins with those drugs. That's in the case of cabotegravir, and rilpivirine, that's based on combination studies in humans with the oral formulation of drug. There, as far as I'm aware, has never been a clinical study in someone who's received the injectable form of any of those three drugs.
So it's a data gap we need to fill. Just a reality check for me, sorry, but for some reason when I heard you say flip-flop, I flashed to one of the national political conventions when they accused them, and they had all those flip-flops that they were waving in there. Anybody remember that?
Of course.
Yes.
Good. All right, it wasn't just me.
That was Mitt Romney's campaign.
Yeah, that was a flip-flop. Okay, here we go. So the same type of question, Charlie. You mentioned about all these different depots and 5 cc's in the butt 5 times or whatever it is. What about implants? You talked about that several years ago. And do you think that we might just go away from injections and just putting implants? And the other advantage, the disadvantage, you have to have a minor surgical, not that big a deal, but you have to do it. But the good news is you could remove it if there was a toxicity. So do you think that your prediction, implants will ultimately replace injections at some point?
I don't know the answer to that, Mike. All I can tell you is there's no pharmaceutical company developing an HIV implant right now, unfortunately. Merck tried to develop an islatravir implant. It looked like, I mean, that implant was only given to HIV seronegative volunteers, and those data were presented at the IAS meeting in Mexico City, which was like, 4 years ago? And no, longer than that, because that was the week my granddaughter was born. So that was almost 6 years ago. But, those data showed that at the end of 12 weeks, the curve was flat for islatravir. And there was essentially no toxicity, and they removed the implant and the concentrations dropped. And the modeling data suggested that same implant could have delivered effective concentrations of islatravir for a year. But because of the issues with islatravir lymphopenia, the implant program was terminated, and as far as I know, it's not being revived. There was a clinical study of a TAF implant that was presented at CROI last year from the Caprisa group in South Africa. And that was an implant that was essentially pure TAF in a silicone sleeve, which is a great idea. And the pharmacokinetics over a year looked brilliant if you could tolerate the implant. But 3/4 of the women who got 2 implants begged to have it removed because the local toxicity was so bad. So it's going to depend upon the nature of the chemical or chemicals in the implant, and it's going to depend upon the device itself. Obviously, we have proof of concept that there are implants that can release hormonal contraceptives for 5 years that produce essentially no local toxicity and are quite well tolerated by most women. So it is something that is theoretically possible. It's just that nobody's doing it right now for HIV, which I think is unfortunate because I agree with you. It has many advantages over the injectable kinds of formulations we're talking about.
So we just got a couple minutes left. We've got a lot of questions from the home folks. Most of them related to vaccines, so I'll try to go quick. One question is about pharmacies that are giving vaccines for reasons. Oftentimes clinics won't because they can't afford to stock them. But the pharmacies typically don't check history. Is that a problem?
I think it can be in a person who's not savvy basically as a consumer. And I think if people know what we recommend, people ask in the clinic and they get approval from their clinician and say, hey, I want to get it at my local Bartell's or Safeway. We say, fine.
Sure.
But we ask them to check with us first. That's what I recommend doing.
Okay. RSV vaccine, is there a particular one that you think is better?
I don't think the data is, I think there's controversy about, this Guillain-Barré and other things. And I think right now there's not, in my mind, a clear indication of one over the other.
Okay. Then the other thoughts came up again, but I think it might be worth mentioning is that someone who has never had chickenpox, you'd still give Shingrix to.
So first of all, if somebody's never had chickenpox before, I think the question a little bit earlier was about somebody who's been immunized. Right. If they've been immunized, I would in an person who has HIV, because varicella vaccine is a live vaccine. There's a significant amount of it, and I think people are going to be at risk for shingles with that, especially people with HIV. There's no guidance on that right now formally. In the general population, I would not do that. And I also think the general population, we're not going to know the answer to that.
Correct.
Till the generation starts to become at an age risk of 40, 50 years old.
It seems to me that we might not need it. But
that's right. In the general population, they may not.
Right.
But I also just think because of the safety of the current Shingrix vaccine, other than cost, and how bad shingles is for people.
Somebody develops shingles, you want to vaccinate them afterwards, how long do you wait?
At least 2 months, probably.
6?
Yeah, 6 would be we've always told people in our clinic at least 3 months. Most people, they've waited 4 to 6 months.
And the last comment was about pajamas. And they, one of the members of the audience rightfully criticized us for making fun of that. Actually, they were up at 4 a.m. because they're on the West Coast. And you're totally okay to wear your pajamas. We think pajama parties are fine, and we support that.
My comment was not a critical comment. It was simply an observation. Speaking as someone who does frequently do conference calls early in the morning in his pajamas.
Exactly. Okay. Well, thanks. We've had a great start to the session. We have a couple more talks after a break. So I'd like to welcome Meredith Clement, who is from LSU in New Orleans. I went to undergrad at Tulane, just down the street from there, and it's a great place to live and be. It's a very unique culture. You can go visit New Orleans, but living there is a whole different experience, which is rich and deep and kind of really interesting. But Meredith's here to talk about sexually transmitted infections. There's a lot of old stuff, but there's a lot of fascinating new stuff that we're going to hear about as well. So it's great to have you here, and welcome.
The title of my talk is Sexually Transmitted Infections, Old and New. Thank you for the introduction. Thank you for having me. And so by way of a brief outline, I'm going to start with just some obligatory STI epidemiology to tell us where we are with STIs in not 2025, because the most recent year for which we have updated data is 2023. And then as far as the old, I'm going to talk a little bit about syphilis, serologies, and interpretation that actually never gets old, as you know, still complex, and causes a lot of consternation among clinicians. And then move into the new, which is doxy-PEP, and talk about a few studies that have come out lately on antimicrobial resistance, which is a hot topic with regards to doxy-PEP. So again, 2023 data, we actually had good news for the first time in several years that rates of chlamydia, gonorrhea, and sort of syphilis are decreasing or stable. So 1.6 million cases of chlamydia in 2023, which was basically stable from 2022, and overall a decline from 2019. And then for gonorrhea, 600,000 cases in 2023, down from around 650,000 cases in 2022. And then syphilis, it kind of, there's a red arrow pointing up, but that's overall syphilis cases. I'm going to show you some data on primary and secondary syphilis cases in a minute. And what's really, I think, a tough number to swallow is 4,000 cases of congenital syphilis in 2023. And as we all know, congenital syphilis can lead to stillbirth. Congenital anomalies can be particularly devastating, and it's really totally preventable. So yeah, really hard to see that number. Although I will say it was only a 3% increase in cases from 2022, which is sort of a leveling off finally instead of these large increases we've seen in the last several years. So the first question I have is, over the decade from 2014 to 2023, congenital syphilis rates increased by 100%, 200%, 500%, or 700%. All right. So, yeah, I kind of tricked you because I showed 100% increase in the last 5 years, but really over the past decade, congenital rates of syphilis have increased 700%, and I'll show that data in a second. Still giving me some numbers. Okay. So first, though, I just wanted to talk about kind of the overall landscape of chlamydia, gonorrhea, and syphilis over the past decade. So the big caveat or asterisk attached to all CDC data is that the numbers from 2020 are not interpretable because of the COVID pandemic. But you can see sort of this leveling off or slight decline over the last several years in chlamydia infections, or since 2019. Gonorrhea, kind of a steeper decrease in the past 2 years. With chlamydia, more cases in folks assigned female at birth. With gonorrhea, more cases in folks assigned male at birth, and then you can kind of see the regional distributions there too. And then syphilis, this is where we're seeing primary and secondary syphilis. And so, as you know, those are the symptomatic stages of infection. And so those numbers are not influenced by changes in testing frequency. So a little potentially more representative to what's really happening in the real world with those declines that are exciting to see. However, in recent years, we have seen large numbers of increase among those assigned female at birth. So you can see this male to female ratio going down as the rate of syphilis cases among females increasing, and alongside of that, the cases of congenital syphilis increasing over the past decade. And so this is this 700% increase in the decade that I showed you in the question. But you can see if you look from 2022 to 2023, you see a little bit of a deceleration, if you will. Okay, so question 2. An 18-year-old woman requests routine STI screening. She reports last sexual activity was 6 months ago. Your laboratory uses the reverse sequence algorithm. So her first test is the treponemal enzyme immunoassay, or EIA, which is reactive. Her reflex RPR is non-reactive, and then after that, her TPPA is also negative or non-reactive. So how would you interpret these results, and what is your next step? Does she have previously treated syphilis? Nothing to do. Previously untreated syphilis? Treat now for latent syphilis. This is early primary syphilis, and she needs a thorough exam to look for a chancre, or is this a false positive EIA result? No additional testing needed. Okay, great. So the majority of people actually got this correct. False positive EIA result, no additional testing needed. I will say answer C is not always wrong. This could be a first positive test with false negative subsequent testing in someone who does have early syphilis. We know that when there is presence of a chancre, there's not always seroconversion at that time, and we would consider that false negative testing. However, this patient or client said she had not had sex in 6 months. So we think that this is consistent with false positive EIA result, and no additional testing is needed at this time. And so I'm going to go through these algorithms in a second, but first I just want to distinguish between the non-treponemal and the treponemal testing. And so if you'll look, this says non-treponemal parentheses lipoidal antigen. And so in 2024, the CDC released updated laboratory recommendations for syphilis testing. And what they said was historically, we've always thought that non-treponemal antibodies form in response to tissue damage in the host. But actually, non-treponemal antibodies, we named them that in the 1960s. That was actually a misnomer because the antigens used in this test are actually found in membranes of Treponema pallidum as well as hosts. And so now the suggestion to add confusion to syphilis testing is that we say non-treponemal parentheses lipoidal antigen testing. So that's a mouthful. But the tests include RPR, VDRL, which are the two most commonly used ones in trusts, which you will not see used very often. And then for treponemal testing, which is still considered more specific testing, EIA, which is enzyme immunoassay, CIA, chemiluminescence assay, TPPA, treponemal pallidum particle agglutination, or FTA, ABS, fluorescent treponemal antibody absorption testing. And there are a few others, but those are kind of the ones you need to keep separate in your brain. The other thing to know about non-treponemal testing is that we can quantify it, so we will give a titer that's quantified. So the traditional algorithm that you're seeing on the left is what was more commonly used previously, but now the reverse sequence algorithm is actually taking over in labs across the country just because of increased throughput and ease of testing. But so for the traditional algorithm, you're starting with an RPR or a VDRL, so the non-treponemal lipoidal antigen serologic testing. If that's non-reactive, you're done. If that is reactive, you want to get a RPR or you want to proceed to your treponemal serologic test. And then if that's non-reactive, then you think syphilis is not likely, probably a false positive RPR or VDRL. But if that is reactive, then that's a diagnosis of syphilis, either somebody who's been previously treated or warrants treatment now. And then for the reverse sequence algorithm, you're starting with that treponemal serologic test, so usually an EIA or a CIA. If that's negative, then syphilis is thought to be unlikely. If that's reactive, then you're going to proceed with your non-treponemal lipoidal antigen serologic test. If that's reactive, then that's a diagnosis of syphilis, either, again, previously treated or needs treatment now. And then if it's non-reactive, then what happens in the lab is that a second treponemal test is conducted, usually a TPPA or FTA ABS. And if that's non-reactive, like in the question stem I gave you, you generally consider that first treponemal test to be a false positive. If you are very concerned for syphilis, you can repeat testing in a couple of weeks. If that second treponemal test at the bottom is reactive, then again, you've got your diagnosis of syphilis, either previously treated or needs treatment now. Okay, so moving on to the third question, we have a 33-year-old cisgender woman with HIV on ART. She has an undetectable viral load, so well controlled, and she comes into your STI clinic with painful sores on her genitals and in her mouth. She reports condomless sex with several partners over the past 3 months. You do HSV and Mpox testing. Those are both negative. Her RPR returns at 1 to 256. I realize that some of you would probably have treated her already when you see her in clinic, but let's pretend that didn't happen. So you call her a few days later to inform her of her diagnosis and the need for treatment. She tells you that in the meantime, she's developed ringing in her ears. And so what is the appropriate next step? Do you call in doxycycline for 14 days for early syphilis? Do you arrange for the patient to undergo lumbar puncture, arrange for hospital admission for IV penicillin, or consult ENT? All right, so it looks like over half are getting the correct answer. Arrange for hospital admission for IV penicillin. And you do want to refer to ENT, but you should not let that stop you from going ahead and arranging for this patient to get urgent IV penicillin. Okay, and so this is sort of a change with the most recent round of guidelines from 2021. So for ocular syphilis, and we can talk more about that in the Q&A, it's similar, or otic syphilis, the suggestion of whether to LP on presentation has shifted a little bit. But just to talk about otic syphilis, this usually presents with cochlear vestibular symptoms, so tinnitus, vertigo, or sensory neural hearing loss. The hearing loss can be unilateral or bilateral, have a sudden onset and progress rapidly, and it can actually be permanent if not treated fairly urgently. It can be diagnosed based on auditory symptoms alone and reactive syphilis serologies. So the CSF evaluation is not thought to be needed in this setting. It's thought it's going to be normal in most settings and does not aid in diagnosis. If there are cranial nerve abnormalities, you should always assess cranial nerves, then pursue CSF testing. And then again, we want to consult ENT, but we shouldn't let their consult delay treatment with IV aqueous penicillin. Okay, and now we're going to move into doxypep. So this question is about that. So 24-year-old transgender woman, she has well-controlled HIV, and she presents to your sexual health center for STI screening. She reports recent diagnoses of chlamydia and gonorrhea. You tell her about the use of doxycycline as post-exposure prophylaxis. She's very interested. You talk to her about how to take it and advise on side effects. Which of the following is correct if she starts doxy? So A, will she be at increased risk of C. diff infection? B, the medication can cause esophageal injury due to its high pH. C, she will experience GI symptoms as a side effect. Or D, her syphilis studies will always be reliable. Okay. This question was too easy. I apologize. So yeah, she may experience GI symptoms as a side effect. We know that's a common side effect with doxycycline. In the DoxyPEP study, which I'm going to talk about in a minute, only 2% of the participants discontinued the study due to really low tolerance of the medication. Yeah, and then just it can cause esophageal injury, but that's due to its low pH, not high pH. Okay, so this table, I'm sorry, is coming across a little bit smaller than I wanted it to, but this table is actually from a review published in CID by a colleague, Anu Hazra, last year that goes over some of the more recent DoxyPEP trials that have influenced the guidelines. And so I just wanted to talk about the evidence base for the 2024 DoxyPEP guidelines and really focus on the large clinical trials that have been conducted in France or Europe and in Seattle and San Francisco. So the IPERGAY study, you guys probably know, was on-demand HIV PrEP. In the open label extension, they actually opened it up to a RCT with DoxyPEP. So participants were randomized 1-to-1 to DoxyPEP or no prophylaxis. The primary endpoint was the first occurrence of gonorrhea, chlamydia, or syphilis. And what they found was a 40% reduction in that first STI occurrence. It was about a 70% reduction for chlamydia and syphilis. The gonorrhea reduction was not statistically significant in that study. And then Annie Lukemeier, Connie Kellum, and colleagues conducted the DoxyPEP study among men who have sex with men and transgender women in Seattle and San Francisco. Again, this was an open-label RCT. Participants were actually randomized 2-to-1 to DoxyPEP versus no PEP. And they looked at two different cohorts, persons living with HIV and participants who were taking HIV pre-exposure prophylaxis. And in the group living with HIV, there was a 62% reduction in the quarterly rate of STI, and that included gonorrhea, chlamydia, and syphilis. And in the folks on HIV PrEP, there was a 66% reduction in STIs. And then the DoxyVac study that was just published last year was looking at the meningitis group B vaccine, but also DoxyPEP. And so this was a 2-by-2 factorial design because they were looking at two interventions at the same time. Unfortunately, the meningitis vaccine was not shown to be efficacious to prevent gonorrhea, but in that study, DoxyPEP did lead to an 84% reduction in STIs. Their primary endpoint was chlamydia and syphilis alone, but actually there was a reduction in gonorrhea too. And I apologize, this is 51% because that was what was in the CROI abstract. It was more like a third reduction in gonorrhea. And then finally, the DPEP study, which was in cisgender women conducted in Kenya. And unfortunately, this trial had a null result. So DoxyPEP was not shown to be efficacious, although adherence was low. So when they did a subsample of participants and looked at doxycycline levels in hair, only 29% of participants had detectable doxycycline levels. And then I didn't show this data, but I want to talk about it for just a second. In January, in JAMA Internal Medicine, there were two different papers that were published. One was published looking at Kaiser data, and what they found was reductions in incidence of quarterly chlamydia from about 10% to 2%. Gonorrhea was 10% to 9%, and syphilis was, I think, 1.7 to 3%. So in all of the Kaiser data, when they looked at DoxyPEP, kind of in their real-world setting, they showed really dramatic reductions in STIs. Similarly, at the same time in JAMA was published the health department in San Francisco was looking at their population level results. And what they found was about a 50% reduction in chlamydia and a 50% reduction in syphilis, again, at the population level. And that was just following implementation of local DoxyPEP guidelines in San Francisco. So we've got real-world data now. We've got clinical trial data, all really encouraging for DoxyPEP, some DoxyPEP, but DoxyPEP efficacy. And so we've got guidelines. And so now let's just talk about some of the other impacts. So the answer for the question stem was not to be concerned about increased C. diff. And so I wanted to show a study that was published in OFID in 2023. This was a matched case cohort study, matched case control study, and it was conducted based on insurance claims data. And so the authors, for every one case of community-acquired C. diff, they matched 5 controls based on age, race, and enrollment period. And then they looked at antibiotics that had been given in the 30 days prior to C. diff infection diagnosis. And you can see hundreds of thousands of cases and controls. They ordered the antibiotics in terms of relative level of associated risk for C. diff infection. And as you can see in the top, the antibiotics associated with greatest risk for C. diff were clindamycin and later generation cephalosporins. And if you look at the bottom, lowest risk was minocycline and doxycycline. And actually, minocycline looks like it had a bit of a protective effect. So that's C. diff. And then I think the last question response, or answer response for that question was the reliability of the serologies in folks who are taking doxypep. And this is still something we don't know a lot about, but we're learning more. So I want to point out that there was a cohort study published in Italian Men Who Have Sex with Men, I think last year, that was looking at serologies, delayed seroconversion in several participants, or I guess clients who were on doxypep in their cohort. And that study to me was not as interpretable because all of the patients in that study had early syphilis or chancre. And as we talked about earlier, you can see false negative or delayed seroconversion anyway, even without doxypep. But this case report, I think, was a little more compelling. So this was a young man who had sex with men, no age given, but he had presented with throbbing left-sided headaches, enlarging swelling on his left forehead, pulsatile vessels, and there was concern for giant cell arteritis when he came in because his syphilis testing had recently been negative, although going back a few months prior to presentation, he had actually had what they called indeterminate syphilis testing. So this is actually what I showed you in that case stem, but a positive EIA, a negative RPR, and then a negative TPHA in this case. And so this patient actually got a temporal artery biopsy that was negative, and then when they got his RPR, it was 1 to 128. And so he was treated and improved. But just to kind of show you that the doxypep, we think, may interfere with serologies, and that's just something we need to learn more about, and hopefully we will as time goes on. So I modified question 2A. So instead of a woman, now it's a man because of the guidelines, cisgender man who has sex with men. But if he has a positive treponemal EIA, an RPR is negative, and a TPP is negative, and he's on doxypep, then how would you interpret these results, and what is your next step? And I don't think that there is going to be an audience response to this one because I just said this is sus, to use Gen Alpha language, and please carefully evaluate for active syphilis. All right, so in the last few minutes, let's just talk about antimicrobial resistance. So the CDC identifies these 7 pathogens as urgent threats as far as hospital-acquired pathogens. But then also, we still have kind of our ever-present concern about drug-resistant gonorrhea. It's grown resistant to nearly every drug used to cure it, and so still something that we think a lot about, especially with kind of the evolution of doxypep in our patients. So I wanted to touch on this study for a second. This is Staph aureus tetracycline resistance and co-resistance in a doxycycline post-exposure prophylaxis eligible population. So this study was conducted, it was a retrospective analysis conducted in Boston at MGH and Brigham and Women's Hospital. They had a little over 400 Staph aureus isolates in men who were either HIV positive or on HIV pre-exposure prophylaxis. So not actually taking doxypep. This is kind of a hypothetical. And so what they wanted to do was look at the association of tetracycline resistance and resistance to other antibiotics in the Staph aureus isolates. And so they split tetracycline resistance up, tetracycline intermediate / resistant or tetracycline susceptible isolates. And so what they found was no association between tetracycline non-susceptibility and oxacillin resistance. But they did find 4.52 greater likelihood of Bactrim or TMP SMX resistance in isolates that were tetracycline non-susceptible. And then there was an association with clindamycin as well. And so the authors kind of talked about this bystander selection, where we need to be more concerned about sort of selection of Staph aureus isolates with resistance to other antibiotics as doxypep drives tetracycline resistance. Okay, and so this study was actually interesting because it was designed to induce resistance of Treponema pallidum to doxycycline. So this was in vitro exposure. They did exposed. They looked at doxycycline kind of given in these pulses, so intermittent exposure, and it was sub-bactericidal or sub-therapeutic, but enough to exert antibiotic pressure. So the idea was to mimic doxycycline post-exposure prophylaxis and look at the level of treponemes. And so they saw decreases with every doxycycline pulse and then increases again in treponemal level. And when they did their MIC determinations and whole genome sequencing, reassuringly, no resistance was found. So this is kind of a reassuring study. And then the next group of slides, I'll probably just cover quickly because I don't have a ton of time left, but this. So in the doxypep study that Annie Luke-Meyer published in New England Journal of Medicine, they looked at phenotypic resistance. This study was sort of the more scientific analysis to look at genotypic resistance. So this is the resistome, which is ARGs or antimicrobial resistance genes in the microbiome. So they took stool samples from participants who were either randomized to doxypep or no PEP, and they compared the resistome at day 0 and month 6. So just to kind of orient you, on the left-hand side is standard of care. On the right-hand side is doxypep, and sorry, the colors alternate a little bit based on what exactly they were looking at. And then you can see day 0 versus month 6. But this first slide is just to show you, on the top is the resistome mass, and the bottom is alpha diversity, which is just sort of the variation in these genes. And there was no difference in either group at day 0 at month 6. However, there was difference, and sorry, they did DNA sequencing, DNA-seq, and RNA sequencing, RNA-seq in this study. And so on the left-hand side is DNA-seq. No difference here in tetracycline ARG resistance, richness, or proportion of the resistome. But if you look at the right-hand panels, using RNA-seq, there was actually increased richness of tetracycline ARGs, and the proportion of tetracycline ARGs seen at day 0 versus month 6 in doxypep versus no PEP. And then finally, there was no increase in proportion of other antibiotics in terms of resistome mass, but there was with tetracycline. And you can see that on the right panel with the RNA-seq, the very last group of box plots. Okay, and I'm going to speed through this because I have 1 minute left. But this is one more study about antimicrobial resistance, and this came from Seattle. So Matt Golden and colleagues looking at UW, looking at kind of real-world resistance that has occurred in their population since doxycycline post-exposure prophylaxis has been implemented in guidelines, but actually they looked at their data, they did cultures of all their Neisseria gonorrhea isolates dating back from 2017 to 2024, and just to kind of get to the punchline. They saw gradual increases in tetracycline resistance over time, but most significant increases in these later years. So for just routine tetracycline resistance, that was 80% per quarter from 2023 to 2024, and high-level resistance, 70% per quarter from 2021 to 2024. And I just want to make the point that the increase in this high-level resistance did predate their release of local doxypep guidelines. And if you took more doses, you were going to have more resistance. And then I think I had one more. They did see more Staph aureus, less colonization in doxypep users, but more tetracycline resistance. And then there's also concern for group A strep colonization of the pharynx being increased in folks on doxy. I think this comes from the acne literature. And they did find more colonization, but both groups of group A strep had really high tetracycline resistance, as we know exists with group A strep. And so in the last few seconds, I just wanted to kind of raise some of these questions. This was a review or evidence-informed provision of doxypep prevention that was published last year by Julie Dombrowski and colleagues. And it just goes, they actually took the data from the doxypep trial and tried to answer some questions that might come up clinically for us as we are prescribing it. So if any of these questions interest you, we can talk about it more in the afternoon session or in the Q&A. And with that, I'm a minute over, so I'm going to hand it over to Rafi.
Okay, and our anchor leg speaker is Rafi Landovitz from UCLA. He is one of the leaders of the HIV Prevention Trials Network and has led a lot of the seminal studies on PrEP. And he's going to talk to us about PrEP and give us an update of what's new and what's coming down the pike.
Thanks, Mike. And it's always a dangerous proposition standing between people and lunch. So buckle your seatbelts. There we go. Okay, these are my disclosures. That was a Wicked reference in case you missed that, remember? Anyway, okay, we're 40 years into the HIV pandemic, and we still have an unacceptable number of new HIV infections. So clearly everything we're doing isn't working well enough. We need new things, and that's why we're having this conversation about new biomedical strategies for HIV prevention. I'm going to go really fast through the old stuff because this is not news to all of you. First drug approved for HIV pre-exposure prophylaxis, the artist formerly known as Truvada, now known as TDF-FTC because it's available generically, and that's the overwhelming majority of what's prescribed. Those of you who have ever heard me talk on this topic before know I have a love affair with this slide ever since 2015. This is a conceit because I grew up in the Northeast, and in the Northeast, as you all know, right, during the holiday times, various houses of worship, when they do their philanthropic fundraising, have a thermometer outside the house of worship, right, where they fill it up as they accomplish their fundraising. And that's the conceit here. So the shape of the individual in each of these studies is the sex at birth. We're still allowed to say that here, right? Of the individuals who were studied, and how filled up the character is the point estimate of the predictive efficacy of the intervention in that population. And if you sort of squint your eyes at the populations a little bit, you get a sense that the initial studies seem to suggest that it's worked for individuals born male, but not born female. And that caused an incredible amount of, I'm so mad at Meredith because she stole my favorite vocabulary word already in her talk, a lot of consternation and frustration among consumers or providers about whether could this work for men and not women, or what was going on. And of course, now we know that it's really two big issues aggregating here, right? The first is adherence. You have to take a drug for it to work. And in a lot of these studies of the cisgender women, this wasn't congruent with what they wanted. So they just didn't take the product. So you can't expect it to work. And the second is, where does the product concentrate? And there's a tremendous amount of debate, angst, fights, fisticuffs over what the relevant location is that a PrEP agent needs to concentrate for there to be efficacy. There's one camp of people that say it needs to be in the mucosal location where the exposure occurs. And that's where the big difference is with TDF in particular. TDF-based PrEP, the tenofovir component, concentrates about 100-fold better in rectal tissue than it does in cervicovaginal tissues, which means that probably it's going to be less forgiving to miss doses with the lower concentrations of the cervicovaginal compartment. There's a whole other sort of group of people, Charlie, please don't shoot me for saying this, largely based at Johns Hopkins University, who really believe that it's PBMC concentrations that are the relevant parameter, and we can talk in the Q&A or this afternoon about what the evidence is for or against each of those arguments. But that was sort of the explanation for why these disparate results in the early clinical trials. Now you're thinking, what about that lower right corner, right? Why is there a mime sitting on this slide? And the answer is because all the other studies that are on this slide are daily oral TDF-FTC. It's not really meant to be a mime, it's just somebody in a striped suit. Why? Because rather than daily use in this one study, and Merit Authority referenced a study called Hypergay, which was done in France and Quebec, which rather than on daily dosing, used this technique called on-demand dosing or pericoital dosing of the TDF-FTC. The community called this disco dosing originally because people would think, I'm going out to the disco this weekend, I'm not going to take daily PrEP, I'm going to sandwich the planned sexual activity that is going to anticipatedly happen this weekend and dose just around that. And we all, of course, as providers said, don't do that. That's a bad idea. And of course, you know, the community had the last laugh because it turns out it does work. And the study itself, again, called Hypergay, again, this is for cisgender men and transgender women. This was the context in which it was studied. And when there was planned sexual activity, and, you know, I guess in France, things happen on Wednesdays, I don't know. But when the planned sexual activity was going to happen, again, Wednesday, 2 to 24 hours before that planned sexual activity, a double dose of TDF-FTC was taken, and then 24 hours after that initial double dose, a second single dose was taken, sandwiching that planned sexual activity between those first two doses, and then a third and final single dose was taken 24 hours after the second dose. Now, of course, what isn't on this slide is that this so-called 2-1-1 dosing, so-called because of the number of tablets taken in series, it really devolves very quickly into something that I call 2-1-1-1-1-1-1-1 dosing if there is ongoing sexual activity. So the instruction that is built into this protocol is that you're supposed to keep taking the daily single doses until 48 hours or 2 doses after the final episode of planned sexual activity. So if you think about it, so it very quickly devolves from 2-1-1 into that 2-1-1-1-1-1. So this is really something that is really only useful, number one, if you can plan your sexual activity, and number two, if it's limited to really less than 2 episodes of sex in a given week. Otherwise, you might as well just take the daily dosing because that's what it really turns into. The one point I will make, and some of the guidelines have evolved to represent this, is regardless of how you're starting daily oral TDF-FTC PrEP, or TDF-FTC PrEP at all, there was a rectal sub-study of this Hypergay study where there were biopsies taken in the rectal compartment 1 hour, 2 hours, 4 hours, 8 hours, 16 hours after double dosing of TDF-FTC. Now, don't panic. Those weren't all the same people who had those serial biopsies. There was like a couple of people who had biopsies at 1 hour, a couple of people who had biopsies at 2 hours, etc. And you could find protective concentrations, or what are thought to be protective concentrations, in rectal tissue biopsies of the tenofovir metabolites 24 hours after that double dose. So what that suggests is anytime you're starting somebody on TDF-FTC PrEP, whether it's daily or this on-demand, why wouldn't you start them with a double dose that should get them protective concentrations in the rectal compartment within 24 hours? That's in the IAS USA guidelines. The CDC guidelines has not caught up with that yet. It's in none of the regulatory approvals, but I think it makes sense. It's got low toxicity. Why wouldn't you do that? Anyway, let's move on to the next agent that got FDA approval for PrEP. It's TAF-FTC, the artist currently known as Descovy, not yet available as a generic. And this was studied head-to-head in cisgender men and transgender women in a Gilead-sponsored study called Discover, which compared the two agents with daily use with HIV incidence as its primary outcome. This is old data at this point, so this isn't a surprise to anybody. There were 48 and 96-week data. They both showed a lower absolute number of incident HIV infections in the TAF-FTC group compared to the TDF-FTC group, but the incidence rates were really low in both groups, and statistically, this only fell into what's called non-inferiority, which those of you who think about clinical trials a lot basically means, know that basically means not that much worse than. Right? And that's all you can say about it. You can't say it's better. You can't say it's worse. It basically performed about the same. Of course, what we know about TAF-FTC compared to TDF-FTC in the treatment space is that it's got fewer bone and renal complications, but has the potential consequences of increasing LDL cholesterol. And, despite the conversation that we had earlier this morning with Joe and Raj about its effect on weight, there were differential weight effects seen in this trial with more weight gain absent the inflammatory milieu of HIV infection in the individuals randomized to TAF compared to TDF-FTC. Honestly, that's probably more of an anorectic effect of the TDF than a weight increase effect of the TAF-FTC, which probably more represents the amount of weight that a placebo-treated or average person gains on an annual basis. In fact, we're all gaining weight since we started this course this morning. So we all should go on semaglutide, right? That's the clear answer, and stop our biologic clock. Anyway, I do want to talk for a hot second with a big caveat about this issue. There's a lot of advertising that has centered around different oral PrEP agents. And so, at least in my clinical practice, I get a lot of people coming in saying, all my friends are on, drug A. Shouldn't I be on drug A? Why do you have me on drug B? Shouldn't I be on that? I see, bus stop benches and all sorts of TV ads for, drug Q. Shouldn't I be on that? And, I print this out and I have this in my clinic. It's already out of date that I'll tell you about in just a second, and I need to update it. But this I stole from Julia Marcus, who's now at Harvard. She was previously at Kaiser in Northern California, and I think it's brilliant. It basically brings up the 5 issues of discussion for how you choose which oral PrEP agent you're going to prescribe, at least for daily use. The first is just graphically represented here. It's the pill size, right? And for some people, the size of the pill is really going to impact whether or not they're going to be able to take it. This happens a lot with adolescents, but even some adults, right? Particularly if there's esophageal strictures or what have you. We already heard about a patient this morning who was having, had esophageal cancer and was undergoing chemo, was having difficulty swallowing. I think it was a patient of Raj's and whom he used an injectable issue. But let's pretend that, pill size is a big issue. This is something to consider. The other 4 domains that I think about, again, are changes in renal function, changes in bone mineral density, both of which have not been shown to be clinically relevant in the PrEP space. The only difference that I've been able to ascertain is, right, TAF-FTC has an FDA approval for use down to a creatinine clearance of 30, whereas TDF-based PrEP only has FDA approval down to a creatinine clearance of 60. That doesn't mean you can't use it, but we do know that TDF-FTC is a proximal tubule toxin and is associated with nephrotoxicity, TAF-FTC less so, not completely absent. So it is something that you may want to consider. Again, the other things, right, TAF-FTC associated with increases in LDL cholesterol, particularly as we have older patients who are on PrEP, have other cardiovascular risk factors, sometimes something you want to think about, and of course the weight gain we talked about. The big caveat that I want to update you on from CROI from 2 weeks ago, a week ago, when was CROI? Last week, is the populations in whom we have data. Until a week ago, we were saying we don't have any data and there is no FDA approval for the use of TAF-FTC for vaginal exposures. It has FDA approval for all routes of sexual transmission prevention except for vaginal exposures. Well, now we have data. There was a case control analysis from a study called Purpose 1. Many of you have heard about it. Everyone thinks about it as a lenacapavir study. Guess what? It had a TAF-FTC arm for cisgender women in South Africa and Uganda, and it did not show prevention efficacy for vaginal exposures. But the reason it didn't is because people didn't take it. Footnote prior conversation. You have to take a drug for it to work. At CROI last week, they presented a case control analysis where they looked at people who had dried blood spot biomarker evidence of good adherence to the TAF-FTC and compared it to the HIV incidence rate in people who did not have such concentrations. And what they were able to show was 89% reduction in odds of HIV acquisition in people who had biomarker evidence of 2 or more doses per week of the TAF-FTC. They didn't get more granular, so we don't have an estimate for 4 or 7 days per week. Somebody quite rightly came to the microphone and asked the presenter about that at CROI, but that information is not available currently. But there is no regulatory approval. But if somebody had a low creatinine clearance and needed it for vaginal protection based on those data, I don't think it's crazy to recommend it anymore. And I think we are likely to see some progressive guideline bodies move in that direction. I doubt, watch me be wrong about this, that it's ever going to get a regulatory approval based on those data, but I do think we'll see guidelines evolve. Okay, so let's pretend that you had an actual interest in things other than oral pre-exposure prophylaxis. I know I do. Again, I'm biased because I was very involved in some of these studies. So more choice is better, right? Pills are good for some people. People doing well on pills, no reason to change that. Some people have trouble taking pills. First injectable product, you're all familiar with it, cabotegravir, approved in the US and a large number of other countries, although programmatic rollout outside of the US has been relatively slow. We have some evidence now coming in from other countries, including Malawi and Zambia, as well as demonstration projects from Brazil and South Africa. But the data on which that drug was approved was based on 2 phase 3 randomized trials, HPTN 083 and 084, that were head-to-head comparisons in different populations with injectable cabotegravir given every 2 months, as Charlie already alluded to, compared to daily oral TDF-FTC. Here's the punchline. Here are the efficacy results. It's a little bit of a complicated slide, so give me 2 seconds to talk you through it. Left side of the slide, HPTN 083, cisgender men and transgender women. Left side of the slide, the original blinded randomized study. 66% reduction in HIV incidence in the men and transgender women randomized to the injectable product compared to the oral product. Still on the left half of the slide, but the right half of the left half of the slide. When the study was stopped early for superiority, you want to offer everybody the superior product, right? It was the middle of COVID. That was actually a really hard thing to do. So we unblinded everybody and continued them on their original randomized regimen until we could amend the protocol and get the product in country and give people or offer people the injectable product. So we actually had a year of additional data with people still on their original randomized regimen, but now unblinded. What you can see, again, left half of the slide, right half of the left half of the slide, still a 2/3 reduction in HIV incidence in that population, but both incidence rates are much higher. That was not attributable to reduced adherence. We don't know why it is. I have some theories. We can talk about it if people are curious. But the really exciting data is on the right-hand side of the slide. HPTN 084, cisgender women in Southern and Eastern Africa, 90% reduction in HIV incidence in the people who got the injectable product compared to the oral product. And that was quite consistent, again, when they were stopped early for superiority, and same deal. They were 6 months behind 083, and they continued on their original randomized regimen until the protocol could be amended, et cetera, et cetera, et cetera, and consistent results. So super exciting. But nothing is a free ride, right? And we learned that with long-acting injectable cabotegravir, there's some new biology in terms of HIV diagnostics in the context of when long-acting injectable cabotegravir PrEP fails, right? On the right side of the slide is the age-old plot that we're all very familiar with of what the viremia trajectory is in purple and what the antibody trajectory is in blue when somebody acquires new HIV infection, right? We're very familiar with this. About 7 days after exposure, you can get, in about 70% of people, a mononucleosis-like illness, rash, sore throat, fevers, lymphadenopathy, perhaps genital oral ulcers, right? We're all familiar with this, morbilliform rash, and then antibodies develop, and that's how a diagnosis is made on conventional diagnostics. Well, it sort of makes a little bit of sense if you think about it. If you have a long-acting antiviral that's potent with a high barrier of resistance to HIV in the system, and you acquire HIV in that context, if you were going to guess what was going to happen, well, you might guess that it's all based on resistance, right? That's something you might guess. And so it might be sort of the classic pattern again. Or you might say that if it breaks through, there's going to be constant pressure to keep the viral load low. And if that happens, maybe the generation of antibodies is going to be delayed. And that's, in fact, what we observed. And we called that LEVI, which stands for long-acting early viral inhibition. And this is what we saw. And again, these are cabotegravir concentrations on the left half of the slide, now in orange. And the injections are being given. And if you stop the injections, then the concentration goes down. And let's say that either there was HIV before you started the PrEP, so you missed it and you started somebody on PrEP, or that it broke through early, right? Sometimes the viremia, just like you would expect, it pops up and you can detect it on your conventional assays, and that's lovely. Sometimes, not so much. Sometimes it stays underground until your cabotegravir concentrations start to wash out, and then it unmasks it and you discover it. And this is the frustrating part, is sometimes it just stays down, and it makes that diagnosis very hard. And those purple lines, those are viral loads. Okay, what happens to antibodies? Well, sometimes, now in blue, it comes up like right when you'd expect it with the viremia. Sometimes it pops up and then goes back underground and only comes up when there's a burst of viremia later. And again, my personal favorite, it comes up, it peaks up, and then it says, peekaboo, goodbye. And it makes diagnosing this extremely challenging. And it was on the basis of this and the fact that the longer this happens, the more likely you are to get integrase resistance, that the FDA and the CDC made the recommendation that we monitor for breakthrough on cabotegravir PrEP with viral load testing. And as you all know, that was an incredibly controversial recommendation, really challenging to implement, highly costly, and created this whole kerfuffle of now when you get a low positive viral load, what on earth do you do with that information? So, important thing to understand about what I've just shown you here on this slide is this was all based on retrospective data. In these cabotegravir studies, we didn't do RNAs prospectively. We just did regular rapid testing and regular laboratory-based antigen antibody testing. It was only when we sort of figured this out by back testing on stored specimens, because this was a clinical trial, that this became obvious. What that doesn't take into account, of course, is when you do a test prospectively and you put it in your screening, right, what's the false positive rate, right? And they're the devil's in the details. Okay, so they're clinically different. LEVI is silent. Acute HIV infection most often is not. I'm not going to spend a lot of time on this. But this is sort of the billion-dollar question that comes out of all this. What's the best testing algorithm when you're using long-acting PrEP? And the guidelines differ on this. The IAS USA guidelines, updated in December of 2024, perhaps the most progressive, they sort of walked back on what the FDA and the CDC said and said, do not do prospective RNA testing to monitor for CAB PrEP failure. Why would they say that? Well, here are the data from HPTN 083, and the bottom line here is basically 2 rapid tests, or rapid and an antigen antibody test, have really good positive predictive value for breakthrough infection, even with cabotegravir. And I actually can give you some updated data here because we had to submit these slides before CROI happened. Whoops, go back. You see that bottom line down at the bottom where it's RNA testing? It doesn't actually say RNA testing, but that's what the little squiggle in a test tube means. So look under the CAB column of 083. See that positive predictive value of a positive RNA test there? 9.1%. Let's think about that for a second. The positive predictive value is 9%. That means 9 out of every 10 positive RNAs that you get are false positives. Does that sound like a good screening test? No. So Sinead Delaney-Morettelway, who led the 084 study, actually presented the 084 similar data at CROI last week. And the answer in the 084 study wasn't much better. It was a little better. It was 25%. But still, not great. So my recommendation is to agree with the IAS USA 2024 guidelines, which is if you have a high incidence population and you can do it, do an RNA before you start somebody on CAB, because you don't want them to have acute or primary HIV infection before you start a single agent. You just don't want that. If you can't do it, that's fine. Just do your regular antibody testing algorithm and repeat it a month later just to make sure you didn't miss something before. But do not do routine RNA screening prospectively to look for CAB PrEP breakthrough. In the questions, or maybe in this afternoon session, if you're interested, we can have this really interesting and fun conversation about, but what about preventing INSTI resistance? Isn't that really important? And do we lose that with not doing RNA testing? And I'm going to argue to you, no, you don't lose anything. But you can ask me later why. Anyway, this is now also out of date based on the TAF FTC information that I told you. But this is something else that I print out and I keep in my clinic. Because when you have providers who don't think about this and obsess about it every minute of every day, it can be hard to remember which drugs have data and are recommended in what populations with what risk exposure. So again, this is in the IAS USA 2024 guidelines, and you can find it there, or I'll update this to include the new information about TAF FTC, which didn't make this slide set, but I think sort of graphics like this end up being really helpful for clinicians who are trying to encourage to do PrEP, but the data are coming out so fast and furiously that it's hard to remember. Let's talk about lenacapavir. Charlie already presaged that I was going to talk about this. You've heard about it. You know it's FDA approved as part of heavily treatment experienced individuals. You know it's a subcutaneous injection every 6 months. And Charlie already also presaged the issue about there needing to be an oral overlap on the first 2 days of administration. And it's going to save the world, apparently, because it's Science's 2024 breakthrough of the year, if you did not hear about that. Why is that so? 2 trials were done that looked at lenacapavir for pre-exposure prophylaxis called, wait for it, Purpose 1 and Purpose 2. I'm going to ask you to focus on the blue bars in these. Left side of the slide, Purpose 1, cisgender women in Uganda and South Africa. These were HIV negative adolescent girls, young women, ages 16 and up, randomized 2 to 1 to either len, daily oral TAF FTC, which I already told you was in there, and then a control arm of daily oral TDF FTC, which we know can work, but people don't like to take it. And the primary comparison of both of these studies was actually comparison of the HIV incidence rate to a statistically determined, mathematically calculated, counterfactual background incidence. What? There was no placebo arm in any of these studies. There's a complex algorithm based on a recency assay, basically a detuned antibody assay, which gives you a sense, based on the people screened in this population, what the HIV incidence would have been. It's a mathematical calculation in this particular population. This is the first time regulatorily planned studies, called pivotal studies, that are supposed to lead to regulatory approvals, used this technique. As Charlie said, June 19th of 2025, if things happen on time, which who knows, we will find out if this is a successful strategy. Film at 11, stay tuned. On the right side of the slide, a similarly designed study, but no TAF-FTC, because we know TAF-FTC works for cisgender men and transgender women already from the Discover study that I told you about earlier. This study was not just cisgender men and transgender women, it was also transgender men and non-binary individuals, which was a happy approach that they took. Again, a counterfactual comparison was the primary statistical inference. These are the results. You've probably seen these because they've been splashed all over creation. Left side of the slide, take-home message, the sort of aqua bar background HIV incidence, 2.41 per 100 person years in this population. In the red box, the LEN arm, 0 HIV infections. This is the cisgender women. So 100% reduction in HIV incidence, no infections. But what I'm going to ask you to take a look at is in the lower left corner of that left side of the slide. You see that thing where it says median follow-up duration, 44 weeks? So the study was stopped very early, right? So 48 weeks is a research study year, right? I mean, we know there are 52 weeks in a year, but, you know, people who do clinical trials, we think oddly, 48 weeks is what we call a year. So if you give an injection every 2 months, and it's on a 48-week year cycle, and the average length of follow-up is 44 weeks, so the average person only got 2 injections. Hold that thought. On the right side of the slide, purpose 2, again, cisgender men, transgender men, and non-binary individuals. Background rate about the same, 2.37 per 100 person years. 2 incident HIV infections for an HIV incidence rate of 0.1 per 100 person years, a 96% reduction in HIV incidence compared to the counterfactual background incidence. Also really impressive results, stunning even. But again, look at the number of median follow-up weeks, 39 when it was stopped. So 100% efficacy, 96% efficacy. Let's take a second and unpack the 2 infections that happened in Purpose 2, because that's all the data we have. And you're all thinking, well, you might be thinking, does Levi happen with lenacapavir? Answer, it doesn't appear to. So this is one participant who acquired HIV in Purpose 2. The infection was detected at week 13, so 3 months on study. So a lot of people say, were the injections delayed? Well, no, they got 1 injection and they acquired HIV before the second injection was due. So no, it wasn't late. The concentrations of lenacapavir were as expected. The HIV testing pattern was fully evolved. So the rapid was positive, the antigen antibody was positive, but look at the viral load. It's like 900,000. And there was lenacapavir resistance in this isolate. No, that probably wasn't transmitted. Now, we don't use lenacapavir as first-line treatment, so maybe it doesn't matter so much right now, but it's something to keep in mind. The second participant, the lenacapavir concentrations were a little bit low at the beginning. The HIV infection was detected at the moment, at the visit where the second injection was occurring. So no, again, it wasn't delayed because it was detected at that visit. And this testing pattern was a little bit different. The rapid test was negative, but the antigen antibody test was fully positive. The viral load was 14,000. Now, and there was len resistance in this case as well. Now, you might say, okay, 2 infections, very infrequent, do we care? So we care about any HIV infections, right? Because I think we need this relatively brief follow-up here. But what I am most concerned about is how often, even if we're giving people an every 6-month injection, are we going to HIV test people? Right? Because both of these infections that happened, one of them was at 3 months with a viral load of 900,000. So this person, if not tested at 3 months, would have been walking around with a viral load of 900,000 thinking that they were protected on PrEP for another 3 months. It's going to be very interesting to see what the guidelines are about whether you can actually only test at 6-month intervals or not. I have thoughts about it. I'll share them with you if you're curious. Okay, so no Levi. But I'm going to end with this. So I don't want to be dramatic. I don't want to scare anyone away from the science breakthrough of the year. But I've given lenacapavir to one patient. It was in the treatment setting, and you know, he's a fairly skinny guy. But this photo on the top is what he looked like 3 days after I gave him his lenacapavir injections. He was hospitalized on IV narcotics for pain control. And because, you know, I work in a tertiary quaternary health center, he was on Vanc and Zosyn. That's a completely different story. We had them stop that. But the lower right-hand corner is what it looked like 6 months later. Now, the company that makes this product tells me that I did this because I injected it wrong. And maybe that's true. The biopsy that we took at 4 months suggested it was not intradermally administered. It was in the subcutaneous space, and it was a foreign body granulomatous reaction, which has been previously described. But, you know, if I am kind of a terrible, and well, not me, I didn't give the injection. My clinic people who give injections all the time are bad injectors. I suspect there are some other bad injectors out there. I'm told this is an absolute outlier, and certainly the rates of discontinuation in the clinical trials did not reflect this. But I think the short follow-up that we have to date, to me, means this story is not over. Because I'm over time, I'm going to stop there. I'm happy to answer questions about this and talk about future agents that we didn't have a time to talk about. But I think it's a very exciting time to be in HIV prevention, where there's more options and a greater menu of things is going to be great for all. Thanks.
Thank you, Rafi. Thank you, Meredith. We'll do questions. I want to make a couple of comments. First off, it doesn't surprise me that in France, and perhaps all over the world, that the day they focused on was Wednesday, because it's often known as Hump Day. I'll just say that. The other point,
I did not say that.
The other thing was that the Discover trial was misspelled. It's not DIS, it's DES, like for Discovery, so it's Discover. Just make that clear. And that the best way to stop the biologic aging clock is to die. I just want to make that point. Okay, we'll take questions now.
Or simple.
Rafi was hysterical. Anyhow, Meredith, a question. And this is another thing that's been bothering all of us for all our lives. You know, it's 2025. Why are we still sending up smoke signals and banging on drums to do diagnostics for syphilis, looking at treponemal and non-treponemal antibodies? Is there a problem? I mean, why don't we have a more modern approach to diagnostics? What is the obstacles? We know, is it that, you know, why can't we PCR this out of blood? Is it that treponemes aren't circulating during different stages? Why has that all failed?
Yeah, that's a good question. I think there needs to be more investment in it. You know, syphilis actually was cultured for the first time several years ago, which we always thought it couldn't be cultured. But you do see kind of systemic dissemination right after infection. And they are working on those tests, but I think we're just not there yet. And there just needs to be more investment, I think.
Charlie?
So just two comments for Rafi. Fantastic presentation, obviously very fast-moving field, and it was a fast-moving presentation. Just a couple of comments. One is with respect to the relative efficacy of TDF versus TAF for rectal versus vaginal prevention. We tend to forget that TDF, tenofovir disoproxil fumarate, is a drug that has an oral bioavailability of about 30%. So when you take 300 milligrams of TDF, 200 milligrams of that drug simply sits in your colon. And what a perfect way to prevent topical acquisition of HIV. That's probably also the same reason it causes you to lose weight, because it doesn't make your GI tract feel very good. And then the second note of caution is about interpretation of the case control data for TAF adherence. So it's always hazardous to base efficacy of a drug on an as-treated analysis. And the reason is that people who are highly adherent to anything in a prevention trial also tend to have less risk behaviors. And that's been shown in cardiovascular disease, high blood pressure, blah, blah, blah. And, you know, we haven't looked in great detail at HIV sexual acquisition, but it's almost certainly true. So just note of caution in that interpretation.
No, Charlie, I completely agree with you. And that actually is one of the big differences between IPREX and voice is risk behavior and correlation with adherence. Right. Yep. So completely agree with you. It's probably the best and only data we're ever going to get. However, and as you know, we often are, as clinicians, are put in the position of making good clinical decisions absent ideal data. And this was supposed to be the study that was going to evaluate TAF-FTC for efficacy for vaginal exposures in cisgender women. And this is what we got. I do think the devil will be in the details when the paper is presented. I think the person who presented it at CROI was one of the investigators and probably did not have access to all of the data that people were really curious about. And I felt terrible for her in the moment, as I'm sure did many.
I also agree with you. I seriously doubt the FDA will accept that for approval of TAF for prevention. So if Gilead ever wants that, they're going to have to do a different kind of study. Thanks.
Charlie, don't go far. Rafi, that was really a great presentation. I think you mentioned it, but one really important difference between the studies of cabotegravir and the studies of lenacapavir is that infections at baseline were excluded from the lenacapavir studies. And I think this is true. In 084, at least for the first 2 years, there were actually no infections in women that weren't present at baseline. There may have been one now, and I don't know if that's been reported, but so actually the results are actually quite similar. The same within men. You know exactly the proportion that were at baseline. So they're not that different in terms of activity. Is that safe to say?
I think for women, that is absolutely true. If you look at people with on-time injections in 084, there were 0 incident infections. It's not quite as exact, but the numbers are so small in both studies, but in the MSM study as well, that they're probably comparable, yes.
Yeah, the reason I want Charlie here is that the first person on Purpose 2 that became infected actually had the most unusual lenacapavir PK, right? They got one injection, it went down, and then it went up again. And it turns out, actually, the one infection that Raj mentioned on the 2 antibody lenacapavir study also had a very unusual lenacapavir PK. Cue Dr. Flexner.
I don't have an answer, Joe. I think there's a lot to learn about those kinds of curious pharmacokinetic curves. I suppose it's theoretically possible with a depot injection that the depot gets scarred and drug concentrations begin to fall, and then you get punched in the stomach and the drug concentrations increase again. I just don't know. So I think there's a lot to learn.
I do think there's a lot about the PK of these long-acting injectable products that we don't fully understand. And, there's a little bit, I think, a lack of motivation to fully understand it because the products are so astoundingly effective. But if you look even within the cabotegravir concentrations, I mean, if any of you are bored and want like an excellent sleep aid, go into some of the early cabotegravir prep papers and their laboratory supplements, which it's all my fault. But there are some sawtooth curve patterns of some of these cab prep failures that nobody understands why the drug is behaving the way it is. There's a fair amount of inter and intra of individual variability in these PK profiles.
I will also say I've learned so much about lenacapavir injection that I never wanted to know, but it is complicated. We sponsored a focus group on whether or not self-injection of subcutaneous lenacapavir was a good idea or not. And there's a high incidence of leakage from the injection site. I mean, imagine a drug that's supposed to last you for 6 months or a year, and half of it leaks out on the day, within a couple of days after injection. So the manufacturer recommends using a Z-track injection, which, I suppose can prevent leakage, but might lead to the Landovitz reaction. So
do not call it that. Jared Beaton already hates me.
Wait. I thought it was called a Landovitz lump. That's what I've been calling it. Otherwise known as an LL. But
better than the Landovitz hump.
True. Good point.
Charlie.
So Meredith, there's a doxy question here about STI prevention in women. Are you recommending it? Because most of the studies were done in men. Does it work?
Yeah,
Should.
Well, so the DPEP study, as I discussed, had a null result, unfortunately, but low adherence. And then there was a trial that was being conducted through the ATN that just got canceled yesterday to look at doxypep in cisgender women and others assigned female at birth. So we don't have an evidence-based answer. Anu Hazra presented data on folks who were getting doxypep at 3 different clinics. I think this was at the STD prevention conference a few months ago. And it's like 0.5 or 0.6% of all doxypep prescriptions are for cisgender women. So some providers are doing it. I have yet to do it just because there's very little data. But I think just like everything, shared decision-making with your patient, the data that's been published by Rich Holland from the CDC, looking at tissue concentrations would make us think that it would work. It should work. Yeah. But we just don't have the data to support it in clinical trials.
Yeah, I guess we've been burned enough where there aren't data. We go with an instinct or extrapolation and we get burned. But most often, biology is biology. And I'll say the same thing about TAF. For prevention, it's hard for me to imagine that it doesn't work. I mean, it just makes sense. So it's not FDA approved. That's what we say at the beginning of the meeting is, some stuff is off label. I guess that's one, but it just doesn't make sense to me that TAF FTC would not work in the Descovy study. Yeah.
The one other thing I would make just on that one topic before we go to your question is there is at least one that I know of, ongoing study of doxypep in cisgender women in Kenya using a standing weekly dose of 200 milligrams rather than a post-exposure dose, since that didn't seem to be sexually congruent. And last I heard, that study, the study does not have federal funding, actually, so perhaps it will go to completion. But at least we'll get those data, which could be proof of principle.
Yeah, and actually what I thought you were going to say, Rifi, is there is a study among female sex workers in Japan, a small study, doxy prep. So I think it was 100 milligrams daily. Yeah. And it did show significant reductions in STI incidence in that population. It was like a pre-post, but really small study, but sort of proof of concept.
It's called the DUH study, I think. Yeah.
This is my favorite conversation I have with Rafi every time we meet. We've got these people who are at risk for getting HIV, but they don't come to HIV clinics because they don't have HIV. Who is going to give those people PrEP? I've advocated very much for giving TDF or TAF-based PrEP because even psychiatrists could learn to do that. They use lithium, so they can learn to do tap. Maybe. But how do we get access to the population of patients who are at highest risk? And they're in substance abuse treatment programs, and they're in psychiatric hospitals, and they're in emergency rooms, and they're in settings where people who know about PrEP are seldom present. I can't get people to screen Hep C in drug addiction treatment programs. I've been working away at it, pounding my head against the wall and trying to get people to screen for Hep C in every treatment program in Maryland, because if we did that, we would really reduce the Hep C prevalence in the state. But you can't get people who are focused on addictions to think about the whole patient. You can't get people focused on psychiatry to think about the whole patients, and can't get people in HIV clinics usually to think about depression, because one of the things about integrase inhibitors that people don't mention is we regularly see people get depression from integrase inhibitors. Hardly ever gets mentioned. I see it, other people see it, but hardly ever. And getting people to screen for that is really hard. So this kind of idea that we're all in these little silos of what we see and that we're not really thinking broadly is really tough for our patients.
No, thanks, Glenn. I think it's a really good point. And, we could, have an entire, day session on how broken our health system is, which I think, that is just evidence of. But I think people who are trying to optimize access to these incredibly powerful biomedical prevention strategies are thinking about how to integrate it into primary care settings, non-ID settings, non-medical settings. And, there's some really exciting work that's been done in low and middle income country settings about deploying prevention services in beauty salons and barbershops, which I think is incredibly insightful, and, is a paradigm we need to think more about. I think the whole issue of integrating it as part of whole patient-centered care in myriad primary care settings, including substance use, psychiatry, et cetera, is an incredibly important conversation that I fear is going to be on hold for at least 4 years.
Well, a world of HIV positive bald people.
Yeah, it's a world of HIV positive bald people, yes. Another DoxyPEP question. What are your recommendations for offering it to patients? What's your trigger, Meredith, for when you say, okay, I think this would be a good idea for you?
I used the CDC guidance with bacterial STI in the past 12 months. I think this might be an evolving discussion for who is considered eligible as we get more data on antimicrobial resistance and other side effects. There's some data now that if you offer it to folks who are getting more or who have more than one infection, so 2 or more infections in the past year, it's just a more efficient way. You prescribe less and still reduce 2/3. I think that's coming from the DoxyPEP study. Still reduce 2/3 of infections. So I think it's probably an evolving conversation, but that's what I use right now.
Yeah, and Rafi, similar question about DoxyPEP. What's your feeling about for women using intermittent or on-demand PrEP?
So there's some modeling that suggests it should work. We don't have any clinical data. The British HIV guidelines have actually come out with an endorsement of pericoital TDF use for PrEP. It's 2 + 7. So a double dose and then 7 daily doses, so 6 additional doses post-coitally. I've talked to a number of pharmacokinetically focused people, and no one can figure out where that came from. But hey, there's a recommendation, so maybe that's a reasonable thing to do. But it should work.
And then the study from Mackenzie Cottrell presented at CROI to 1, 4 ones as being the PK book. Yeah. As being
Great.
What would be.
And
Yeah, so
Mike, this is a question you didn't ask, but what about TAF FTC on demand?
Yeah, what about that?
Yeah, thanks. So Jean-Michel Molina, who is the Parisian investigator,
He's the guy with the beret.
Yeah. I'm sure he wouldn't enjoy being called that, but yes.
Okay.
He is currently doing a study in France and Thailand of single dose, single dose, post TAF for PrEP in cisgender men and transgender women. So I expect we will see the results of that in the not too distant future.
Do you remember what the dosing is? Is it 2-1-1-1-1 or
I think it's 1-1-1.
1-1-1. Okay.
No, just 1-1.
Okay.
Well, yeah.
Got it. Clear. All right. So thank you all very much. It's been a wonderful morning, as usual, at OPMAN. So, as usual, I picked a number of cases to bring up issues that I think a lot of us are struggling with. Some of these are easy, some of which are not. We'll have our panel here to argue with one another, hopefully, in some degree. I also have the iPad here, so if folks want to raise issues as we go, I'll try to incorporate those. You're invited also to come to the microphone to push back if you want. We'll go till the time's up or we run out of questions, whichever comes first. These are questions that often arose in the clinic and what we're dealing with. So I don't have any conflicts to report. We're going to cover starting HIV therapy, which Joe Iran's already done for us, so we'll probably go quickly through that. What do we do about HIV treatment-associated weight gain? Co-infection with HPV, we've talked about a lot, but I'm going to bring it into a clinical context. And then talk about a regimen that failed from PrEP. Talk about bacterial vaginosis. We didn't get into that with HIV, with this STI overview. Skin lesions and fever and heart failure. So what should I use as initial therapy? Dr. Iran kind of covered this, so I'm just going to go relatively quickly. Newly diagnosed person, viral load 280,000, CD4 count 65, wild type virus, which you don't know at the time, but let's assume you did. No prior medical history, normal renal function. Wants to start therapy. Which would you choose? Go ahead and vote.
So while people are voting, one thing that Raj didn't mention, there actually was a randomized trial in Freud, the largest randomized trial ever to be presented as a poster, comparing second-generation integrase inhibitor with the boosted PI in people either with an OI or CD4 less than 200, an area where it's really a data gap. So anyway, for whatever it's worth, we finally have a randomized trial that.
And the answer was?
The answer was the second generation and then second generation NST, right? Yeah.
Right, and that's kind of what you'd expect. And the audience is consistent with itself. It looks like it voted the same way. I don't know that I want to spend a whole lot of more time on this, except that if we go back, let's go to the slides if you don't mind. Dolutegravir with TXF or XTC is kind of the number one regimen worldwide. It's used a lot in sub-Saharan Africa. And we're hearing a little bit about dolutegravir resistance at the CROI meeting. I don't know if anybody picked up on that. It's uncommon. It doesn't happen that often. It kind of gets back, I think, Joe, to your point about lottery tickets and burning your money or something, and that's kind of true. But there was some change. There was some esoteric discussion to some degree about resistance being conferred by locations on the viral genome that were not in the integrase region. Joe, you want to comment on that?
Yeah, so it turns out that almost everything that probably everyone in this room was taught about how HIV actually replicates in the cell is actually wrong. The capsid goes all the way into the nucleus, and it turns out there are important interactions between capsid and integrase that are required for integration. So a group at NCI Frederick, I think that group, and then a group of people from clinical trials actually found that there are these capsid mutations that occur sometimes alone and sometimes in conjunction with integrase mutations that may be like secondary mutations or increase the level of resistance or decrease susceptibility. So it's actually biologically now makes sense. And whether it has any clinical importance, I think right now is not known.
Right. So that was kind of news out of the meeting. I think I'll, just in the interest of time, move on. Rafi mentioned about the ISUSA guidelines a couple of times. I was smiling to myself during the presentation because the guidelines were referred to in the third person, but actually Dr. Landovich was the second author on the paper, so it was hard to distinguish there, but it was good. It's a wonder why those comments were directly lifted from the guidance, but I think they're actually pretty current and helpful. We'll see what happens as lenacapavir gets approved in June if all things still work in the government. We talked about a little bit about weight gain already, and let's just go to a case about that. A woman who started Big TAF FTC 12 months ago, fairly early, not very advanced infection, had a nice response as you would expect, but her BMI went into the obese range soon after, but her fasting blood sugar was in the sort of early pre-diabetic, and the hemoglobin A1C is also pushing that boundary. What do you recommend besides obviously diet and exercise? No changes, change to non-TAF regimen, non-INSTI regimen, start metformin, refer for bariatric surgery, which, believe it or not, is still being done to some degree, start semaglutide, or some other option. Go ahead and vote. Okay.
Nobody's getting bariatric surgery.
All right. So looks like the majority would start semaglutide. There's some folks saying leave her alone. Some starting metformin. Okay. What does the panel think? David, what do you recommend in the echo chamber out there in the West?
So I think the challenge is, we can talk to people and tell them, the data, it's very confusing. It may not help to do anything. But a lot of times I have a person that comes in and they read about this and they say, I want you to change my regimen. So when I have that and they're saying, I want something different, then the regimen we've usually used is doravirine, TDF, FTC. That's a regimen we've usually gone to, whether or not that and I tell them probably the best thing we can hope for is for them not to continue to gain weight and to stabilize. And I try to be very realistic and say, we don't know this is going to help, but the best we can kind of hope for is that it's going to stabilize their weight. And if people are, really with a high BMI, then we'll talk to them about GLP agonists. And but we have a multidisciplinary approach in the clinic with that, where our pharmacist gets involved with a lot of that. But that's kind of the initial approach we take. But I think it is challenging sometimes because people are really insistent they want to change.
Other thoughts, Rafi?
No, the only thing I would say is we're actually going to get data on that strategy imminently. There was an ACTG study, 5391, that took people on TAF, second generation INSTI containing regimens, and randomized them to switch either to doravirine or lose their TAF to TDF or both. Is that right? And we'll be getting those data hopefully imminently. I'm looking at Joe since.
Yeah, the primary analysis has been done. So
okay.
It's got to wait till it gets written up and presented. So we'll find out. I don't know.
So someone knows the answer to that question. We don't.
All right. My guess is that. Go ahead, Charlie.
There's also the John Prine approach. Move to the country and blow up your TV. we live in a country that's basically designed to make people gain weight. It's hard to fight that.
And I don't have an easy answer to it because, as we all know, behavioral modification of anything is almost impossible. Dr. Treisman will reinforce that tomorrow. But I do think we just need to be aware of the fact that anything we do that makes people feel better about themselves is likely to be associated with weight gain, and sometimes unhealthy weight gain.
Yeah. Just to add, sorry, Mike, at CROI there was an amazing presentation from Uganda, which looked at these 50-something-year-old Ugandan people with HIV who had been on an integrase for a long time. Some of them, and they were looking at coronary artery plaque, and they matched it to like a U.S. population where it would have been like 60%. Any guesses of what it was in this Ugandan population? It was 8%. 8%. It was like crazy, and so just walk, carry your water,
Yeah.
Don't
no television.
No social media.
Stop drinking diet caffeinated beverages.
Cheers.
Well, so does anybody want to get on the bandwagon for semaglutide here? All right.
I mean, I would, but we can't access it.
Let's say you could. Let's just say you could.
Okay, sure. Yes, I would. The patients that I do have on it who are diabetic and not pre-diabetic, we have had very good outcomes. And we tried to do kind of just a retrospective cohort study to compare it to metformin, and we saw more, weight loss. But when I can't access semaglutide, I do start pre-diabetic patients on metformin.
Yeah. So that's kind of the way we've been moving forward. The bariatric surgery is really reserved for people with very high BMIs in the 45, 50 range. And it can work, although a lot of times people overeat the sleeve. But semaglutide has been getting more and more data that show that it's not just good for weight loss, but an awful lot of other, we mentioned the biologic clock. I don't know exactly what to do with that, but I'm glad it goes in the proper direction. But there are more and more studies with liver fat, heart failure, arthritis, cognitive.
Apnea.
Yeah. So we'll see. Maybe by next year, this will be a little bit stronger
I would
vote.
say for people that actually, tirzepatide is much
Yes.
easier to get. And it also there's no requirement for raising the dose, right? With semaglutide,
You got to bump up.
If you get a prior auth, they send you these, time to get, increase the dose. So, and I've had a little more success getting it because the lower doses of semaglutide are rarely available.
Correct.
And that's not the problem.
So you use tirzepatide if you can. It works a little better too as far as weight loss in general. Okay, so we'll just bookmark this for the future. So this is an interesting question because we've been seeing a lot of data on hepatitis D or Delta virus. So should I be checking this? And there's a follow-up question of what to do about it. So 48-year-old, newly diagnosed 4 months ago, was started on dolutegravir TAF FTC. The initial viral load was the same as our original case. And then we check hepatitis B, and they're antigen positive, antibody negative, E antigen negative. And the question comes up, should I check for hepatitis D or Delta virus? Go ahead and vote. All right, so about 60% of us say yes. We might get some of our liver docs to weigh in here as well. But how many people on the panel actually routinely check for Delta? Nobody.
Well, routinely depends on, so you really only should be checking it if you get a positive Hep B surface antigen test.
All right, so that's antigen positive.
Yeah, so, but routinely in those people, I would say we're not routinely doing our clinic, but people are starting to do it intermittently. Whereas a year ago, nobody did.
Right. Yeah, so all right, so the data are, and Mark double check me, fact check. In fact, you may want to go to the microphone. So the data are that somewhere in the United States, somewhere between 8 and 12, 14% of people have Delta. And then the question is, what do you do about it? But Mark, what do you think?
No, I think the guidelines that we're following right now for this say that people with HIV are at increased risk for Delta, therefore they should be checked. S antigen positive, they should be checked. Many parts of the European guidelines have moved to anyone who's S antigen should be tested. We're not there yet, but for this group of people, absolutely the recommendation is to be tested.
Okay, so let's stay at the microphone, please. So the next question is, if the Delta virus result is positive, antibody and RNA, should I use bulevirtide? Let's go ahead and vote. Not sure. Okay, good. And one of the reasons you're not sure is, how do you get it? So, Mark, do you want to continue the conversation?
Yeah, I'm happy to weigh in. This was a medication. It's injected daily, and it blocks the NTCP receptor where the surface antigen binds. So it's used for Delta in Europe, where they got initially a conditional approval and now a full approval. So they're using it pretty routinely. It's got a good safety profile, except it has to be injected every day, and normalizes liver tests, reduces the HDV RNA. So it looks good. The U.S., they've been working on issues related to formulation and the vials of this. Yeah. So as of today, it's not available to U.S. clinicians.
Correct. So in the treatment, as I understand it in Europe, it's just for a 48-week period?
Well, that's debatable. I think most people would say it needs to continue indefinitely because this is a tricky virus to cure. And it does look like if you add interferon to it, it works even better. So some centers will add interferon to it. So in France,
if they don't like the patient, they add interferon.
No one likes interferon, but so the treatments are now. There are some oral NTCP inhibitors coming in clinical trials. So, but it would be a nice addition. This is a group of people where the only recommended therapy is interferon at relatively high doses. So
yeah. So to me, this is one of the bigger conundrums. It's kind of a little bit of cult now. Thank you, Mark. It's a little bit of cult now because we don't have the drug available to us. But the data are pretty consistent that besides the acute acquisition of Delta that can cause fulminant liver failure, which we don't see all that often, but sort of chronic Delta virus, and it does have associated with it worse outcomes. There are it's faster progression to cirrhosis and some other bad things. The question is, how and when do you pull the trigger? It's an injectable. May have trouble getting people just to adhere to regimens of antiretroviral therapy, period. I just brought it up to flag it for future discussion, but it is something that is emerging. All right. So Dr. Flexner's question, can I start a long-acting ARV in someone who's already got, who has HBV and long-acting agents? This is the same person. I just kept the same stem. Doing well now, started this over a year ago, but he's heard about this on TV because he didn't follow the Charlie Pride thing. And he wants to simplify to ropivirine and cabotegravir. His viral load now is suppressed. Not going to get into the issue that Joe talked about, I think, Joe. And CD4 counts 270. You check now, you go back and you say, well, wait a minute, what's the hepatitis B status? So which of the following would indicate that you would not start ropivirine? I realize there may be more than one right answer, but pick the best. Which is the one that says, yeah, we shouldn't start, or we should just not start with any history of HBV, core antibody positive, for example? Go ahead and vote. All right. So it looks like most people said antigen positive. Charlie, what do you think about that?
So, your question was, can I start a long-acting in someone who's...
Yeah, the problem with words is that they have meaning.
That's true.
That's a big problem.
The answer, of course, is always yes. But then the question is, what else do you do? We talked about vaccination for people who have not been vaccinated. I think that's key to not forget about that. Hopefully everyone in our clinic has already gone through that algorithm. I think this is not as nearly as big a problem in high-income countries as it is going to be in low and middle income countries with a high prevalence of co-infection, where it's going to be huge, because just simply the cost of testing people before switching is the cost of a hepatitis panel is more than the annual cost of oral antiretroviral therapy. And I think most governments are just going to say, no, we're not going to do that. So, I think I agree with the audience in terms of the answer. I think this is, well, you could start long-acting injectable ART, but tell the person you got to go on oral anti-hepatitis treatment.
Yeah.
Which probably nobody wants to do.
That's going to be true for sure with the answer the audience picked. Hepatitis B, surface antigen positive. I think most folks would agree. If I could go back to the slides real quick. The next slide. Whoops. Yeah, there.
By the way, we had a really nice workshop on Tuesday in Los Angeles on how to promote development of long-acting injectable anti-HBV drugs. And hopefully that will solve some of these problems, but it's years away.
Yeah. So there's a couple of smaller studies. There was a couple studies at Croy, but I think this study might be a little better. This is from the VA 2 years ago, presented at ID Week. And I think the take-home point is here. If somebody has never been surface antigen positive and has always got surface antibody, their risk of a flare after switching is very low. If they're antigen positive and never surface antibody, that's where you have most of the trouble. So I think that's the take-home point. A second take-home point is if someone last year I brought the case of an isolated core. And I brought the case because I was always scratching my head about what to do. I think the right answer, I think Ken Sherman said this last year, vaccinate them. Just get them to get a surface antibody, and then you might have enough protection and see. So what do you think, Dave?
Yeah, I totally agree with that. And this came up this morning, that maybe it was Raj that said it, or Joe that said, in this exact scenario, they would vaccinate before switching them to cabrolipivir. It's exactly what we do. And even though the guidance don't say give 2 shots of Heplisab B, that is what I would do.
Yeah.
And because Heplisab B is only a month apart, and time can really be of the essence in some of these individuals that you're trying to get on cabrolipivir due to other issues. So I think it's really very convenient that you can do 2 doses 4 weeks apart, check a serology 1 month later. 2 months later, you should be able to have the person vaccinated and a documented.
Right, but the issue is that during that 2 months, they will have seen 73 commercials on television telling that should be on cabrolipivir. Mark.
Yeah, well, I wanted to make, I guess, 2 points. One is that we will talk a lot more about hepatitis tomorrow. I have a couple lectures on hepatitis, and we'll lean into this pretty heavy.
Of coming attractions.
No, this is great. But I did want to make the point that what we're talking about is this issue of reactivation. So people who are core antibody positive, most of them are going to have intact CCC DNA in their livers. It's being held in check by the immune system. The data on whether or not the S antibody keeps reactivation down is not as robust as one would like, but there is data to support that, as you suggest. So I think what we're trying to do is boost the immune system so that will hold this intact CCC in check. It's a little bit different than preventing primary infection. So you've got, so it's a different indication. It's trying to keep a existing infection in check. And I think the discussion of titers is really interesting one, because I'm not sure I wouldn't, just keep pushing. We can't get titers at our lab at Hopkins. So I'm a little bit interesting to hear this discussion.
Yeah, it's because y'all never see hepatitis there. It's a problem teasing. Hopkins has been like one of the main leaders in hepatitis B, C research for several decades now. Okay, just wanted to kind of get that out there. So what should I use as initial therapy in the setting of a PrEP regimen failure? So this is a 28-year-old guy who was newly diagnosed after having been on CAB for every 2 months for PrEP and has not missed a scheduled dose. Detected by routine antigen antibody test. They had actually read Dr. Landovitz's statement. HIV RNA is kind of low here as opposed to that lenacapavir failures that we heard about. But CD4 count is high. Other labs are normal. Normal renal function's okay to start therapy. We don't have resistance data. So do you use, it's more or less the same listing that we had, except now we've added lenacapavir as an option and have darunavir or ritonavir. Let's go ahead and vote, and Dr. Landovitz, I'll have you walk us through this. So a lot of folks, most folks went with BIC-TAF FTC, and we had some with darunavir, we have 1 or 2 lenacapavirs. Dr. Landovitz, would you put this person on BIC-TAF FTC in this setting?
So the devil's in the details, and Mike, you didn't give us enough details.
Of course.
So you said he hadn't missed a dose, but you didn't tell us if any of his doses had been delayed.
Let's say they've never been delayed.
Because, what we have seen in the 083 study is anyone who fails CAB prep, which is a rare but event that happens with on-time injections, all of those people have integrase strand transfer resistance. The devil is further in the details of, well, what integrase resistance do they have? Because not all integrase mutations are created equal. And as Joe was just telling us, right, we don't even know where to look for all of the information about integrase resistance. The viral load is probably too low to get a genotype in this case. I probably would start this person on a boosted PI to start, and maybe when they were undetectable for some length of time, I might consider switching them to a dolutegravir or a bictegravir containing regimen. I probably would not do it up front. The available data from the clinical trials just isn't robust enough to know the right answer for sure here. I would be anxious about putting this person directly on a bictegravir or dolutegravir containing regimen, even though the viral load is quite low to start with. And it might be okay. And it might be okay initially, but I would worry about a late failure. I know Joe has also thought a lot about this, so I'd love to hear his thoughts on it as well.
Yeah, I don't necessarily disagree with the people of quick choice B. There's a couple things way back in the last century when we did AZT3TC, the first AZT3TC study. If you looked at people with viral loads, if you looked at viral loads less than 1,000, most of those people suppressed.
Yeah.
So probably TDF, TXF, XYZ would probably be sufficient. And you don't know whether the integrase inhibitor is actually working or not, and then you may never know. I think Rafi's approach is the safest approach, personally. Again, sentencing someone to a life of a boosted PI has a lot of negative consequences. This is an argument where you could do that, but also get a proviral DNA. This, as much as we, these are really uncommon. This is not like getting a proviral DNA every time you go to switch to carbopivirine. So that might give you a clue as to whether you would feel uncomfortable going to, because if you get it early enough, you may not have a major integrase mutation. You may have one where bictegravir or dolutegravir is active. So I do think the safest thing to do initially is what Rafi said.
The one other thing, we talked earlier in Joe and Raj's session about, what might be the clinical use of a doravirine, islatravir regimen. This, as long as they don't have Hep B.
Hey, I had a question for Rafi. So these people that have Levi, do we think they would have a different set point since they're essentially getting antiretroviral therapy at the time they're getting acute HIV or primary?
So I don't think we know anything about set point, but the question has really been raised about whether the reservoir is not seeded at the same extent and whether prolonged antiretroviral therapy might actually even potentially be curative in these people who've never had a high viral load, or if not, maybe that they might be an outstanding candidate for a future cure study intervention. This is sort of being investigated actually in an ongoing observational study within the ACTG where people who have broken through CAB prep are being followed longitudinally and samples collected to assess the size of the reservoir in people who've never gotten a viral load that's over 1,500. So if any of you have such a person and want to refer them to that study, please do. We've got 4 right now.
Thanks. So Rafi, do you think this event is rare enough that we will never be able to collect prospective clinical trial data to know the answer to this question?
I do think it's going to be really hard to get a definitive answer to this. There's a group out of UCSF that took over an NIH-funded project that I actually don't know if it's still standing, called Zero Prep, which for anyone who fails any prep regimen, you can remotely enroll them in this virtual cohort, and they will draw blood levels and do dried blood spot analyses for biomarkers of adherence and resistance and hair levels of drugs, and be really helpful in terms of disambiguating some of these things. And they have now presented at CROI just last week 4 additional cases to their previous set of 3. So now 7 people who had broken through CAB prep, and they had treated with various regimens. Almost all of them were initially treated with a boosted PI, and then some of them were switched to an integrase later. And we presented some data, a case series of 47 people at CROI last week, only one of which had an INSTI-resistant mutation, which was the R263K, that was treated with a bictegravir-containing regimen and suppressed. But an N of 1, I don't know that I would make a lot of clinical decisions based on that.
I think there's a couple really important points about one thing that Rafi said. If people keep going, well, what about covering the tail, covering the tail? It appears that covering the tail is probably not very important, that once cabotegravir levels get low enough, the virus actually doesn't need to be resistant to infect people. So people that miss doses or past 6 months of a dose, we don't actually see resistance. It may happen, but that's one point you were making, I think, Rafi. And then the other thing to add to this is the kind of the partial activity or the relatively poor fitness of integrase-resistant viruses, where we know now that capsid-resistant viruses are not, there's no residual capsid activity, and capsid-resistant viruses aren't unfit, right, based on the 2 examples from Purpose 2, where they're high viral loads, single mutation. So I think that, there are definitely a lot of subtle things we can argue about for many OPMAN to come.
Yes, well, all right, I'm going to do an aside right here, like they sometimes do in theater. Let's go into the details of how the sausage is made for these questions. I don't use real cases as a rule. I go with that initial question that I ask, and I try to keep it as simple as possible to avoid the comment from a panelist that says, you didn't give me enough details, because sometimes we get tripped up in the details. But in this particular case, I used a lower viral load thinking Levi a little bit, because it usually is very low. But I think maybe a better way to get to this is to say the viral load was higher. We can get a resistance assay, save the person from being committed to a sentence of lifelong protease treatment. And we could also think about this 2 nucleoside, which is kind of, taboo and not done. But Joe, as you said, there's no reason in this case why tenofovir FTC alone would not be sufficient when the viral load's less than 1,000. It probably would be enough to hold it even without the protease.
And to be fair, doravirine with TAF or TDF FTC as a single tablet, or doravirine with
islatravir,
even rilpivirine plus nucleosides would be fine here. They don't have we don't know for sure they don't have NNRTI resistance. I guess that's the point.
But it would be unlikely.
But it depends where in the world, right? And
so that's true.
In the world where there's high rates of transmitted NNRTI resistance, you wouldn't.
Most of the OPMAN audience is working somewhere in Southern California, I think. Okay.
But NNRTI resistance is still more common.
Yeah. Doug.
Right.
Joe, I just wanted to follow up on when I saw the talk about the resistance or mutations in the capsid potentially affecting integrase inhibitors. Do you think that theoretically now, if we have capsid resistance, that we might be seeing something with integrase?
No, they're entirely different sites. Different sites in the capsid. Totally not the same as what's required to unencapsulate, which is what lenacapavir blocks. Blocks actually not dissolution of the capsid. It's actually it blocks the capsid can no longer get through that nuclear pore because it's critically important that the capsid actually break apart just at the right time.
Yep. All right, a question coming right down the middle of the plate for Meredith here. All right, so what do I do with a woman who has recurrent bacterial vaginosis? Cisgender woman followed by you, monogamous with her husband, diagnosed 10 years ago with HIV. Now her viral load suppressed, CD4 counts great, on Big TAF FTC, has a history of recurrent bacterial vaginosis. Other STI screening has remained negative. What regimen do you prefer? And there's topical therapies, there's oral therapies, and then the last one is something from above and treat her partner. Go ahead and vote. All right, let's get the microphone to Meredith here. Yeah.
Okay, so everybody saw the same study, or 70% of us saw the same study published recently, which is very exciting. So I work with Christina Musney sometimes, who's at UAB with Dr. Sag, and she's been telling me for a long time, I believe bacterial vaginosis is an STI. It is. And so we finally saw evidence recently published in the New England Journal of Medicine that if you treat the partner, then
I got the slide. I got the data slide coming up here.
Yeah.
There we are. There it is. Okay.
Recurrence rates of BV go down in the patient who's in front of you. So good to see. And they use the regimen you show here.
David Spock just fell off the table.
I mean, this is very new, hot off the press earlier this month. No updated guidelines, but
well, right.
Exciting
So
to see.
what's fast? Yeah, what's fast? I'm sorry.
This just came out after our slides were due. I was going to make that point.
Is metronidazole common 400 milligrams?
It was in Australia.
It was down under. Right. So that was the dose that was used. But I think the key point was that the guidelines say explicitly, do not treat the partner. So it's already kind of in the face rejected. But I thought that was fascinating.
So I was going back and forth with Christina Monthly this week because she does work on our curriculum. We're changing it. So she actually said this week she treated 2 male partners and was so excited about it. So it is now in her practice that this is what she's doing. So she actually thinks this really should be what we should be doing.
Yeah, well, the data are pretty strong, and she wrote the editorial.
She wrote the editorial,
in the New England Journal. Okay, just thought I'd bring that up. Great. So I probably should change the slide to 500 because we can't get 400, right?
But that's that was what the
500 twice a day is what we do.
Yeah. Okay. All right, new skin lesions in the outpatient setting with fever. This is a 30-year-old male with lesions on multiple parts of his body. He's sexually active. He has, in addition to the fever, anorexia, asthenia, failure to thrive. He's known to be HIV positive was off therapy, and at the time of this presentation has a 28,000 and CD4 count of 250. His urine drug screen is positive for meth, and he required hospitalization because of his degree of illness. What do you prefer for treatment of this? Go ahead and vote. Okay, so the question really is here. I mean, a month ago or two, we would have said, take a format, right? And now we don't know what to do. I think what Raj presented, what's key, is that in the study that showed no daylight between the curves, the initiation of therapy was at least 8 days after the onset of illness. And if we did that with Paxlovid for COVID, we probably wouldn't see much impact either. But if you treat in the first 2 to 3 days, maybe there's a difference. David, how do you throw this all together?
I think it was very disappointing, and I think the point you raised, and Rachel Bendar-Ignacio, kind of right when these data came out and they had to release it, said, well, part of the problem was exactly what you said, because they started the drug late. So that is problematic. I will, yeah. It's just the only thing I was going to say is that, let me just say, with Jason Zucker, who's a person
Yes,
I know
at Columbia. Yep.
People online can't hear it.
Oh.
Yes, go ahead.
Oh, sorry.
I feel offended by the.
You've heard of the hook.
I was just going to say, I wasn't involved in the study.
You steal the microphone. That's the way
I wasn't involved in the study, and Joe knows better, so I will totally defer to you.
You can differ. Jason was part of this study.
Yeah.
And anybody who's taking care of MPOX knows that they don't show up on day one or day two, on day three or day four. They show up after they've been to like a couple of emergency rooms for their herpes treatment. And I mean, this study, we actually enrolled people before we even had a diagnosis, right? Yeah. They didn't have to have a diagnostic test. We enrolled people remotely, so they didn't even have to come into clinic. And the 8 days is not because of the study. Right. So Rachel should keep things to herself.
No, and I didn't phrase that right. I should say, what I guess I should have phrased it that 8 days was late just to be able to prove. Right. I should have said that better. Absolutely. So thank you. It was just it didn't necessarily disprove that there was antiviral activity because it wasn't a study problem. It was just that people
the nature of things.
But I don't know if you agree with what Jason was saying. He said he would use dual therapy now for a lot of people with brincidofovir.
Yeah, no, I think I think again, you can get dual therapy through the CDC. Yeah. That so brincidofovir and tecovirimat, and that's what would be recommended for this person. For
let's deconstruct this a little bit because people are going to see this. So what do you do? So you use the tecovirimat with brincidofovir, which by itself was not effective, if I remember correctly. Not been studied. All right. Well,
in vitro, tecovirimat is tecovirimat in 2 large randomized studies was not effective.
Correct. Now the question then is, brincidofovir, fine, you get it from CDC. What about regular cidofovir with the probenecid and all that stuff? I mean, you run the risk of kidney failure, but it would be, it's much higher levels than you get with brincidofovir. Charlie.
So putting on my hat as a former pox virologist, don't forget that in addition to brincidofovir, the CDC also keeps a stockpile of vaccinia hyperimmune globulin. If I had a patient who I thought was going to die of disseminated mpox, an HIV patient who was untreated, had a low CD4 count and a high viral load, I would not hesitate to call the CDC and ask them. I'm not sure they would release it, but it ought to work.
Yeah. Okay, I guess.
As Mark points out, if you can get them to answer the phone.
Oh, boy. So the reason I brought this question to the meeting was because as I saw the Zucker study and the Rachel study come forward, I kind of said, okay, well, now what the hell do we do? I mean, it's nice. It's hard to sort of sit back with somebody who's that sick and do nothing virologically, but we don't want to just be futile in our attempts. So, all right. So the recommendation from this panel would be combo therapy with brincidofovir if you can get it, with tecovirimat. And if somebody's on dire straits, ask CDC about vaccinia immune globulin.
And I just want to clarify again, what I was trying to say was that just because the drug was given, it still could have antiviral activity. And would you agree, Joe?
Yeah,
that was the point, and not that there was any problem, because that is exactly what we see, people coming in late, and that's the challenge.
Correct. Okay.
That's going to be the challenge.
How much mpox have we seen? I've seen a couple.
The question is how much mpox?
Depends upon the part of the country.
Yeah.
Sporadic in Seattle.
I saw a case 3 weeks ago, but it's not like it was 2 years ago. I mean, it's less than we used to, but we're still going to probably see it. And that doesn't even get into the issue of the current outbreak or the recent outbreak that was in Nigeria, I think, or Congo. DRC. And that's a whole different clade and more advanced or aggressive disease. All right, heart failure. We don't talked about this at this meeting before, I don't think. So this is a 41-year-old presents with progressive dyspnea on exertion, no P&D, 2-pillow orthopnea, history of meth use, diagnosed 15 years ago, and is persistently undetectable on 2-drug regimen. So the HIV is under control. JVP slightly elevated, soft F3, trace edema, so mostly left-sided failure. Liver and renal numbers are okay. He's already on amlodipine. Former smoker, but he quit. Echo shows low ejection fraction on the left ventricle, about 35 to 40%. What do you start? This is going to date some of you, especially if you answer number one. DIG, Lasix, beta blocker, Entresto, SGLT2, or refer to cardiology and punt. Let's see what we say. All right. So in addition to my spelling valsartan incorrectly with an IN instead of an AN, as it was so pointedly just brought to my attention. So a lot of folks are going with that regimen. So Entresto, what does a panel do? Do you all try to address this yourselves, or do you send them to cardiology?
Clearly, the audience watches network news like I do, because any drug that is consistently advertised on network news is obviously way more expensive than it needs to be.
Yeah.
So these combination drugs are a way to increase the price of drugs that are going off patent, and I personally would try to avoid them unless they have clear advantages over other therapy.
Yeah. The issue is that that combo in heart failure has been shown to increase. It's with a survival benefit. The SALT-2 is also a survival benefit. DIG, I don't think is being used at all anymore. Lasix, sure. I don't know. My personal thought is that I can certainly follow guidance and throw medicines at people, but I really think cardiology should be brought in on this for a number of reasons, just because, A, they do this all the time, and I don't. And secondly, they'll probably want to evaluate for cath and see if there's some ischemic disease and that type of thing. So it's a little bit of it's a goofy question. I just tried to make up to get the status of heart failure on the agenda. I'll go back to the slides, please. Yeah, thanks.
It's not a punt, it's good medical care.
Okay, thanks. Well, sometimes a punt is good football care. You know, when you're 4th and 20 on your own 10-yard line. But so this was a great overview at CROI by Feinstein, Matt Feinstein from Northwestern, and he did a great. Just said that. Basically, it's complicated, which also tells you why you should get a cardiologist involved, because there's multiple reasons why someone at age 41 might have an ejection fraction of 35%. He presented some data from the CNIX cohort that showed with adjudicated heart failure. So that's one of the cool things about CNIX, and I realize I'm speaking about a study that I'm heavily involved in, but the outcomes are not just taken from a medical record where some things can be actually wrong. You actually find people who have a sign that they might, or on the record that they might have heart failure, and then you send the records from a hospitalization for experts, cardiologists to look through and say, yep, it is, or no, it's not. And with the adjudicated outcomes, there were 402 that were alleged to have heart failure. Only 289 were confirmed. And 212 of those were incident. But so not a huge number of cases, but kind of a good number. And overall, the age was more associated with higher age, as you would expect. But this is something that traditional risk factors were often associated with higher heart failures, higher viral load, lower CD4 count. So overall, this is something we're going to be seeing more of. And I think we just need to be aware of it and get used to it. I'll just skip through this, but the bottom line is you can have access to the slides and you can look at this yourself. But I thought it was a key new takeaway from CROI this year that I wanted to make sure we got covered. All right, so this is gets back to earlier discussion we had about DNA genotype. So what do I do with a patient that has this on a DNA assay? So the context clinically is a 65-year-old guy who got transferred to you for treatment to take over his care. He was treated somewhere in another city. He was diagnosed a long time ago, had a viral load of almost 1 million initially with a low CD4 count, had gone through multiple regimens, mostly due to toxicity, not true virologic failure. And at his other clinic, was on dolutegravir 3-TC abacavir because they read Joe Iran's guidelines. They switched him from that 14 months ago and put him on dolutegravir 3-TC, and he continued to do well. Viral load never less than 20, which you often don't see in somebody who had 1 million copies, but never above 50 or 60, and no historic resistance tests because he had never had virologic failure. And during a routine visit, you're out of town and your colleague starts to see him and orders a DNA genotype, and it's positive for an M184V, and he's on dolutegravir 3-TC. So what do? Stay the course. George Herbert Walker Bush, I got to get his quote, wouldn't be pretty back in the debt. Can stop it and start the abacavir back. Stop it and start BIC-TAF FTC, or fire your colleague who ordered that damn test. Okay, go ahead.
You're fired.
Fire. You're fired. Okay, let's go ahead and vote. Okay, so most folks, very few people would fire their colleague. I guess that's good to see. Some would put them on BIC-TAF FTC, but the majority look like they would continue on. Joe, do you have an opinion in this setting?
No, I agree with the 47% of folks.
Leave them alone.
I wouldn't do anything. I think there's a lot of retrospective observational data, mostly from Italy, but other places. Here in DC, actually, too, where people with M184V have stayed suppressed on dolutegravir.
With 3-TC alone.
Yeah, dolutegravir. Yeah.
Yeah, I think that was the point.
Because as we
it's
all
a little
know,
bit of a different question if it were prospective. You're going to switch and you want to see. But I'm not sure I would have ordered that test, to be honest, with that history. Right? Charlie, what do you think?
No, I was going to say it's because, as we all know, 3-TC lamivudine is magic.
Yeah, it's magic. Mm-hmm. Okay.
I can cite the study.
Yeah. All right, so complications of OIs. This is the only real case that I have for you today. This is a guy who we've been struggling with. It's a 35-year-old diagnosed 1 year ago, admitted with failure to thrive, etc., had advanced HIV with MAC, lymph node biopsy positive, and high viral load, low CD4 count, got treated with BIC-TAF FTC, trimethoprim sulfa, azithro, ethambutol, rifabutin, improved. 6 weeks later, developed iris, got put on steroids and improved. Came back 6 months later. Now we're about, again, total of 6 months into therapy, and he'd stopped his medicines. We restarted the medicines, and he felt better. So about 2 to 3 months ago after that, he's continuing to take his medicines, but now, which is around 5 or 6 months after he's restarted his medicines, his symptoms are sort of back, and his CD4 count is now 255, his viral load suppressed. His white count is elevated with the left shift. CT of the abdomen shows the same lymphadenopathy as before, unchanged, but now with some necrosis in the lymph nodes. Numerous lymph node biopsy done on the accessible one showed AFP, negative for malignancy, negative flow, and all cultures are sterile. What is this? Is it MAC? Is it recurrent iris? Is it a bacterial superinfection? Is it culture negative endocarditis, occult malignancy, or something else? What do you think? Let's see what we got. Yeah, we got it kind of all over the map. And this is a very complicated case, right? And I talked to Irini Soretti at NIH, and she is, like, to me, the world's expert on iris. And my 2 questions to her, one was, can you get recurrent iris? Answer, yes, you can. So that's possible. The timing of it, being 4 to 5 months out, atypical, possible. Then the second question was the more puzzling one to me. The elevated white count, which I'd never seen associated with iris. And she said there have been a few case reports. Okay, not a surprise. But she also raised the question, could that lymph node be secondarily infected with a bacterial pathogen? And so, interestingly, he's back in the hospital now. We're getting an excisional lymph node biopsy as opposed to fine needle. Hopefully we'll get the answer. They didn't culture for MAC. But generally speaking, do you guys have any general thoughts about what you think might be going on here besides a ball of confusion? Temptations?
You can definitely see iris. My record is 6 years after starting antiretroviral therapy. And it literally took them almost that long to get a CD4 above 300 or so.
Wow.
Was Mac in a cartilage in his chest.
Wow.
And, it suppurated after 6 years. He was on the original lopinavir-ritonavir study.
Okay.
But I agree with you totally that the white count is weird. Otherwise, I would have said this is recurrent iris.
So when you drew aspirate of that suppurative infection, it did not grow MAC.
It had granulomatous lesions with AFB, but
Positive.
did not grow anything.
Isn't that interesting? Yeah. Just fascinating stuff. Yeah, David.
I mean, the only thing I would add is that these intra-abdominal MAC iris has been something that's been kind of the bane of our existence in several patients. It can be really problematic with severe pain. The only thing that I would say is that my experience with steroids, at first when we started treating these, we'd give them for 2 or 3 weeks and then stop. I've not had very good luck with that. I've usually now needed to just keep people on steroids or recommended to have them stay on at least for 6 or 8 weeks and then taper down. But that short 10 days, 2 weeks of steroids that I sort of thought was the right thing to do initially, and not had good success with that.
Quick show of hands. How many folks have seen this type of iris with MAC? Good number. That's what I would guess. And it's just a conundrum.
And you know the antigen is there because of the biopsy, right?
Yeah.
The antigen's still there.
Exactly. And I don't know why the bugs just don't get carried away or destroyed, but you see them on, of course, there's so many of them with MAC when advanced disease of sort of used to be called globules or I forget what they called it. But anyway, yeah. Okay, so we're about out of time. Take-home points, art therapy should be initiated with an INSTI-based regimen. Weight gain is associated. We talked about that a lot today. Maybe not deliberately or specifically associated. If I had to weigh in on what might be happening, I think HIV and chronic infection does something to metabolism pathways that when you stop it, those pathways take folks into a direction of weight gain and metabolic syndrome that we are left to deal with. Chronic Hep B co-infection with antigen positive is a relative contraindication for non-tenofovir regimens. We'll see more about that. Bacterial vaginosis is an STI. Imagine that. And Mpox has limited treatment options. Use of a non-INSTI regimen in setting of CAB failure for PrEP, although maybe with more details we could have fine-tuned that a little bit. Unclear what to do for hepatitis delta virus. Heart failure is common and can be complex, and cellular DNA genotype, in my opinion, is generally not helpful, but I guess in selected circumstances. So that's a summary, actually, of the whole day, right? I mean, we kept coming back to this, and I didn't exactly know how our discussions would go, but like always, in sort of the magic of the OPMAN meeting, it sort of all comes together in a way that's kind of cool at the end of the day. So thank all of you for hanging with us for this. Thanks for the lively discussion from the panel. And we got workshops. The workshops, thank you. The workshops will be, you're going to get a post-conference CME. Please fill those out. The long-term outcomes you'll get in a couple of months about what we talked about. A reminder that these the videos and the presentations will be archived. You can access them on the PracticePoint.cme.com website. Thanks again to our commercial supporters. And then for the virtual attendees, this is it for the day for you, but thank you for joining in. Hopefully you'll be with us tomorrow for the hepatitis and the liver trouble day. And our meetings, we're going to be talking about PrEP with prevention, and we're going to talk about challenging cases and emerging advances. So find your rooms upstairs. Hopefully those departments of government still exist, and we'll close out this session. Thank you very much.